the basic, the anatomy, the dynamic, static imaging, updates, and non-pituitary as well. So the focus is of course pituitary and cellular. What we find, it is pituitary mainly. So let's start with sagittal is your meaningful plane of imaging for midline structure like pineal and more importantly pituitary gland. And we always start with T1 imaging, non-contrast, at least 3 millimeter images. Still you will have high amounts to signal because of the resolution of the images, but still it works. And at least 3 millimeter imaging, the first thing you see anterior pituitary, second chiasm, third is hypothalamus, fourth is infundibulum, and the bright structure behind the anterior pituitary, of course, posterior pituitary hyperintensity. The reason is it has lipogranules and they don't even get fat suppressed. And when we inject the patient, this pituitary and infundibulum has to enhance because it does not have blood-brain barrier. And also need to remember that posterior pituitary hyperintensity can be absent in 20% absent in diabetes insipidus. That's where we have to look for it. So anterior pituitary is enhancing as well as the infundibulum as expected. And the next meaningful plane in pituitary imaging is of course coronal and T1 imaging, and we will see the same structure, but ideally they are suited to two structures, the chiasm and the cavernous sinus. As you see chiasm here, anterior pituitary, and when we inject the patient, so you need to inject to look at the cavernous sinus, particularly when you have an adenoma to determine its involvement. So here is your cavernous sinus, and as I said, at least 3 millimeter imaging is required. So I don't know why it's showing like this. So 10 millimeter is our cutoff, more than 10 millimeter is a macroadenoma, and more than 4 centimeter generally called giant adenoma. There is a subtype of invasive or aggressive adenoma. This is the 5 subtypes based on immunohistochemistry and molecular imaging that they would behave aggressively. So these are the 5 types, particularly the one purely hormonal, and it would be manifested on imaging as well. I'll show you example. As you see in the picture, this was actually incidental macroadenoma. Macro because it is 12 millimeter. Lower graph tells you that there is a spectrum of functionality of adenomas. There can be null cell adenoma and move up to functioning adenomas. Some people believe that there is no such thing as null cell adenoma. All the adenomas have potential to secrete something, and this is based on transcription factor negativity. So it's about 5%, but it is important for me as a radiologist because those adenomas which are not functioning, we will find them for you. These will be incidental adenomas, and that's why these are incidentalomas. So starting now, pituitary microadenoma. Let's go over what are the imaging features of microadenoma, right? And you have to inject contrast for microadenoma in most of the cases, and the reason is that we want to see a non-enhancing focus. And for this detection of these microadenomas, you need good high resolution images with good signal to noise ratio. So you see a non-enhancing focus. What else you see is slight deviation of the infundibulum, and there will be some asymmetry of the gland. These are the 3 features you have to look for microadenoma. And if you want to hit the microadenoma at the right time, it's better to scan the patient at about 40 seconds. If you do dynamic imaging, then you will hit it anyway. And despite all this, we may miss some microadenomas. Here what you see is the adenoma sitting at the floor of the cell, and this is quite characteristic for growth hormone adenomas, that they will be sitting at the floor of the cell. And here, sometimes we say, well, T2 imaging is useless, but here you see cornea up here on the contrast, it was very difficult to see. So they always complement each other, so they are meaningful images. And ACTH adenomas can still be elusive, and we have to really struggle sometimes to find them, and they will be clinically very, very significant for the patient. So, in terms of detection of microadenomas, and in my experience, actually, a lot of patients with prolactin high level, for some reason, I don't see a lot of these adenomas, microadenomas. I don't know whether it's a local problem or a technical problem, and the endocrinologist will get upset that we are not seeing these microadenomas. So this is a challenge that we don't want a negative pituitary imaging if the clinical suspicion is very high. So you should better use a high field MRI, 3D MRI, then dynamic MRI is another tool. Plus, you can use the GRE techniques, 3D GRE technique, which increase your sensitivity. And lately, people are trying flare imaging post-contrast, which a lot of people are not using it. So it can increase your sensitivity. I'll show you a slide. And if nothing works, then we have to revert to invasive procedure, which is inferior petrosal sinus sampling. But it will only show you the confirmed adenoma. It shows the site, but still, the surgeon will say, where is the adenoma? We will not be able to tell you that. So this is a dynamic imaging. What we do in dynamic imaging, usually it's coronal acquisition, and you inject the patient. While you inject it, you keep scanning the patient again, you generate. There is nothing in pituitary, but as you move on, there is contrast enhancement, and that's what we have to capitalize on. And why we see these microadenomas, as you see this, these are tiny because they are tiny, right? So you have to really squint, and that's why they are too blurry. And here it is. Why we see microadenoma? The yellow curve is normal gland. It enhances ahead of the pituitary adenoma, and this gap we capitalize on. That's why we have to hit at the right time to pick these microadenomas. So this is a nice study somebody did, and you can see the top row of images that there is low early enhancement of adenoma as well as low delayed enhancement. That's exactly what I want. I don't want the adenomas to enhance early. I want the pituitary to enhance, so there is a difference, and I can pick up the adenomas. Although this is a big adenoma, but in microadenoma, that's exactly what I want. I want a contrast. We are living on the contrast. Radiology is living on the contrast between the structures. And lower down, you see the whole adenoma is enhancing. Where is imaging? This is from the article, and you see the T2 and contrast study was negative, but here you see we picked it up on the coronal flare imaging. So if your imaging is negative and is a meaningful patient, you can try flare imaging as well. This was actually a negative Cushing disease patient, and then that's where the flare imaging came to the rescue and helped the patient. So we always forget about T2 and other imaging sequences. We always focus on T1 imaging, but T2 imaging can be quite helpful as well. This is just normal structure you can see on T2. But what is the utility? The utility is try to adapt cis sequence, fiesta sequence. This is a very high resolution T2 imaging, and inject the patient post-contrast imaging. Remember, on T1 contrast look bright, but on T2 contrast has to look dark. So this dark is actually contrast enhancement. So there is homogeneous enhancement. I can tell Dr. Asha that you are going to find a very firm adenoma, because this is a marker of collagen dominant adenoma. But if it is heterogeneous, then I can say that it's going to be cellular dominant adenoma. On the same token, I can use diffusion imaging, which we use in brain tumors. If it shows restriction, as you can see very bright, this is restrictive, it is full of cells, so it's going to be soft adenoma. But if it is facilitated, as you see here, dark or no diffusion hyperintensity, this is going to be a firm adenoma, so at least the surgeon is alerted what he is getting into. So we always talk about MRI, and the poor CT, we forget about CT. Actually, CT has a significant role. Even Dr. Khalid would appreciate that. Its planning purposes, it has a role. And what is the role of CT? So many macroadenomas, I do business. I find that on CT, and patients come for headaches and use the symptoms. Asha would like to know where is the carotid, how thick is the bone, this and that. And body changes, calcification and hemorrhage is the forte of CT. We rely on CT, then MR on these. As you see, a large adenoma, lytic lesion destroying the bone, CT give you a much better perspective. And here we go. There is a large calcified adenoma, a long-standing stone there. And here we have a hemorrhagic apoplexy case, right? So CT has a value. This one you can see is a post-op changes too. And it can be an alternative diagnostic option if your MRI is not possible or not available or contraindicated. So at least I can diagnose macroadenomas on CT. So CT has a value, don't forget about it. And here, cavernous sinus invasion, large adenoma. And as I mentioned to you, pre-operative planning purposes. So the surgeon wants to know how thick is the bone. You look at the sphenoid sinus, very small sphenoid sinus, he has to cut a lot of bone there. But if I tell him, well, sphenoid sinus is too big, pre-cellar, and then cellar and post-cellar, this is more favorable. He just has to enter the sphenoid sinus and the floor of the cellar is so thin, so he can enter it easily. So all these variations are very important. Look at the planar process pneumatization, and you can see the arrows pointing to the optic nerve and laterally to the carotid artery. The surgeon has to know where is the carotid artery. You know what the complication of carotid artery rupture in transternal surgery. We all know that can be horrible. So the surgeon wants to be very safe. It is bulging into the sphenoid sinus here, the carotid arteries, and here is the almost kissing carotid arteries. The surgeon wants to know these things. It is very important. And here is a very interesting study after the surgery. They say how big is the defect at the floor of the cellar. And you see the bigger the defect is simplistic. The surgeon was very good and he made a big hole and there is a less chance of recurrence. So it's simplistic, although we want to have a small kind of defects. Now we covered microadenoma and some technical aspect. Let's move on to macroadenoma. And macroadenoma, as I say, they are looking at you. You don't have to try to look for them. They are so obvious, right? And what are the features? If you have a central skull-based mass, most likely it will be adenoma. But what are the features? If you cannot see the anterior pituitary separately, if the cellar mass has cavernous sinus involvement, if the mass is encasing IC but not constricting, if it is constricting, most likely it will be meningioma, or there is a large cellar component, you are thinking of pituitary macroadenoma, right? As we see here, very obvious large cellar, supracellular mass with IC encasement. So we have these two examples. You can see the pituitary separately. In the first one, you can see this was a large cavernoma. This was a case from King Faisal, Riyadh. Then this is also from the same hospital. You can see the pituitary is intact, so you have a large glioma, which we see quite commonly as well. So separate pituitary, less likely to be adenoma. What are the two major typical features you look for and assess on imaging? We already can easily say this is an adenoma. Cavernous sinus invasion. So that is something we have to understand. It predicts post-op residual tumor because surgeons want to stay away from it, and high hierarchical output for obvious reason, and extracellular extension or cavernous sinus extension predict non-remission and recurrence. We all know that. But the real question is, we have inter-observer and intra-observer variation, whether cavernous sinus is really invaded or it is just a pushing or dural deflection. For that, we have the famous knobs grading. And I have a more simplistic approach, the approach of C's. As you can see, divide the cavernous sinus into compartments, into carotid lines and carotid encasement, almost on the same line of knobs grading. As you see here, the 5 compartment, the lateral, the inferior compartment as involved, the tumor has traversed the cavernous sinus, most likely it is invaded rather than pushed. And if there is carotid encasement more than 67 or more than 70 degrees, most likely it is sitting in the cavernous sinus and the surgeon would find it on surgery as well. And if the carotid line, if you draw the lines and if the more lateral it reaches, it means there is cavernous sinus invasion rather than just dural deflection. And it is on the same line as knobs grading. The first applies to 1 to 3, and when there is encasement, we On that side, you see, this is just medial encroachment, so we can preoperatively say confidently that there is just encroachment, most likely the neurosurgeon will be able to remove it. But in this case, the other patient, you see, it is in the inferior compartment reaching the lateral wall, there is going to be invasion, high probability, and that was proven. So this is in summary the cavernous sinus involvement, how to assess objectively. The second C, which is important in macroadenoma, is charismatic compression. Usually it's obvious, we don't grade it or objectivize it. We can see it very clearly. As you can see, the cavernous sinus, the chiasm is compressed by large adenoma, and visual impairment up to 70%. There may be debate about that. And here you see thinning out of the optic chiasm. Contrast study again, the same finding you see. Large tumor size, increasing size of adenoma, it predicts post-op poor improvement. So there is significant compression. And these are some T2 images, and you can see a thin line of chiasm left, and you can imagine how much deficit the patient will have. Again, the same 8-figure sign and a large chiasmatic adenoma with chiasmatic compression. So, when an entity is common, we see a lot of them. When you see a lot of them, so they would be typical, but you would have a collection of atypical statistically, right? So adenoma, we see so many. I have a collection of typical, but I have a collection of a lot of atypical. So the tumor grows, they will develop cystic and necrotic changes. You will see a lot of solid and cystic tumors. This is a mixed solid and cystic tumor. This is, you see the T2 star imaging, this is for blood. So this is apoplexy on MRI. And then here we see the run amok, the crazy adenoma, which remember the 5-band adenomas, as I showed you before. So they would behave like this. And then this is a Cleveland Clinic case at Abu Dhabi. And this was probably a Rakesh clepsis, but this was a large unicystic pituitary adenoma. So these are just different appearances of adenomas. So this is a large sitting in the sphenoid sinus, and it was actually just necrotic adenoma on surgery. And we thought this may be craniopharyngioma because they typically are very bright. Adenoma was mimicking. So adenoma can mimic, and adenoma can be mimicked. Right? So we've covered the adenomas. Now moving on to the empty sella, partial empty sella. I think we are good on time, right? So we have few slides left. So it's a very common incidental finding, as you all can appreciate, and usually older patients, typically female patients. And you can see there will be a lot of flow artifact, don't call them aneurysms or lesions. And you can see it is more rapid in young patients, and it is a consistent finding in idiopathic intracranial hypertension, and if the patient has previous insult, including radiation. So you would see empty sella or partial empty sella. Endocrine dysfunction about 20%, but more common in pediatric patient, for example, pituitary stalk interruption syndrome, and you can see the ectopic pituitary hyperintensity posterior sitting at the infundibulum and hypothalamus. And here is previous surgery and post-radiation, a complex looking empty sella or partial empty sella. So, what is the role of MR in terms of predicting whether it's a secretory or it's a moot point? You will know that clinically, but still we can do that for you. And about 60% are non-functioning. Hyperintensity of T2 means there's going to be secretory granules in it, and it predicts that it will be secretory. And it can even predict the response to the agents you use for these patients. And growth hormone adenomas less often supracellular, as I alluded to before. And prolactin level also is a predictor. If they are, for example, above 1000, I can say, well, most likely will end up with cavernous sinus involvement. This was a small adenoma in a syndrome, prolactinoma, here cavernous sinus involvement, ACTH adenoma. If we find them, that's a very good sign. It will predict remission. So now there are three red herrings I want to point out, and these are very, very important from practical point of view. And The first one is normal variation. Remember, pituitary gland, as we do magnified imaging, there will be heterogeneity, and you must have seen radiologists calling microadenomas, which are actually called pixel adenomas. We can be all over the board. There is a punctate signal there in bright signal, and you can make some adenomas here, and here I can make one adenoma. So you have to be very careful looking. The second red herring is pituitary hyperplasia, and pituitary adenoma is a mimicker of pituitary adenoma. And what happens is physiologic or pathologic hyperplasia we are all familiar with, and they can get up to even 15 to 20 millimeter, even can cause optic chiasm compression, and particularly pregnant patients and all familiar with particular hypothyroid patient, they can come with pituitary hyperplasia. And what we need to look at homogeneous signal. Homogeneous features of hyperplasia, and we should be familiar with. Few minutes. So posterior pituitary hyperintensity is usually present in this patient, unlike microadenoma, macroadenoma. This is very important lesion or entity we have to be familiar with. These are 8 different patients. Every few weeks I see one, and their report says pituitary apoplexy, pituitary adenoma, this and that. And you can see here in the stellar suprasellar region, these are hyperdense lesions, and everybody get alerted that there is blood, right? These are not blood. This is a normal variation, is a congenital finding, and it will create a lot of undue concern, and people are getting admitted for this, and this is nothing but Rathke's cleft cyst, right? You will see them so frequently, Rathke's cleft cyst. And this is a good cousin, the bad cousin is craniopharyngioma. They can be stellar, suprasellar, and suprasellar, the 3 types. And more common is the intrasellar, most common incidentaloma, at least in my experience, and they can be symptomatic. Midline location is the key. They should not have fluid levels and septations. So these are different versions of Rathke's cleft cyst. You see the tiny dot there behind the enhancing pituitary, and it can be very bright. I see stellar, suprasellar, and then this dark signal is proteinaceous secretions, and look for a dark P2 neuron nodule. That is a sign qua non and pathognomonic of Rathke's cleft cyst, as you see here within the cyst. And then the whole dark thing is a neuron nodule within a cyst, and it was moving. It's a massive one I borrowed from a book, and this. So these are just the bonanza of Rathke's cleft cyst. This is an entity. So sorry, I will take a few minutes more because I have few slides. So this is a entity we had in SKMC, and T1 bright we call craniopharyngioma, probably or hemorrhagic adenoma, and there was little enhancement. So this is an entity I'm talking about is hypophysitis. Hypophysitis are 3 types, usually is perinatal, we all familiar with, and there's some medication can cause this, but lymphocytic is the most common one. But if you see dark signal in the stellar paracellular region, then think of an entity called IgG-related hypophysitis, which is less familiar, and now we should know about it. And it is steroid responsive older patients, and endocrine dysfunction is common. So you can see diffuse enhancement, even dural enhancement. So this entity is actually turned out to be xanthogranulomatosis hypophysitis, the case I showed you. Just quickly, just pass through it. So this is something we have to be aware of. This is craniopharyngioma, and it is an entity we should be aware of in the 2021 brain tumor classification. They are adamantinomatous, and they have a rule of C, calcification, cyst formation, and enhancement, as you see here. And they are very usually bright on T1 and non-propagated tumor. The surgeon tell me usually they come up quite easily, these cystic lesions. And you can see the calcification and some enhancement. And the second type is actually, so these are the cystic component, and papillary is the one which is more common in adult, and they are usually solid. And they have actually genetic correlation, the beta-catenin and BRAF B600. So this is our second last slide. Pituitary star or hypothalamic lesions. I am grouping them together because they look very similar, right? So what you see is This is the only exception that hematoma will not enhance, but the rest of them, metastasis, lymphoma, granulomatous diseases, as well as germinoma, they all will enhance, they will look very similar, and not to forget, the third category of primary tumors beyond cranioperineuma and adenoma is the pituitarycytomas from CNS origin. They can also enhance supracellular region, including spindle cell, oncocytoma, and granular cell tumors. So with this, I end up. This is a trivial question for you and for Dr. Asha as well. That this is a picture and this is the second picture. What is the difference between these two pictures? Look at the MRI, it has moved towards on the patient table, right? This is an intra-op MRI, and this is the standard of care in high-level hospital now. And the this must be on the wish list of a neurosurgeon because it really helps in post-dissection and intra-op imaging for the patient during surgery. Thank you very much.
Any question for Mansoor before we leave? If you have any questions?
No, I have to say.
Thank you very much.
Okay.
Cushing disease where we get them, what's the role of functioning image?
Functioning imaging. What do you mean by functioning imaging?
PET scan.
Oh, those molecular imaging, right? Because in we mean MRI functioning imaging, right? So yes, actually we can use those, and there are some agents which can be utilized. I think CCAD has some tracers coming right now. It depends if you have the tracers, like specific tracers. So I have read some papers that you can use PET scanning, right, if you are lucky. Otherwise, you have to go to petroscience center. But the whole issue is the availability of tracers.
One question? No? Yes. Yes.
So the end stage series.
We want to get rid of the ITS because of the concept imaging using C, 11, compressive and 3D imaging. So you can reconstruct to find out very tiny invasive.
Right? Yeah, you see that inferior petroscience sampling is the last resort. When you exhaust all your techniques, the more, as I showed you, I showed you the paper, they specifically picked on Cushing patient, negative MRI, everything, and they use a flare technique, right? So we have to be familiar with the new techniques, even in MRI. So I'm sure nobody is doing flare technique, right? So we should give it a try. We should try all our non-invasive options, and then we should go to the techniques, even including the vaccine, if it is available. That's the key.
Thank you very much.
Thank you very much. Thank you very much, Mr. Mansoor. Thank you. Actually, we will share the next meeting.
Salam alaikum. Our next speaker is Dr. Muhammad Asha. Muhammad Asha is a consultant neurosurgeon. He is British trained and he is having 3 fellowships from UK, Canada, and from France. He is the head of neurosurgery at Awam Hospital, and he is the chair of the skull-based committee of the Arab Board Specialization Committee. Dr. Muhammad Asha is going to talk to us about the advances in neurosurgery and pituitary surgery. Welcome, Dr.
Thank you very much.
Good morning, everyone. Thank you, Khalid, and thank you for the organizing committee for having me here. And so in the UK, the surgeon has the title of Mr. the physician's doctor. And the reason is surgeons historically didn't know much medicine and probably don't do until now. So you are the smarter ones. I'm not going to teach you anything new you don't know. I just will share with you new surgical perspectives. Dr. Khalid is experimenting with me with this new mic. So the idea is he asked me to present about new insights, new updates in surgery. And really what has changed in surgery of pituitary adenoma recently is not the main concepts, it's the perspective understanding of what we can treat, how we treat it, and how we can be maximally aggressive but very safe at the same time. This is how the pituitary surgery was depicted historically through the nose with rhinotomy, big invasive procedure. This is how we are thinking about it now, and this is what we call transsphenoidal. But really that's the door opening of endoscopic skull base surgery. And this is a very small procedure compared to all the full spectrum of endoscopic procedures we do for the full pathology of the skull base. These are very complex, minimally invasive, but very effective procedures. And when we talk about pituitary, this is primarily an extradural lesion protected by the diaphragma cilia from the intracranial part. So when patients get complication after pituitary adenoma, some people frown and say, got this from a pituitary surgery. Well, it depends on where is the pituitary tumor, and it might carry a significant morbidity with it. This is the background that you're all familiar with, and various histological grading of pituitary adenomas. The way that we think about them has changed, and nowadays we are more interested in the laser pointer. Okay, so at the bottom you see there are molecular markers, and I will come to this in one separate slide here. The way that we're thinking about pituitary adenomas has changed, and we have better understanding with all the genetics and epigenetics of the adenomas now, and we know that familial adenomas are a small entity, most of them are sporadic, and the mutation itself carries a significance. So if we have P53, I know this is going to be a large invasive adenoma, and I know that there is a small residue. This patient most likely is going to come back with recurrence, and most likely he will need further treatment. So with the clinical presentation, it depends pretty much on whether it's functional or not, how big it is, and which part of the adjacent structures it's pressing. Dr. Mansour did a beautiful job talking to you about different classification. This is Hardy classification, and we use it to give a representation of how invasive the adenoma or not. And most adenomas that we actually operate on are probably, at least in my experience, the tertiary referral center, are category D and E. These are paracellular adenomas, and I'm going to share with you some examples like this. I would like to spend the next few minutes talking to you about the visual field and optic pathway affection in adenomas. And this is very important because we have lots of patients we live with incidentalomas, and we say we are following with visual fields. And we're probably using the wrong tool if we don't fully understand how it works and how the pathophysiology of the optic pathway. This is a very old paper about optic chiasm affection in adenomas, and we see the classical picture that we are seeing is the bitemporal hemianopias. This is not the most common. It starts with scotomas. It starts with a patchy, non-uniform affection, and usually superior quadrantenopia. Why? Because the adenoma is coming from the bottom, it's growing. The optic pathway decussate, nasal fibers decussate, and also they have vertical arrangement, so upside down. So if you're pressing the medial inferior, you're affecting superior lateral. That's quadrantenopia, but it's not that simple. Now, when we look at how the optic chiasm is affected, if something is growing from the bottom, you expect everything at the roof to get the same pressure. That's not true. There are some cadaveric experiments where we put a very micro small catheters inside the optic pathway, and then using a Foley's catheter in intact cella, we inflated the Foley's catheter or the balloon and measured the gradient of pressure, and we found the most medial fibers to have differentially much higher pressure than the lateral. It's the apex of the sphere. So when we talk about that, we see patients with large adenomas have different visual field deficit to one maybe with a medium size. And the reason is we have to think about the position of the chiasm. You might have read in one of the radiology reports, nice ones from Dr. Mansour. He's talking about prefixed, post-fixed optic chiasm. So what we mean by that is really the relationship of the optic chiasm to the posterior clinoid. And if it is too anterior, like the first one there, we call them prefixed. In which case, a pituitary adenoma growing will not compress the optic chiasm, will not give you bitemporal myopia until very, very late. It will give you optic radiation, a homonymous visual field deficit. And different from post-fixed, where a growth of pituitary adenoma will not give you bitemporal hemianopia or homonymous, like right homonymous hemianopia or left homonymous hemianopia. It will give you monoocular, one eye, complete blindness if it's that big. So, and you see sometimes that people are saying, oh, this cannot be from the pituitary gland, he's got glaucoma, he's got retinal disease, and it is incidental only. So, I will not spend more time because I think you get the gist of it, but these are the different patterns, and this one here is from a post-fixed optic chiasm. Because one eye is affected, the other eye starts to be affected when it's too late already. So ocular coherence tomography, it's a very useful tool. It's essential clinical tool. Now if you send your patient to a good ophthalmologist, they will always give you that. And what it's looking at is the thickness of the retinal fibers. And that sphere is spread into a line. So you see it there, and you get the curve showing you the thinning of the different fibers. And we have to remember that you get lots of fiber loss which is still silent, so you do not have necessarily clinical symptoms until it's a little bit late. So using OCT is an early predictive tool. It actually gives you an idea if the thickness of the fiber is more than 80 micron, you still have a chance of regaining good and useful vision. There's another interesting fact. So what happens with the hormones with these non-functioning adenomas? Why do we see many of non-functioning adenomas with disturbed hormones, with a secondary hypothyroidism or secondary hypoadrenalism? How do they affect it? They are not that big. And there are lots of theories here. One of them is the intracellular pressure, the other one is the microvascular compromise that's happening. So it does affect the function of the normal gland, even if it's small. And in fact, there's a theory, if it's a small adenoma, the cell has not expanded, so any growth will exponentially increase the pressure, unlike macroadenoma. Now, when we talk about the surgical perspective, and this is really where the real surgical part starts, is I think the question you ask is, who needs surgery? Especially when we talk about incidentalomas and nowadays prolactinomas. And the second one is, what are the surgical challenges and limitations? Dr. Mansour presented a lot about cavernous sinus invasion, and you hear this as the usual excuse for not achieving biochemical cure after surgery, that there was cavernous sinus invasion, so I couldn't do much. And what really a center of excellence would offer more than a regular pituitary surgeon. And finally, where we are heading with the invasive, aggressive, recurrent adenomas. So now I don't think that we need to debate about the role of surgery for functional adenomas. I think everyone agrees they are largely recommended as the first line of treatment. We have to have a look at non-functioning adenomas and prolactinomas. And to understand what we do with incidentalomas, we have to look at the natural history. I worked with Nikki Kravahaki from Birmingham. She's very enthusiastic pituitary endocrinologist, too enthusiastic in fact. And here she looked along with some of her colleagues to the micro non-functioning adenomas generally. The percentage of growth is about 7% if you follow them for 3 years. That was 5 years. The question is, if you get a microadenoma, you label it as ascendant adenoma. How many of us would follow this patient 5 years? Can you see show of hands? If you done a scan for any reason, you found non-functioning microadenoma, 3 millimeters. Would you follow the patient for 5 years? Probably not. And these patients really have to be referred to surgeons. They have to be seen by a surgeon at least once and put on the radar. Because we know that about 50% of them, those 15% who grew, will eventually become macroadenoma. Well, not only this, they will develop endocrinopathies. They will start losing hormones, and you say, well, I wonder why the thyroid function is gone, the adrenal function is gone over the years, and does not explain microadenoma to it. As I said, the intracellular pressure, the portal circulation changes, does explain that. Now with macroadenoma, it's completely different. Even the innocent macroadenoma, we have about 11% of them, 10%, and that's 1 in 10, not a small percentage, require surgery. And when we say that they require surgery, some of them actually came late because they were labeled as incidentalomas and not put on the radar for surveillance. So what's written red is very important. When we follow the patients, we say at least 6 monthly scan, 6 monthly visual field, etc. We have to understand that if you've got something showing on OCT or visual field for more than 4 months, it is almost guaranteed to be irreversible. So we're losing some of these patients if we are a little bit too complacent following them up. And OCT is generally very sensitive, but is not 100% sensitive and specific. So you may get abnormalities in OCT which are basically silent or not shown in visual field. Now what does the Congress of Neurosurgeons think about this? Well, basically the recommendation is symptomatic non-functioning adenoma, incidentaloma, or growing should be referred for surgery. When we say symptomatic, we even include these endocrinopathies, patients who have unexplained low TSH or ACTH, etc. So this is considered endemic. But all of these should be followed in a joint clinic that does have a surgeon. So with something like this, it's no-brainer. You don't need to think much about this one. It's already touching the optic chiasm, it's causing mass effect. You do the visual field and you find that it is not too bad. Well, this is the window to discuss surgery with the patient. If you wait until there is visual field deficit, you know that that is probably getting into the irreversible stage. Now, hormonal follow-up, as I said, that what you see on the left-hand side might be controversial for some, but there is now a suggestion that if you operate early on some of these silent adenomas, you may preserve and prevent the progression of loss of anterior pituitary function. So, prolactinomas, it was considered at some point to be a crime for a surgeon to operate on prolactinoma because they can be treated by a pill and it's readily available, etc. The tide is reversing, and now the International Pituitary Congress or Society is giving a strong, when they label the recommendation, they put the first one as a strong recommendation that surgery should be considered as first line of treatment for all microprolactinomas and for some macroprolactinomas if they are not grade 0 or 1, which means if they are not already inside the cavernous sinus, because you can achieve a complete remission cure, so 80 to 90 the first 3 years, and beyond that it's more than 65 to 75% beyond 5 years. We live in an insurance-based system. These are expensive medications, there is morbidity, there is cardiovascular risk, psychiatric side effects, patients would like to become pregnant, etc. So there is a compelling case for prolactinomas to be sent for surgeries early. And there is actually a meta-analysis about starting carbamazepine and dopamine agonist, what it changes the consistency of these adenomas and how it will make life difficult for the surgeon as well as the patient and reduce the chance of success. And perhaps some of the historical failures of surgery in prolactinomas were based on the fact they were always referred after having been for a long time on medication. So what other strong recommendation from this international consensus statement is only in the very invasive adenomas, medical treatment should be the first line of therapy. So I don't see many endocrinologists sending prolactinomas for surgery. In fact, actually the only ones sent are the very invasive big ones, and usually surgery has more of palliative effect on these. So these are special categories that we've spoken about: pregnancy, young age, etc., or CSF lead after prolactinomas. This is for patients who already started on medication. So now we're talking about the cervical challenge, and we said cavernous sinus is the main one of them. So as things have changed with the philosophy of surgery, also the technique have changed a lot. So many of what you see here is no longer inaccessible to us, it's no longer a red line and we stop there. We're actually pushing the boundaries, and you will see cases where we can achieve a gross-total resection even with the most invasive adenomas and give a good result for the patient. Dr. Khalid asked me not to present too many videos this morning and you guys squeamish from blood, so I kept it for a few. He said one, I couldn't resist, so I did more than one. But I'm going to just give you an idea. What do you mean by endoscopic transfenoidal? You see the picture of this patient, and now we're going through the nose, and surgeons, I think I've seen ENT, Dr. Ammar is there. We hate the middle terminus, we always take it out. And now this is a revolutionary thing with this skull-based surgery, is nasoseptal vascularized flap. You see that we peeled it off, we took it from the septum down, it's vascularized, so we use it to repair CSF leak, and it's very, very effective. And I personally raise two flaps, one on each side, we do small septectomy. Now what you're looking at, that heel, the bony ridge, that's where the sphenoid sinus is. And now we are opening the anatomical ostium of the sphenoid sinus. We take the face of the bone of that sinus. This is all the standard simple case. And we are drilling just to have a flush, smooth surface. And then what you see here is a soft adenoma. And this is what we like to see, soft, suckable adenoma. And we feel very secure because that kind of adenoma you can, as you can see, you can take it out with suction. And this is the diaphragm cell. This is the arachnoid membrane bulging, and you can see it's actually like onion skin, so thin, very easy to get tear there and CSF leak. So really CSF leak is not a sort of a very unimaginable complication of it, and now this is being reconstructed with some artificial, but this is the most important thing. This is the mucosa flap sitting there, and that's a game changer because previously we avoided like hell to open the arachnoid, to go intradural. Now we feel quite brave if we have a good nasoseptal flap to do that, which makes us chase these ones, right? A monstrous adenoma is all the way there, ventricle almost going to the foramen of Monroe. There's no doubt that both cavernous sinuses are involved here. Dr. Nazir is approving. Yes? Good. So the idea now is I will just go through this very quickly. Now you can imagine we've done all these steps, all the bony work has been done, but now we're doing something extra. This is called tuberculum cell, where we're doing. It's the junction between the sphenoid and the anterior skull base. So we're taking more bone and almost the planum because we want to have a vertical trajectory to the third ventricle. And now here we are planning from the beginning, we're going to go intradural, we're going to go inside the ventricle as well. So this is a brain surgery, not a sinus surgery anymore. And you can see what we are coagulating something called intercavernous sinus. It's the connection between the two cavernous sinuses anteriorly at the tuberculum, which now is going to be cut, and that will give us a window to the suprasellar compartment. And here we cut it. So it's not a suck surgery anymore, it's a much more complex, and you can see now these bits of adenoma are being dissected down, and I will not discuss too much more. So now we are anterior to the adenoma, we are looking into the third ventricle, and you can see I'm using the Doppler because now I'm going to cut the wall of the cavernous sinus to make sure that there is no carotid artery in there, and that one thing was the micro-Doppler. And now we are coagulating the attachment of the cavernous sinus. We're going to cut it in a minute. We'll do the same with the right and left. So now I have separated the part that's in the cavernous sinus, both sides. Really hope no one is going to feel disgusted by the end of this. You all had your breakfast. So we cut now the other side, and that has given us some freedom to mobilize, and you can see how fibrous this is. This is not really a simple adenoma, and now it's a matter of rolling it from up to down, and it will come gradual. Obviously, we do not just grab and pull because that will cause lots of injuries, and then we miss the part where it's coming out, but this is where it's coming out through the nose, and you see how huge it is. Here we go. So, and the rest of the video, and that is the view that you almost never see with pituitary surgery. We are inside the third ventricle, and this is the two foramen of Monroe. So, and I think once we remove that particular piece of cotton, we see the cerebral aqueduct, and you can see the third ventricle. I have it, cerebral aqueduct. So we're pushing the saline through it to wash any blood clot, and it's coming out from the other side. So we have become braver, more skilled, and we're now able to chase some of the more untreatable adenomas. This guy is a Cushingoid patient, and he had this one, and the difficulty, I think the radiologist is very smart, they give you a transfemoidal adenoma outline, above which you cannot get this through a transfemoidal surgery. So I should have listened to them and changed my technique from the beginning, but I thought I can get this one through a standard transfemoidal surgery, so went through it, and immediately after surgery scanned the patient. I was very disappointed, I think Khalid remembers this case, to find there is a nodule still here. And basically this nodule was in a blind spot. It's within the third ventricle, and when I looked, I saw the optic chiasm, the white structure, didn't see anything around it, and that's what's in the middle vertically is the pituitary stalk. So we convinced the patient for a second one, and we went after it. It was a quick surgery because we knew that I need to go in a much more different angle. Obviously neuronavigation is there, but that's never accurate 100%. And we were able to get it. I will skip the video maybe of this one. And this is the outcome of this patient before and after surgery from visual field. And this is his cortisol. And now he's 14 months down the line and following remotely, and he is still on replacement. So with paracellular, like this one, it's another different category of tumors, and here we are talking about completely different surgical approaches using different techniques to go inside the cavernous sinus like this, and we talk about something called oculomotor triangle, where basically we are through the cavernous sinus between the third and the inferior hypophyseal artery. That is the idea, and this is what we can achieve. We can chase all of that out. And this is very interesting, probably one of the very last slides. This guy was referred as an functioning adenoma, and on the images it looks a little bit bizarre, very strong homogeneous, so I knew it's going to be firm, but I'm still thinking it's adenoma. Inside surgery it looks more like a meningioma. Then the histology came to say it was gonadotroph adenoma. And I really made them repeat it twice because I could not believe it was not an adenoma. And just to show you very briefly how bizarre this case was, it was completely separate from the pituitary gland. The stalk, the gland was completely intact, it was completely ectopic. I cannot still understand the origin, whether it's actually part of the stalk, but small pedicle or not. And it was very tough. So here, when we open, this is what we see. The orange color always points to the normal gland, so it's always in orange color. It's always fibrous and firm. But the part of the top where I'm burning now, usually if it's adenoma, if I open it should be like toothpaste and easily suckable, but this one was so hard. So I decided now this needs a more expansive endoscopic approach with drilling more anterior in the skull base to go to the suprasellar compartment. And here we remove the flanum, which is that piece of bone in the anterior skull base. And just to show you how fascinating this was, now, so it's completely separate from the gland. The gland is below. The white tough tissue, I'm using ultrasonic aspirator now to dissolve and cut it, is the tumor. And if we lift it up, if you look at the bottom where we lift it up, we will see the stalk intact, and at the end we see even the optic apparatus is there. So you never stop learning about these fascinating tumors. Now, that's what I said, it's completely separate from the gland. I even could insert a cottonoid to give me a plane. Everything at top is the tumor, completely suprasellar, not attached to the gland, very firm. And this is my first gonadotroph adenoma. Really, I have not seen And this is at the end of the procedure. You see the optic chiasm, you see the pituitary stalk, which is still intact. This patient pituitary function after surgery was pristine. I've sent it twice to Mayo Clinic to check if this was not a meningioma, and they were 100% confident. The pituitary stalk is the redundant red thing going down. So it's all very fascinating. The last case is this guy who was referred with a very invasive adenoma, completely blind, but only for about a week. As you can see, complete encasement of the optic nerve. Very far lateral. There's a rule in endoscopic: if it's crossing the mid-pupillary line, you cannot chase it. But sometimes we are lucky if the tumor is soft like this one, and we could suck it. You see now the optic nerve in the middle picture completely free. And top row before surgery, bottom row after surgery. You can see that it's almost completely clear. There are some on the top right and the far right picture, some small residue. And he had an excellent result. You cannot do these operations without a multidisciplinary team. So in fact, for this one, we did a carotid occlusion test. We took him a few days before with Dr. Jamal, our interventional radiologist, and we put a balloon inside this carotid artery. That picture in the center that you see with the neurophysiologist study, you see how this affects the somatosensory potential of the brain, and the patient semi-awake, so we can often do during surgery. And theory was, the worst case scenario, I'm working in the science, I enter the carotid artery, can we sacrifice that carotid artery or not? It was lucky that this patient tolerated the balloon occlusion test, so we knew that we could, but we did not need to do so. In fact, his carotid artery was intact. This is the patient, visual field within 2 weeks. And this is the patient himself, who was completely blind in that eye. So for the last few weeks, this patient could not see at all. He was very joyful in the fact that he was able to see again in that eye. Still, it's not great vision, but he's got some vision in that eye. And just the concept of the cavernous sinus surgery. Why we are so aggressive? Because we can achieve cure in some of these patients. And in this particular patient was done very recently, I think only 2 weeks ago. She was acromegalic, and we knew there is cavernous sinus invasion. And just to show you, sorry, this is come in the wrong place. The steps that what we have done is basically, I will skip to the last end because that's where we need. So now we are in the cavernous sinus, and the structure in the back is the carotid artery. You will see it clearer, and that's the carotid artery. So we resected the wall of the cavernous sinus, and it's red because it's blood from the cavernous sinus coming out all the time. And here it is. So now the top corner is the area above the horizontal carotid, that where the tumor was filling. The green line denotes the internal carotid artery, and what's on the right, the orange, is the normal gland. So we went inside the cavernous sinus, took the wall of the medial cavernous sinus, removed it completely. This patient so far appears to be in biochemical remission. How do we stop CSF leak? Well, basically multi-layer repair. We spoke about the vascularized layer septal flap, but one layer is never enough. So you have 2 septal flaps, you have some surgical and synthetic material, you have fat graft, then more synthetic material, then balloon to push everything back, and often we put a lumbar drain. So we have 6 or 7 lines of defense. Still, sometimes we even fail with all these lines of defense. What's in the future? Well, similar to what we're doing in gliomas, and Khalid is there. Now I think we're more and more trying to understand the molecular markers, the genetics and epigenetics. For invasive adenomas, can we use temozolomide if they are methylated? What about BRAF therapy? Is there any targeted therapy for these invasive ones that we can use? And I think in the future it's going to be a multimodal where we use surgery, targeted therapy, and maybe directed gamma knife or stereotactic surgery, as well as medical treatment for some of these ones. Why surgery had a bad name at some point? Well, this is called Scott's parabola, and someone trained in the UK were very familiar with this because Scott was a gynecologist from the UK. And he described the evolution and demise of new techniques and anything. They are started by enthusiastic pioneers who are very good and excellent in this, but a small limited number. And then they give great results. And then they become fashion. Everyone loves them. So every Tom, Dick and Harry will do them. People who are not trained, not skilled, but maybe enthusiastic. So you have an increase in the popularity, and then you start having the disappointments that many of the results are bad, lots of complications, lots of CSF leak, reuse, not cured, the recurrence rate is high, hormonal assay is bad, and then they start dropping them, but it will continue with the very few skilled ones who will still maintain that. I think this is something that we all go through it in life, and very true for surgical techniques and procedures. And I think we are seeing the second part of the paradigm now with endoscopic pelvic surgery, where it's becoming very complex and very advanced, but only with very few. What about Pituitary Excellence Center? We all love to call ourselves that, but really you need a strong multidisciplinary team. You need a very strong pituitary endocrinologist, good diagnostic imaging and then prevention as well as a multidisciplinary surgical team. We're very happy to welcome you in Sheikh Tahnoor Medical City, where we moved just recently, and thank you again for this presentation.
Thank you very much, Dr. Mohammed. Now the floor is open for a couple of questions. Please.
Thank you so much, Dr. Mohammed. I didn't really feel talking about Dr. Brilliant surgery. I'm trying to convince my ophthalmologist about OCT benefits, leave alone the surgeries. My question to you, Dr. Mohammed, how is your experience in prolactinomas as a surgery and person?
Well, I think, as I mentioned in the beginning, for many years I surgically avoided to operate on prolactinomas because it was considered as a stigma. If you operate on prolactinomas, it means you are desperate, you're taking medical cases to surgery, although I always felt there is a role. The number of prolactinomas we operate on so far is small, usually apoplexy or resistance or CSF leak afterwards. But I'm really hoping that we start seeing more referrals for microprolactinomas. And not because I'm enthusiastic for pituitary surgery, but honestly, if I had a pituitary microprolactinoma, I would choose surgery than taking medication for indefinite period of time. We know only 20% can stop it at 2 years, and 80% might need to continue longer. And in some patients, it needs to be indefinite time. So I think if something you can fix it with a surgery, if it's in the right place, right time, and with a low risk, it's worth considering.
Any other
Pituitary pituitary prolactinomas, the one we treat with maximum oracles. If we represent the neurosurgeon, what's the experience of the cure rate for
the cure rate is very high. So the recommendation of the International Pituitary Society was based on multi-center large studies, evidence grade 1. And for the short term, for 48 months, it was between 85 to 90%. After 3 years, it dropped by about 20%, but it was sustained throughout the follow-up, which was more than 5 years. So if you talk about microprolactinoma, if we can see it, it's actually easy to remove it. And that concept is true for even pushing microadenomas. We can see it because now that the thinking has changed, I don't need only to resect the microadenoma, I can do hemiphysiectomy, remove half the pituitary gland with almost no effect on the normal pituitary function where that microadenoma is. So I will take the adenoma and the capsule and maybe a thin layer of the normal gland tissue. So I ensure 100% that that area is resected. So for microprolactinoma, it's actually a great result. It's only for the invasive ones, because of the considerations of cavernous sinus invasion, etc., that there is still about 45% persistent high prolactin after surgery.
That was a gross rate
per year. The growth of macroadenomas is about 10 to 14% per year. Per year. 10 to 15% of them grow, not of the size. If we have 100 non-functioning macroadenoma, 10 to 15% will grow. The average growth is about 2 millimeters. Yes. If they grow. Now you have to remember that it's like other tumors. Biology is the reason behind it. So some tumors have favorable biology that you might follow them for 20 years and there will be minimal growth. And some tumors will grow and they will grow 1 to 2 millimeter per year if they grow.
So it's not visual effect, more like the physics. We can follow up by MRI.
Yes, if the tumor is not already touching the chiasm. If you have, this is what we said about, usually we talk about microprolactinomas. If they haven't reached the chiasm yet, usually it could be some macro in the process. But you have to remember that these patients, you have to follow them up very closely. So even people saying 6 months visual field is not enough, it has to be 3 months. You can scan them every 6 months or once a year, but the visual field and OCT has to be done in 3 months, because if it's persistent more than 4 months, it's irreversible.
So, one last question.
Just a brainstorming. Sometimes we fronted with patients who have upper limit of normal of the quality levels, and when you do an MRI, clinically they'll be having menstrual disturbances. You do an MRI, it's normal. So, question to both of you: how do we approach these cases? Because you have a dilemma to treat or not to treat. And on the MRI, there's nothing.
I did the right to talk to Dr. Mansour. I'll just say one thing about the physiological part. I think if the patient had one scan which is normal, we tend to repeat it multiple times, but he can probably tell you about some advanced techniques.
So I mentioned, in my experience, a lot of patients, particularly prolactin levels, for some reason they turn out to be negative, as I mentioned. So bring back patient, use better techniques, whatever you have, as I mentioned, the 4 or 5 techniques, except the invasive, right? Use the 3D MRI, even try the flare technique, try the dynamic technique, so exhaust all of them if it is going to help the patient management, so try all of the techniques. That is it, right? So your technique is very important to take, particularly the microorganisms. Just a comment about your residual tumor case, right? So that's the technology to intraoperative.
Yeah, I mean, the changes that happen now, that's something I haven't touched on, I've moved my time, so last comment is, we use lots of intraoperative visualization. There's something called 5-ALA, which is glioma. It's actually a dye we use for glioma tumors. Now, this has been experimented to visualize intraoperative adenomas. You change the light to blue light, and these fluoresce, become pink. And it's still a little bit experimental. There's use even for tractography for some tumors to see the hypophyseal bundle if we really want to be very finicky and protect the posterior pituitary and the hypophyseal axis. In this tumor, we can see on tractography which part of that tumor. You've seen the big tumor, the solid one we removed. The stalk was preserved, but was so stretched and so thin, so we can have an idea it's going to be anterior, posterior, lateral for your tumor. And intraoperative MRI is a great thing. For a poor man who doesn't have intraoperative MRI, there is now ultrasound probes that we put through the nose that will give you a rough picture at least which part of the tumor is adenoma. But really, from surgical experience, the consistency, the shape, the behavior is different. So sometimes what we don't see clearly on the MRI scan intraoperative, we know that this part is the adenoma. It actually feels very different. It looks very different. So thank you very much again.
Thank you very much for this informative lecture. Just before they prepare for the next speaker, we take very short question, very short answer.
So what's your criteria for like non-functional adenoma? What do you
Okay, so yeah, so a very simple rule, sort of a simple surgeon rule is if it's not touching the optic chiasm, I tell them you need follow-up. And if it's growing, even by 1 or 2 millimeter, I will offer them surgery, and it's up for them to accept it or not. If it's touching the optic chiasm, even with normal visual field, I tell them it's normal today, in 6 months it might not be normal, and it could be too late. So consider surgery seriously. If there is any deficit, I will really make great effort to convince them to have surgery, even if it wasn't quadrantal, because the optic nerve, they tolerate up to a certain point before very rapid changes happen.
Thank you very much. So today's morning session was mainly emphasized on the the multidisciplinary approach for pituitary diseases. So we started with radiology, then neurosurgery, and then we're going to finish with radiotherapy. And the best talk is Dr. Khalid Al-Raj. Dr. Khalid has been trained in the United Kingdom, and he has qualifications from UK, Ireland, and Canada. He has 2 fellowships in gynecology brachytherapy and CNS stereotactic radiotherapy. He's an assistant professor at Faisal University, Riyadh, and as well in University. He has been treating patients with radiotherapy with multiple modes of radiotherapy, and he's going to tell us about updates in radiotherapy. Welcome, Dr. Khalid.
Changes.
Fibrosis.
Okay.
Okay. Bismillahirrahmanirrahim. Mr. Chairman, dear colleagues, good morning. A pleasure to be with you at this great event. Khalid, thank you very much for the invitation. Been assigned to talk about the updates in radiation therapy to pituitary. There's an evolution in radiation therapy over the last 4 decades. So I thought better to take you through a journey over these 4 decades in radiation therapy evolution. At the same time, we'll concentrate on the radiation therapy with the pituitary tumor. Over the last 40 years, there was a statement clear that radiation therapy is a modality as an adjuvant treatment for all pituitary tumor before or after surgery. With the improvement of MRI and surgery, as you've seen by the previous colleagues, this is not true anymore. We assign the radiation therapy only for specific cases. Even though, you know, MDT is an important rule for all the cases to be discussed before to decide what the modality of treatment should we go through. And it is easy to decide that this patient is needing radiation therapy. But the difficulty that we face and the challenges nowadays is how to decide on what modality of treatment among radiation that we will use for this patient, what doses we will get, and what margin we get. That's why we have our own MDT after the normal MDT that we have with all the specialty hospitals to decide on the treatment. I will not go through this quickly. I think you're more familiar with it more than me. Pituitary is within the pituitary fossa. There are a lot of diagnoses, whether benign or malignant or differential diagnosis or the mass on that cellular threshold. The most important thing is the proximity of critical structure to the mass itself. So if it's near to the optic nerve or near to the vagal sinus, there will be a lot of presentation based on that. If it is small, there might be only some sort of symptom related to the tumor itself, whether it's functioning or non-functioning. they will present with neurological symptoms, visual impairment, cranial nerve septic, or sometimes, as Dr. Mansour showed us, this is asymptomatic because of incidental finding, hormonal abnormalities according to its function. And it varies from large size to small size. And I said, if it is going, craniocaudally, there will be a presentation based on this extension either to the carpal sinus or to the pituitary itself. This is the famous guy, Robert Welbo, who was the tallest recorded man on Earth because of pituitary tumor. Diagnosis, I think again, you know the informant of radiology, important for radiology, blood test, and neurological and ophthalmological, manifestation. As oncologists, usually when we talk about any cancer, we have to stage them. But unfortunately for pituitary tumor, there is no stage. We rely only on the size, as Dr. Mansour mentioned, that is it microadenoma or macroadenoma, as a 10 millimeter is a cut line for that. Radiotherapy nowadays indicated for those tumors with residual disease and have symptoms, or those are functioning tumor that cannot be controlled either by surgery or hormonal treatment. It accounts for 10% of all intracranial tumor. As I said, multidisciplinary approach not only for the main hospital MDT, it should be also there should be another MDT among radiation oncologists themselves. In our department at Tawab, we have several radiation oncologists, so we discussed the case before and we assigned the final way of treatment to each patient and the dose and the regimen that we use and margin for each tumor. So post-operative pituitary radiotherapy for non-functioning tumor is now based on a risk assessment, depending on the histological finding, and also if the tumor progresses with significant threat to function like vision. It is a valuable and effective treatment option for recurrent adenomas or region not amenable for surgery or medical treatment. So over the last 40 years, we start with something called 2D. Imagine if we treat the pituitary, which is a centrally located tumor, from two lateral area. So we will give the 100% to the pituitary tumor, but also all temporal lobes will receive the same dose. So if we give, for example, 45 gray, all that area through 2D will receive the whole thing. And that's why there is a movement toward another thing that we need as a radiation oncologist to deliver the dose to the tumor and spare as much as we can to the normal tissue. So we should conform the treatment to the tumor itself and spare the normal tissue. That's why there's dramatic improvement in radiation therapy from 2D to 3D conformal therapy, then to intensity modulated radiotherapy, then stereotactic radiotherapy and stereotactic radiosurgery. The difference between stereotactic radiotherapy and radiosurgery is the dose itself, and fractionation. So if you get more than one single fraction, we call it stereotactic radiotherapy. If we give only single fraction or three fractions, we call it stereotactic radiosurgery. Stereotactics, it's a term taken from our colleague neurosurgeon when they localize the tumor through coordinate outside. But for example, we fix the brain and then we put the coordinate the box and then X and Y and Z point to correlate to the deeply seated area that we want to treat. We call it stereotactic. We start with the production of X-ray. This is William Röntgen. He's a German scientist. In 1905, he was playing between cathode and anode. He played with the voltage through these, two things, and they found that there is a light coming when he accelerated the photon with different velocity. So he questioning this, light. What is it? So we call it an X-ray. He put his finger in the films and then reflected on the films, and they call it X means unknown. He said, this is unknown ray, I'll call it X-ray. And hence, that time it's called an X-ray. This is the tube, and if you see that this is the cathode, and this is the anode. So when we accelerate and bombard the electron with a high Z material, it produces something called photon. Photon is the X-ray or the energy that we're looking for in radiation therapy. We have two types of radiation, either industrial that we create through accelerating the electron to bombard high Z material to produce the photon, or from the nature. If we have a radioactive source like radium or deuterium or any other radioactive source, the disintegration of the cell in order to reach to a stability can emit radiation, but this radiation they call it gamma ray. So from the nature we call it gamma ray, from industrial we call it photon or X-ray. At the same time, this couple, Madame Curie and her husband, discovered the activity. So they come with the radium and deuterium as a radioactive source for radiation, which is gamma ray. Then this smart guy came and put this radioactive source in a machine, and he put a lead shield around it. And when he wants to treat the patient, he will expose the patient by opening this shield, so radiation will come to the patient himself. And they call it cobalt unit, and this was in 1950. Then there was more advances in radiation. So we're using something called linear accelerator. You see, this is a lengthy, distance between the anode and cathode. So the difference between the normal X-ray and linear accelerated is the acceleration. Usually in diagnostic X-ray we use 80 kV-fold, while in radiation we use million-fold. So if we accelerate the electron with million-fold and bombard it with the target, then we have photon with very high energy, we use it for radiation. So what is the radiation target? To eradicate the tumor, we need to hit the target itself. The target is DNA. Either direct or indirect. Direct through the dose directly to the DNA, or indirect through activation of this ionization through water to form a free radical that kills the DNA and causing the problem. When we say that this cell died in radiation therapy, we mean that it's not instantaneous death. Radiation therapy is not like a Panadol, you give it to the patient and within a few seconds you have a relief. No, it takes time to act. Usually start 1 week from the start of the patient till 2 months at the end of the treatment. Damage to DNA can be repaired and there will be nothing happen to the patient. And when we give radiation therapy, radiation cannot differentiate between normal tissues and abnormal tissues. So that's why if you see most of our regimen is fractionated, given over long period of time. So we kill the tumor in one head and we let the normal tissue to repair itself, to recover, and we next day give again another head to kill tumor and give more time for normal tissue to be repaired. The radiation therapy is more sensitive at M phase, whereas the time for division. And this is the finding. So the first thing is single hit with large dose called dicentric chromosome, where the cell will not be able to divide at mitosis. Maybe a ring chromosome. When we have the ring chromosome, it will be like circle, so there will be no duplication. And when we don't duplicate this, the cell will die. Anaphase bridge. When the cell is moving away to duplicate to other sister cells, if there is a bridge caused by radiation, it will not separate and will not divide and die. A head might cause only translocation, and this might be repaired or might be stay still the same. Next day, if we have another head, will cause the same thing, and then cell will die. Insertion, so part of the chromosome will go to the other end, and one from the small one go to the larger chromosome. Deletion, part of it will completely disappear. So what is the end result? If you expose to radiation therapy, whether for treatment or for exposure, there will be one of these three things. If it is for treatment, there will be cell death and unviable cell, and this is our aim. If it is only exposure due to war, due to area that there is a radiation and you've been exposed to it, there will be DNA problem, and then you will develop cancer. Or, as I said, it might be simple hit that can be repaired from normal tissue, and next day the cell will divide normally to compensate for the head itself. As radiation oncologists, we accept up to 95% response, and we accept up to 5% complication. There is a clear agreement called tolerance for all tissues that all radiation oncologists will not exceed as a dose. So if we give this, for example, the brainstem has a limit of 50 gray. The optic nerve has a tolerance of 55 gray. If we exceed these, it means that we exceed more than 5%, which is globally, agreement that we accept up to less than 5% to achieve a complete cure or 100% response. Our aim as radiation oncologists for the last 50 years is to spread this curve from each other. So if we take the tumor curve in this way, so we'll be able to achieve the 100% with no effect on normal tissue. That's why we're moving from 2D to 3D to 4D, and the aim is just to balance between the tumor killing and damage to the normal tissue. If there is less than 5%, we accept it. If more than 5%, we share with the patient the likelihood of side effect, and the patient should decide also, and the management. So 2D conventional simulation is mandatory. Before we start the treatment, we take the patient to a simple X-ray with the laser help to decide by putting them on the actual treatment location. So that's why we later on we calculate and see what is the proper dose to the area that we will control or we will treat, and see what is the dose calculated to the normal tissue surrounding, and then we'll bring the patient to be treated actually on the actual treatment later on. So then we move to 3D because of this device. This device is called MLC. It's a 16 pair or 32 pairs of leaves that move during the treatment. So if imagine the tumor is like a circle, and instead of coming with from two areas, so 50% from here, 50% from here, it will be 100 to the center, but the normal tissue will receive 50 and 50 from here. So because of the 3D now, we are able to come from different directions. Imagine if this is a 360 degree, we can come from pinpoint pencil beam to give only 1%, but on the center it will be 100%. So 100% inside with the aim of this MLC. This MLC will shade in each direction the tumor shape in order to protect. For example, if the machine is operating on this shape, all that area that there is light shielding will not receive radiation, only the shape of the tumor. And as the tumor is the head of the gantry is moving in 360 degree, this MLC will be modulated to deliver to the same shape of the tumor itself. And this is a picture of 3D nowadays that before, as I said, before starting the treatment, we'll take an impression on the brain by taking 150 slides, and they will call me to draw the normal structure in each slice and draw the tumor bed on each slice. Imagine, it takes us in the past 8 hours to 9 hours to finish it. But nowadays, with AI, we pull millions of data from normal structure, and the computer will help us just by pressing on brainstem. It automatically it will draw it for us, and my job is just to come and draw only the GTV or the gross tumor volume. We've used, when we did the CT plan, we've used the normal diagnostic with our radiological or planning CT. We have our own planning CT in 1 millimeter thickness CT. So imagine that if we draw the GTV on that, or the gross tumor volume on that, and take it from an MRI, the resolution would be great. As the tumor consult said, MRI is perfect for delineating the tumor itself. But sometimes we use the CT scan to allocate the bony structure and how to coordinate it with the day and daily treatment. So this is an example to illustrate how we've used our CT scan finding on planning with the MRI or with other diagnostic things to make sure 100% that we draw the right area of interest. In radiation, we're talking about gross tumor volume. So we draw in each slice out of this 100 the gross tumor volume itself, and then we take margin around it. We call it clinical target margin for subclinical extension. Then we take another margin, we call it PTV, planning target volume, because on a daily basis, if we treat over 5 weeks, patient is not in proper setup. There will be a setup error on daily basis, maybe 1 millimeter, 2 millimeter difference. So we take bigger margin, and on daily basis, we treat that area with 100% accuracy. But of course, we don't want to treat all this, we need to treat only GTV. And that's why we are limited because of three GTV. And that's why with the fusion of radiation therapy, we will move to something called 4D nowadays. So nowadays with 4D, we can see the tumor while it's moving. So we are not just conform the tumor in 3 dimensions, because if you take this slice and add it to the rest of the slice together, you might find only 1 square dimension. But in each slice, we need to conform it like if we have tumor with C shape, we'll be able to deliver the treatment to the C shape itself, and not to the whole normal tissue around it. This is an example of 2D pituitary tumor management. The orange one is 100%. Imagine we want to treat only the pituitary, but at that time, in the history, in the past, we used to treat the whole brain with the whole dose. Then we moved to the 3D, just to inform you to understand the concept of 3D. See, if we come from 4 sides, 25% from each one, it will be 100% on the center. But again, if you see, this is, the black one is a normal structure, still part of the normal structure on 3D is included. So how to get rid of this? They came with something called intensity modulated radiotherapy. What we mean by intensity modulated radiotherapy, through the gantry itself of the machines, if this direction will expose first to a normal structure, the machine will tame off the beam and will not receive any radiation from that side. And this is the final thing. So you can see on here the part of the normal structure receive radiation. But here with IMRT, no more radiation is delivered to normal structure. So thanks for the IMRT, it's a new advance in radiation, and we managed to have it. So please, if you send any patient for radiation therapy, make sure that your radiation oncologist have an IMRT to deliver to the patient, if we give fractionated radiotherapy. This is an example of 3D. You see, it's like a box. The yellow is the 100%. It's a box from 2 lateral and 1 anterior field. And see the difference in coronal, sagittal, and axial. But this is a case also 3D, but this is the IMRT. See the beauty of IMRT, they deliver the treatment to the tumor itself, and no more radiation to the critical structure. I'm not going to repeat the rationale, I think you are aware about it. This is the intensity modulated radiotherapy. It's more advantageous because it's increasing conformality, spare adjacent normal tissue, useful in tumor with supracellular extension, and we can give up to 50 gray in 5 years treatment. All this is, for conventional or for IMRT or for 3D conformal therapy, we have long data over the last 30 years. More than 100 retrospective trial addressing this question and showed that the control rate achieving up to 90% over 10 years and up to 88% over 20 years with very minimal side effect. I'll go through it. When we have functioning tumor, the likelihood of stopping this is very high, up to 75% in 10 years, whether it's Cushing or acromegaly or prolactinemia. The biggest trial came from Royal Marsden, and again, this is more than 200 patients. 10 years progression-free survival is 92%, 20% at 88% at 20 years. Functional tumor normalization for growth hormone, more than 75% at 15 years. And Cushing, 50% within 6 to 8 months. Of course, exposing patient to radiation, we get a cure rate, but at expenses of toxicity. Hypopituitarism is the main thing. It's ranging from 30 to 60% over 10 years. Visual pathway deficit, around 1 to 2%. Risk of second brain tumor, cumulative over 20 years will be around 2%, and it's more likely glioma and meningioma. Cerebrovascular risk, there was slight risk of stroke, but they related to deficiency of hormone rather than radiation itself, because they found it's the most important factor related to that. The cognitive deficit, there is no difference between treating patient with surgery or with radiation therapy, because the hippocampus is away from our field of treatment. So we'll come now to the latest advance in radiation oncology, which is SRS. SRS stands for stereotactic radiosurgery. As I said, single fraction or fractionated. The difference between this modality of treatment and the previous one, the conventional one, is the margin. You remember, we take the GTV, then 1 centimeter around it, and then 0.5 for BTV. Here, we will not take any margin. We take only the gross tumor volume, and we deliver very high dose in single fraction. So imagine if we, instead of delivering 50 gray, we deliver 20 gray in single fraction, the likelihood of killing the cell will be great, the control will be more, and at the same time, normalization of hormone will be quick rather than giving conventional. But this is not applicable for all tumors. There's specification for it, we can give it only for those small tumor away from critical structure. So the key message is that if there is a tumor less than 2 centimeters, we can treat it with SRS. And if there's tumor more than that, microadenoma, large one near critical structure, we cannot give large dose with specific margin to cover it without affecting the normal structure like optic pathway or coherent sinus. So this modality of treatment is only given to small tumor, and it should be done in a place where there is a dedicated machine. And when I say dedicated machine, it should be either a gamma knife, and this gamma knife, most of my colleagues in neurosurgery, they like it because they are the one who invented. The unique about that, it's only for cranial cases. But the pitfall is that, again, is that's invasive procedure. We need to fix a very rigid frame under GA. We put a screw and 4 screw in the skull so the patient cannot move, because if the patient is moving less than 1 millimeter, the whole treatment area will be changed, so we might expose the patient to large dose unnecessarily and cause more side effect. The other new machine called CyberKnife. This CyberKnife is a robotic machine, and the gantry is mounted on this robot, so it moves in 360 direction and more than 1,000 angle. Would treat with a pinpoint beam. Imagine you have 1 centimeter tumor, and you come to this 1 centimeter through 380 degree, and with more 1,000, pencil beam, you will give very, very low dose to the normal tissue and very high accurate dose to the tumor. The good thing about it is non-invasive, simple. We do mold this frame, and the more advantageous thing is that it's not only for cranial like gamma knife. We like it as radiation oncologists because we treated other sides like liver, bone, or spine with this machine. We can call it SPRT outside the brain itself. And this is the evidence, if you like it, that show that more effective dose is benefit to the tumor, more control achieved, and more normalization to the hormone happen with this modality of treatment. One more. Just I'll show this.
X-ray images to detect the patient's skull and thereby transposition of the treatment target, regardless of complexity or location. If the patient moves their head even slightly, the CyberKnife S7 system uses artificial intelligence to synchronize the treatment delivery beam to the target's new position in real time. This allows treatment to be continuously delivered with sub-millimeter accuracy and precision. Conventional radiation systems cannot adapt treatment delivery to movement of the patient's head and often require invasive head frames to compensate for potential motion. These stereotactic frames, which are bolted to the patient's skull, are painful for the patient and create a labor-intensive workflow for clinicians, requiring a supplementary procedure to install the frame and additional setup for each treatment session. The CyberKnife S7 system reliably positions the linear accelerator with 6 degrees of freedom to provide non-coplanar, isocentric, and non-isocentric treatment delivery from potentially thousands of angles. This wide range of available beam angles is not possible with conventional systems and allows the CyberKnife S7 system to distribute highly personalized conformal dose with sharp dose gradients, which are needed to irradiate brain lesions while helping minimize dose to healthy tissue. The AI-driven robot repositions the treatment beam with sub-millimeter accuracy in real time during treatment without the need for a stereotactic frame, human intervention, or pausing and stopping treatment delivery. Real-time adaptive treatments are often delivered in as little as 15 minutes, and personalized motion-synchronized SOS treatment plans are easy to create and can be optimized in as little as a minute. Together, this provides the patient throughput required to be successful in today's clinical environment. CyberKnife S7 system with Synchrony uses X-ray images to detect the patient's skull and thereby track the position of the treatment target, regardless of complexity or.
So, other modality than photon radiation therapy is proton therapy. I think some of you hear about it. The good thing about it is when the proton will come and deliver all the radiation therapy in a specific way. It was amazing for specific tumor like clinical angioma or pituitary tumor in kids because it's sparing normal tissues. But the evidence showed that there is no superiority of this proton on the conventional for pituitary tumor. Re-irradiation. I think still, even if we irradiate the patient, if we have a patient with recurrence after surgery, after hormonal therapy, after radiation therapy, and this patient cannot go for surgery, we can still re-irradiate. If the patient treated with conventional radiation therapy, we can take him to SRS and give him single fraction to the residual tumor or to the radiation. Of course, there will be slightly higher side effect in comparison to the naive patient who receive only one treatment or one modality before. I'm not going to go through this experimental type of a new treatment. They are using the thyroid receptor radionuclide therapy for neuroendocrine tumors. still under investigation. So I'm proud because we have this latest version of this machine in Taiwan, and we are under specification, doing calculation on the last, period of this machine now. So we'll start our first patient hopefully end of November. Waiting for our colleague to refer patients with pituitary adenomas. I was part of the reconstruction myself. And this machine, I call it yes machine. It deserves a kiss because it causing a lot of huge difference from what we have in the past. Again, the rationale of additional, as I said, it's there. It's a modality of treatment, but we need to discuss it in MDT. And also, as a patient oncologist, we need to discuss this among ourselves to choose the best modality of treatment, the best dose. Otherwise, if we don't discuss it in MDT, we'll find this finding, which is true. Everyone did his part perfectly, but at the end, the net is zero. So this is true, by the way. It happened. We try to avoid it, inshallah, with proper MDT. Thank you.
Thank you very much, Mr. Khan. Very interesting. Very interesting. Well, congratulations to get all these new machines. Also, Thank you very much. Because we are already supposed to start the next session. Please, Dr. Khan is available. Go and ask him a question. We'll have short photo. Just that's for Dr. Khan and for the group to the mic. So please come forward to have a photo. Then we break for yes. Right, the other side. Outside. Okay. We'll go outside for one photo. Then take something and come for the next session, please. Thank you very much, Dr. Khan. And I thank all the speakers, like Dr. Mansour, Dr. Khan, Dr. Muhammad, thank you very much, and Dr. Ala, thank you very much. I appreciate it.
Okay, it gives me a great pleasure to introduce my co-chairman and myself, Dr. Manki from Riyadh, senior consultant endocrinologist. I'm more of a dinosaur, very old, but appears to be young. I work in Oman as a senior consultant endocrinologist as well. So the next 3 sessions are going to be very interesting, hopefully. The first one involves our speaker from abroad, Professor Nikki, and she's from Birmingham, endocrinologist with interest in pituitary disease, hyperpituitarism. She's been involved in a lot of research with different bodies from across both UK and the Atlantic. And the main topic will be on, as well known now, the new nomenclature for diabetes insipidus. Now we are calling it G9 vasopressin deficiency. So there have been a lot of changes and developments in the old past. We used to do 8-hour test for diagnosis of diabetes insipidus. I think she enlightens us on different aspects, different utilities for diagnosis and clinical aspects and interventions. So I think we can start the session and we go ahead, please.
Hello, everyone. Many thanks to the organizing committee for the kind invitation. It is indeed a great pleasure for me to take part in the pituitary course organized by the Gulf Association of Endocrinology and Diabetes. And in this lecture, I will cover a quite challenging area, which does not only involve endocrinologists, but a wide range of specialists involved in the care of patients when they are admitted in hospital. So we will discuss the inpatient management of central diabetes insipidus or vasopressin deficiency, as we would like to call it nowadays, and I will share with you some pearls and pitfalls. I have no conflicts of interest on this particular topic, and during the presentation, the areas we will cover involve the definition of AVP deficiency. Then we will move through the management of AVP deficiency following neurosurgery, and we will also cover the management of the patient with AVP deficiency who is admitted in hospital. So what is AVP deficiency? AVP deficiency, as we all know, is characterized by hypotonic polyuria, and in adults, this polyuria is defined as passing more than 50 ml per kilogram of body weight every 24 hours. And the causes are many. The causes of central diabetes insipidus or AVP deficiency are quite a lot and include acquired or congenital. Just to go through a few of them, it can be following surgery, it can be associated with neoplasms in the paracellar area, like craniopharyngiomas, meningiomas, metastatic disease. It can appear after a cerebral hemorrhage or be associated with granulomatous conditions or infectious conditions or inflammatory autoimmune conditions. Rarely it is congenital, but yeah, there are cases which appear and are looked after in our outpatient clinic with congenital AVP deficiency. And thankfully, nowadays, we have means, we have ways of managing this condition. We have the desmopressin, which is the synthetic analog of AVP, and we have various routes of administration, oral tablets, some linguinal melts, intranasal spray, or intravenous injection. These are the daily doses we can use. And just to remind you that the bioavailability of the parenteral form is 100 times that of the oral form and 10 times that of the intranasal form. And obviously, we keep this in mind when we manage our patients with AVP deficiency. So let's move on now to the inpatient management. And we will start with the inpatient management for a patient who has undergone neurosurgery, or it relates generally with neurosurgical causes. So we can see this condition after transsphenoidal or transcranial surgery in the sellar or suprasellar area. And actually, it is one of the most commonly reported complications after surgery for pituitary tumors. We can see it after traumatic brain injury. We can see it after subarachnoid hemorrhage. And I would like at this stage to focus on the presence of vasopressin deficiency after transsphenoidal surgery for pituitary tumors. This is, as I mentioned, a complication which we can come across in pituitary centers, and it would be good if I shared protocols on how we manage or how we will suggest this condition could be managed. What's the prevalence? What's the frequency of this condition? Very recently, we published a systematic review on the topic, and we estimated rates of transient or permanent AVP deficiency after transsphenoidal surgery. And we looked at pituitary adenomas, transient 16%, permanent only a small percentage of patients, 2%. In craniopharyngiomas, just transient in 31%, and permanent was in 30% of the patients. And following surgery for a Rathke's cleft cyst, just transient, only transient was 35% of the cases, and permanent in 14% of the cases. You can see from the confidence intervals that the ranges are quite wide. And this is where the question comes, why they are so wide. One of the reasons is relates with the criteria we are using to diagnose AVP deficiency. And these tables show the studies we relied on, and they have more details on how AVP deficiency was defined. So there was a quite wide range of definitions, and this may explain why we have such a wide range of frequencies. What does this mean? I think it means that it is very important to have a robust protocol on how we diagnose AVP deficiency following transsphenoidal surgery. In the Queen Elizabeth Hospital, Birmingham, we have a protocol which we have been following up for years, which we believe has led us to safe care of the patients. And let me share this with you. So following transsphenoidal surgery, we aim for a maximal fluid intake of 2 liters per 24 hours. There is close monitoring of the fluid input and output. We check UNEs, calcium, plasma and urine osmolalities and glucose daily. And when the urine output of the patient is more than 200 mL per hour for 3 consecutive hours, and there is serum sodium of above 145 millimoles per liter, and we have hypotonic urine with urine osmolality below 200 milliosmolar per kilogram, or if we use specific gravity below 1005, then we say that diabetes insipidus has developed and we need to intervene. And of course, there are a number of pitfalls in this setting in patients who have pituitary surgery. One of them is the fluid overload. The patients can have polyuria as expected because they received large amounts of IV fluids during surgery and now they are offloading them. But in these patients, the plasma osmolality will not be high. The urine osmolality or specific gravity may be normal or may be low, and the blood sodium would not be high. So these are points we need to remember. Another pitfall, we have a patient with acromegaly who is operated on, and acromegaly has successfully led to reduction in the growth hormone levels after surgery. And we all know that the growth hormone and the IGF-1 have an anti-natriuretic effect. So following the reduction of the growth hormone, this effect becomes less. The patient then will have polyuria, which usually is in the first 48 hours after surgery. And in such a case, the urine osmolality or specific gravity will not be low and the blood sodium will not be high. Another pitfall, a patient with polyuria following transsphenoidal surgery. If the patient has osmotic diuresis due to glycosuria, the patient may have diabetes mellitus, which has been in his medical history already, or it may relate with the fact that the patient was given large amounts of steroids. So whatever the reason is, with the glycosuria, we have osmotic diuresis, so we have polyuria. In such a case, plasma osmolality would be high, but also urine osmolality or specific gravity would be high as well. And an important point we need to remember when we manage these patients in the neurosurgical setting, we all know that glucocorticoid deficiency impairs the free water clearance, and this can mask the polyuria if the patient has AVP deficiency. So once we offer glucocorticoid replacement, we need to be aware that we need to monitor for the development of AVP deficiency and manage it appropriately. Another point which can lead to problems in the management of patients with AVP deficiency following neurosurgery. This has to do with the time course of the AVP deficiency. So these are all the patterns we could expect to see in patients who had transsphenoidal surgery. So the AVP deficiency could be transient, just transient. It usually develops within 24 to 48 hours post-surgery, and it resolves within a few days. It can be permanent. we can see a triphasic or biphasic pattern, so AVP deficiency followed by syndrome of inappropriate secretion of antidiuretic hormones followed by AVP deficiency, or in the biphasic pattern, AVP deficiency followed by SIDH for a while. Or we may have SIDH, which can be followed or not by AVP deficiency. So it is very important to keep in mind that we will not have a specific pattern of the electrolyte abnormalities and the polyuria. And it is important to remember this because, especially in cases of transient AVP deficiency or cases of SIDH, there is a risk of hyponatremia if we offer unnecessarily DDAVP, or we offer, again, unnecessarily excess water. So with the Queen Elizabeth Hospital Birmingham criteria, once the patient has all these 3 points, we offer desmopressin. Our dose is 1 microgram subcut or IV. We monitor the UNEs, the plasma and urine osmolality, and the glucose twice daily, and we allow the patient to drink according to thirst. And we will repeat the DDAVP dose if all these criteria are met again. And it is important to highlight that we would not go with pre-scheduled DDAVP doses in the first week after surgery, because there is a risk of hyponatremia after resolution of the transient AVP deficiency, and there is a risk of SIDH. So everything that happens with the patient in terms of DDAVP administration is decided on a daily basis. If the AVP deficiency persists for more than 48 hours, we would consider offering regular DDAVP, which could be oral or sublingual. And again, we need to monitor for resolution of the transient AVP deficiency, or to monitor for the triphasic or biphasic response I mentioned earlier on, by careful monitoring of the fluid balance and the UNEs. In such a case, we would stop the DDAVP treatment, and if need be, we would fluid restrict the patient to maintain normal sodium levels in the blood. If we would need to offer IV fluids, we would prefer hypotonic ones, and this could be 5% dextrose in water, followed by 5% dextrose in 0.5% saline, and once the patient is discharged from the hospital, again, we would need to continue the monitoring of the fluid balance and the blood electrolytes. So that was the protocols. These were the protocols following transsphenoidal surgery. How about the patient who has diabetes insipidus already and is admitted in the hospital? I will mainly focus on the Society for Endocrinology guidelines in the UK we have, and I will highlight a few important points. First of all, we need to remember that during hospitalization of patients with AVP deficiency for acute illness, the fluid balance can be less stable and there is a risk of hyper or hyponatremia. And unfortunately, serious adverse events, including even deaths, have happened through a combination of lack of knowledge and treatment failures by health professionals. And this led the NHS England in 2016 to release a warning of the risk of severe harm or death when desmopressin is omitted or delayed in patients with cranial diabetes insipidus. And in the text I have in the right side of the slide, there are a few areas that are highlighted and we need to discuss. So the main themes from reported incidents of desmopressin omission, as confirmed by a short survey of nursing staff, included lack of awareness of the important or the vital nature of desmopressin amongst medical, pharmacy, and nursing staff. Poor availability of desmopressin as well within inpatient clinical areas, where often it was not kept as a stock item. Other common reasons for desmopressin omission included nil by mouth status or patient refusal, especially if they have an acute illness. There were times also that there was an assumption that desmopressin was a relatively low priority medication, and this was particularly evident when this was given as a nasal spray formulation, and it was in the mentality of healthcare professionals that if it is a nasal spray, given that other nasal sprays are used to treat minor symptoms, then maybe this medication is not important. And as the symptoms of omitted desmopressin can include confusion, agitation, a hostile or uncooperative behavior by the patients, then the patients who would usually be aware of how important this medication for them is, they would not be able to emphasize this to the medical staff. So these are important points we need to keep in mind during admission of the patients. Now, important aspects in decision-making during the management of patients, of inpatients with AVP deficiency. We need to assess the fluid status. We need to check for hypernatremia. We need to consider fluid resuscitation. We need to monitor the serum sodium and urine output. We need to choose the right fluid replacement, the right dose and route of administration of desmopressin. And of course, we need to avoid overcorrection of hypernatremia. And patient groups who can be at particular risk of rapid deterioration, and we should be really alert with these patients, are frail or physically unwell, or if there is acute or chronic confusion or reduced conscious level, patients who are nil by mouth, patients who are unable to self-administer the desmopressin, patients who have hypo or hypernatremia or have adipsia, patients who have problems with their communication or difficulty in language, and patients who have multiple transfers within an institution facility, and in such cases, mistakes, omissions, unfortunately, can happen. Organizational guidance for hospitals and other care facilities when a patient is admitted in hospital include, first of all patients in a hospital or care facility with central diabetes insipidus should be identified immediately on admission. Also, endocrinology or alternatively appropriate clinical team should be alerted and remain aware of all patients in a hospital or care facility who have a diagnosis of central diabetes insipidus. This could be through the electronic patient record in which there is an alert to the clinicians that these patients have central diabetes insipidus. And all wards or equivalent clinical areas should have 24-hour access to DDAVP. Furthermore, patients with AVP deficiency who undergo elective surgery, they should be highlighted in the pre-assessment process. And the colleagues who are involved in the perioperative care should have developed a very clean plan to cover this condition during the admission and not leave it in the last minute. Also, hospitals and other care facilities should develop an alert system that serves to highlight all patients who require ongoing treatment with desmopressin, aiming to reduce the harm from medication errors like missed prescriptions, incorrect prescribing. We know, for example, that diabetes insipidus could be confused with diabetes mellitus, and therefore, instead of desmopressin, insulin can be offered with catastrophic consequences. And let's focus now on 3 groups of patients and how we could manage them during admission. Patients who are able to drink or require maintenance IV fluid therapy and care, but they are able to have their desmopressin. So these are patients who are orientated, they have normal Glasgow Coma Scale, they have intact thirst mechanism, they are able to drink, and these patients should have easy access to water by the bedside, should receive the DDAVP as prescribed and agreed by the clinical team. In terms of IV fluid replacement, how should we go with that? For patients who have normal serum sodium and they require IV fluid therapy, the type and volume administered should be equivalent to the daily requirements which are appropriate for other patients without AVP deficiency. And obviously, they should be together with the agreed prescribed dose of desmopressin and serum sodium should be monitored at least every 24 hours whilst the patient is on IV fluids. That's one group of patients. How about the group of patients who have impaired consciousness or who are unable to manage their own intake and medication? This is a more difficult group. So for those who have normal sodium, the type and volume of fluid administered should be equivalent to daily requirements appropriate for other patients without AVP deficiency. And again, this should be given together with the agreed prescribed dose of desmopressin. We need regular assessment of the fluid status, and this would include monitoring of fluid input and urine output, together with measurement of blood sodium at least every 12 hours until the patients can manage their own fluid intake or are clinically stable. And it would be good to move to oral or nasogastric water as a replacement fluid of choice as quickly as it is clinically safe, because this provides a good buffer against rapid changes of serum sodium. And how about another group of patients who are significantly unwell? They have intercurrent illness or decompensated AVP deficiency. We need urgent clinical assessment here of volume and hydration status, measurement of blood sodium, potassium, renal function. Optimizing fluid replacement should take a priority, and this is followed by assessing the need of DDAVP administration. In patients with high sodium levels, the type and volume of fluid replacement should reflect the standard daily fluid and electrolyte requirement, plus the component of the estimated fluid deficit, such that correction of hypernatremia is controlled. And in this box, we have the sodium content of common infusates. Obviously, we will go with 5% dextrose in water as a first choice. But there is also a group of patients in whom the circulating volume status is compromised. These patients may not be polyuric at presentation. Also, patients who are volume depleted, they may even have normal sodium levels. So in patients who have depletion of their intravascular volume, the volume status, as assessed by blood pressure, pulse rate, it should be restored by 0.9% sodium chloride in water prior to consideration of free water administration. And these patients need close monitoring. We need to measure the sodium every 4 hours during the fluid resuscitation, and the frequency is reduced later, but again, it should be close. We would go to oral or nasogastric water as soon as the patient is clinically safe, because as we mentioned, this route can provide a buffer against over rapid changes of serum sodium. We would go with treatment with IV or IM DDAVP, usually 1 or 2 micrograms, if the patient has excessive, inappropriate dilute urine. Again, close observation of the clinical or biochemical response. And in order to avoid the development of over-rapid correction of the hypernatremia through the combination of high fluid loads together with the antidiuresis, which is caused by exogenous DDAVP, we need to consider that further doses of DDAVP will be given when there is production of higher volumes of dilute urine. When this happens, we should be cautious. And a final point, in symptomatic patients who have hypernatremia that has developed within 48 hours, so acute hypernatremia, the serum sodium should be corrected at the rate of 5 millimoles per liter in the first hour or until symptoms improve, and it is limited to 10 millimoles per 24 hours. In cases which are not as severe, so patients with no or mild symptoms, hypernatremia can be corrected at a rate which is not exceeding the 0.5 millimoles per liter per hour, and it should definitely be limited to 10 millimoles per liter per 24 hours. And another important point, which could be forgotten when we manage these patients, is that hypernatremic dehydration is associated with increased hematocrit. And not only that, but immobilization, obesity, infection, they further increase the hypercoagulability, and there is a risk of venous thrombosis and pulmonary embolism. So we could consider prophylactic subcutaneous low molecular weight heparin when we have episodes of hypernatremic dehydration. So conclusions from this session. The management of the AVP deficiency in the inpatient setting can be challenging and requires endocrinology input and multidisciplinary approach. In patients who develop AVP deficiency following transsphenoidal surgery, for these patients, we need robust protocols for the diagnosis and for the management of AVP deficiency. And this is vital in order to achieve safe care. And during inpatient management of a patient with AVP deficiency, priorities always remain the optimal fluid balance, the safe correction of sodium abnormalities, and the appropriate DDAVP administration. And with this, I would like to thank you for your attention, and I would be very happy to take questions. Thank you again.
I don't know if there are sessions for the questions. She's not available, I think. So just to emphasize the talk very clearly, we've seen and found out that how we should treat hyponatremia and arterial vasopressin deficiency. I would also like to emphasize to you, all of us, that nowadays we don't do the water deprivation test, we do the co-peptin hyponatremia stimulation test, for which is much easier, and within 1 hour we'll get you the results to diagnose the arginine vasopressin deficiency. Even more important, you should also look for the etiology. If a young person is coming with a clinical picture of polyuria, polydipsia, you should, I think, go further to look at the pituitary because of hypophysiasis and also histiocytosis. And also, not to forget that nowadays we should look for the IgG4 driven diseases. So just to emphasize this, and I think we can ask my co-chairman to ask the next speaker to come.
Assalamu alaikum wa barakatuh. It's my pleasure to introduce the second speaker. This speaker will be Dr. Riyad Mazrouj. She's a consultant technologist at the Tuam Hospital, and she's assistant professor in the College of Medicine and Health Science at the University of United Arab Emirates. Dr. Riyad will be talking to us about the cannulated prolactin, when and how. Because we are running short of time, please, Dr. Riyad, try to stay within the allotted time.
Thanks for the organizing committee for giving me the chance to present today. Hopefully, inshallah, I will stick with 20 minutes. So I will give you an overview about the candidate prolactin test, when and how to perform. So I have nothing to disclose for this talk. The outlines of this talk will be a brief introduction, and then I will go with you through the evolution of the hyperprolactinemia guidelines and how they started to incorporate cannulated prolactin test in the evaluation of hyperprolactinemia. And then we will focus on some of the important studies that had made this change in the guidelines. Then we will speak briefly about how and when and how to perform the test, and then we will end up with some clinical cases before we conclude. So as you all aware, prolactin secretion is versatile, with a maximum secretion during REM sleep, with a typical peak between 4 and 6 a.m. And prolactin secretion can be influenced by several factors, which is among them medication as well as stress, and prolactin is eliminated mainly by the liver and the kidney. It has a circulating half-life of around 20 to 50 minutes. Now, the prevalence of hyperprolactinemia basically depends on gender, mainly due to the symptoms of the patient. And the more women will have symptoms related to reproduction, the more likely they will have hyperprolactinemia. Now, venipuncture is well known to cause transient elevation in prolactin due to stress-induced elevation. And this can make a slight complication during diagnosis and further workup of these patients. So, going back about talking about the magnitude of prolactin has been helpful to predict or to determine the etiology of hyperprolactinemia. And the reason behind that is that we all know that serum prolactin in general do parallel with the tumor cells. However, you could see from this large Brazilian study about the etiology of hyperprolactinemia that when it comes to macroprolactinemia, it makes things easy. However, when it comes to patients with microprolactinemia, the level of prolactin do overlap with other etiologies of hyperprolactinemia, including venipuncture-induced hyperprolactinemia. And therefore, we are really in need for a tool to help us differentiate between patients who have really true hyperprolactinemia versus those who have just venipuncture-related stress-induced hyperprolactinemia. And this is what cannulated prolactin test is coming out, which basically involves repeated blood sampling for prolactin under controlled conditions that we will discuss later. And this test mainly is used to differentiate, as I said before, between physiological versus pathological hyperprolactinemia. Now, I will take you through the evolution of hyperprolactinemia guidelines and how they start to incorporate and recommend this test. Initially in 2006, pituitary societal guidelines, they do recommend single measurement of prolactin to be adequate for diagnosis of hyperprolactinemia. However, they did emphasize the importance of the sample to be taken without excessive venipuncture. And they recommend that if the initial prolactin values were not diagnostic or not high enough to indicate a prolactinoma, then it can be repeated in another day. Again, in 2011, the Endocrine Society guidelines emphasized that a single measure of prolactin is enough to diagnose hyperprolactinemia, or provided that excessive venipuncture stress is ruled out or avoided. However, it only comes to 2022, then when Italian guidelines do clearly mention that they recommend confirming mildly elevated prolactin level with cannulated prolactin test unless the prolactin level was quite elevated, above 80 to 100 nanogram per ml, which is around equivalent to 2,000 milli-international unit per liter. And this again has been emphasized and recommended in the latest consensus, where patients with mild hyperprolactinemia need that is less than 5 times upper normal limit to have accumulated prolactin to differentiate true versus non-true hyperprolactinemia before further investigation and imaging or treatment is initiated. Now, what are the studies that led to this change and evolution in guidelines where they started to recommend this test highly compared to the previous guidelines? This is one of the major studies that have been incorporated in these guidelines. And in this study, which for this and all the other studies I will mention, most of them are retrospective studies. In this study across a decade, they included around 235 patients with elevation of prolactin above normal limit and less than 10 times upper normal limit. All secondary causes of hyperprolactinemia have been ruled out. Macroprolactinemia have also been ruled out. And all these patients went through cannulated prolactin irrespective of their baseline symptoms. In this protocol, they use 2 time points of prolactin, time 0 baseline and time 120 minutes. Of course, the conditions have been satisfied for this test, including doing it in the morning, fasting, quiet room, and IV cannula inserted in antecubital fossa. And as you can see with this test, they could exclude hyperprolactinemia in almost a third of patients. So 28% of the patients had normal prolactinemia, and therefore no further imaging were taken. Though there was a mild difference in referral prolactin level between those with the true versus non-true hyperprolactinemia, there was a huge overlap between both. And among tend to have true hyperprolactinemia and correlated prolactin test. Most of these patients who had imaging, almost 2/3 of them, they had documented MRI abnormalities on imaging. Going further, they tried to look for the cutoff that best predict the utility of this test. And what they found that if the patient has an elevation of a prolactin for up to 4 or 5 times the upper normal limit, then actually you don't need this test because most likely with a specificity of 97 to 98%, the patient will have true hyperprolactinemia. So any patient with prolactin level that is less than 4 to 5 upper normal limit, you need to do cannulated prolactin, and this is where it will be useful. They go further and try to look at the symptoms will help to differentiate whether these patients with true hyperprolactinemia can be differentiated from venipuncture related. And in fact, they found that there is no difference in symptom distribution between those who have true hyperprolactinemia versus those who have venipuncture related, except for galacturia. We did also this study on a lower number of patients. However, here we included only patients who have a twice elevated prolactin level. So, and here 42 patients who had cannulated prolactin after 2 measurements of markedly elevated prolactin level. And again, cannulated prolactin was useful to differentiate those from normal prolactinemia from venipuncture related, and it has been excluded in a third of patients. Among patients who had imaging, almost 82% of these patients had abnormality in pituitary. Most of these abnormalities were microlesions or microadenoma, and only minority had macroadenoma. Again, in this small number of patients, we could not find that there's a difference in symptoms between those who had true versus non-true hyperprolactinemia. In a larger study over 15 years, made almost 1,000 patients had been evaluated for hyperprolactinemia, where almost 757 had cannulated prolactin. And you could see that majority of them who went through cannulated prolactin, almost 50% of them, they normalized at baseline cannulated prolactin test. However, almost 27% again normalized at time 0, at time 60 and 90. It's worth to mention in this study they did cannulated prolactin with 3 measurements, baseline, 60 and 90. Now also they had a few patients, almost 139, who had 2 measurements of elevated prolactin before the cannulated prolactin. And still it was useful in ruling out true hyperprolactinemia and almost 50% or 40% of these patients. Now also they found that prolactin level up to 5 times upper normal limit and above, these patients are likely to have true hyperprolactinemia, and therefore you may not need to do for them the test. And this recent study where they tried specifically to look for the only pituitary abnormalities in these patients with positive cannulated prolactin. They enrolled a high number of patients, again almost more than or almost 60 of these patients where true hyperprolactinemia have been ruled out by the test. Then actually they removed the patients who had other secondary causes, though this should be done before the cannulated prolactin test. So they ended up again with 139 patients that had true hyperprolactinemia and cannulated prolactin test, and among these patients, 76.3, that's almost 2/3 had pituitary abnormality. Most of these abnormalities were microlesion, however they had a good number of patients as well with macroadenoma. Now some other people will criticize this and say, okay, what about those patients who have too elevated prolactin test and have pituitary imaging? I found only this study, which is quite old, but also trying to address this question. So in this study, what they did, they took females who presented with the reproductive of the issue, mainly infertility. And once they have an elevated prolactin test initially, they were repeated under quiet morning, fasted, non-stimulated condition. And among those who who will have elevation in the second test, they will proceed with imaging. So among 1,700 patients, they could confirm the second elevation in around 88 patients. And they did MRI for this, which was seen in almost 60% to be normal. And therefore, still cannulated prolactin may play a better role in detecting the abnormality in pituitary MRI compared to mild elevation in prolactin. So when to perform, now it is clear from all this study that calculated prolactin is very helpful when it is done for patients who have mild elevation in prolactin that is less than 4 to 5 upper limit of normal range. And this is provided that other secondary causes have been excluded and macroprolactin have been excluded. Symptoms may not be helpful in this range to differentiate between those who have a true versus non-true, though galacturia could do, but still you could consider doing or you should cannulate it in these patients. Now, by this time, you could see that there are different protocols, but all these protocols agree on the same principles. First, you need to prepare the patient appropriately. This test needs to be done in the morning, fasting. The patient needs to be calm and rested, and the patient has to be relaxed, supine, or semi-recumbent position. You need to make sure that the patient is not on any medication that could lead to elevation of prolactin, or have thyroid dysfunction, or any stressful condition, including physical activity, exercise, or even pain. And then choose the appropriate vein. The antecubital fossa is preferred for cannulation rather than the hand, and basically because the manipulation with the hand cannula is more, and actually when you draw blood, it's more painful. Some people, they will draw the baseline of blood immediately after cannulation. However, it is better to wait 15 to 20 minutes before doing that, which is almost the half-life of the prolactin level, and to account for the stress of the insertion of the cannula. Now, serial blood collection, this is based on the physiology of the prolactin, which, as we said, have a half-life of 24 to 50 minutes, and it is pulsatile. So, baseline 60, 90, or 120, there are several protocols. I think baseline and 120 is enough and will be more effective, or cost effective. Now, each time point, the blood has to be drawn through the cannula, avoid unnecessary manipulation to minimize the discomfort. Interpretation very simple, and normalization of prolactin at any time point. However, the question, what about the magnitude of change? Is it helpful? Now, this has been analyzed only in one of the recent studies, where they looked for patients, 55 patients, and who had cannulated prolactin, and among these patients, 23 had true hyperprolactinemia, and 21 of them had MRI. They used the delta change of less than 100 milli international unit per liter in patients who already tend to have true hyperprolactinemia and cannulated prolactin, to help them differentiate whether the patient could have an MRI abnormality or not. And they found a positive finding where patients with less delta change in prolactin are more likely to have a positive MRI. I have to admit that this delta change have not been studied on general cannulated prolactin, and I think it's needed to be studied really in patients with true hyperprolactinemia. Now, the challenges around this practice is mainly the cost, but I think it's still much less costly than performing MRI for every patient with mild hyperprolactinemia. Accessibility for the test, usually it is done in an endocrine investigation unit or in any infusion unit where the conditions needs to be satisfied. Patient needs to be calm, morning, and bed available. And I think this is available in most of the secondary and tertiary hospitals. Also, for the best cost effectiveness, as the guideline highlighted, this has to be done only in patients, a right patient with mild hyperprolactinemia, when prolactin elevation is less than 4 to 5 times the upper normal. So I will end it up with the two cases. So hold on. So this is the last slide. So to start with the first case, this is a young lady, 23 years old, who has suffered from mild hyperprolactinemia, ranging between 700 and 1,000. And macroprolactin was ruled out. She had regular periods, no galactoria. She had intermittent headaches, no interfering medication. Actually, before referral, she had MRI done outside, which reported no pituitary abnormalities. She had first cannulated prolactin test, which showed a mild hyperprolactinemia at baseline. And you can see that her prolactin level mainly related to the test. However, you can see that there was a significant change or drop in prolactin level. And actually, when I questioned her, she had abdominal pain during the test. However, she didn't endorse this to the nurse. So what we did was read the test, which showed completely normal prolactin level, and therefore this patient does not have true hyperprolactinemia, and actually she has spontaneous pregnancy. Case 2 is a 34-year-old female who was referred for mild hyperprolactinemia again. Macroprolactin ruled out and no interfering medication. She had menstrual irregularities with oligomenorrhea. She had no galactoria and she is known to have migraine. No interfering medication to explain the mild hyperprolactinemia. She had cumulative prolactin that document mild 2 hyperprolactinemia, and MRI pituitary showed microadenoma, and she was commenced with medical therapy. So to conclude, I hopefully could convince you that the calculated prolactin test is very useful to differentiate very puncture-induced versus true hyperprolactinemia, and therefore avoid unnecessary imaging and treatment. And it is useful to be performed in patients who had prolactin level of less than 4 to 5 normal limit after excluding other secondary causes and macroprolactinemia. And the test showed almost 2/3 of cases to have macroprolactinemia, and based on this result of true hyperprolactinemia, 60 to 80% had pituitary abnormality. And this to be performed in the appropriate time under the right condition, and maybe the future study will try to address the delta change, and it is utility to differentiate those patients who will need MRI system. Thank you for your listening.
Thank you, Dr. Ryan, for the informative and the painted presentation. I'm sure some audience might be have the any question, but unfortunately we are running late. So if you have any question, you can approach it during the session. Now we have to move with the last speaker. For the session, Dr. Adnan Ajmal, consultant cardiologist at Cleveland Clinic, Abu Dhabi. He obtained his clinical fellowship in the Carnegie at the University of Michigan. He focused primarily on his work on pituitary and the adrenal diseases. Over the next 20 or 25 minutes or so, he will be discussing management of resistant prolactinoma. Dr. Adnan, the floor is yours.
Thank you for giving me the opportunity to come and present today. So my talk today is resistant prolactinomas. I have no conflict of interest. These are the references I got the talk from. So let's take a step back and see what we want to talk today. We'll look at the degree of resistance and then how that interferes with our ability to achieve our therapeutic goals. And if it does interfere our ability to achieve therapeutic goals with prolactinomas, then what are our options? So we have two targets. One is related to prolactin excess, and then the other is related to the mass effect of the headache and visual field deficit and hyperpituitarism. And related to the prolactin excess, we have the very well-known causes, well-known effects known to the audience here, hypogonadism primarily, and then all the other related issues related to hypogonadism. So, what is drug resistance? So, we have to make sure that patient has good tolerance, they are compliant with the medicine, we are able to achieve efficient doses, and still we are not able to reach the therapeutic target. And it can range from complete resistance, and then some people can be very sensitive. And then the main medicine we're talking about is the dopamine agonist here. So we'll see how it affects our anti-hormonal and anti-tumoral targets. So people can have different degree of resistance. We can have some patients who totally not respond at all to one medicine, but then help switching to a different one. Or patient respond initially, then stop responding later. Or they can have selective resistance, meaning that we achieve the anti-tumoral effects, hormonal effects, but not achieve the anti-tumoral effects. So what is the resistance criteria? Few have been proposed on the basis of anti-hormonal effects, meaning we cannot normalize prolactin, we cannot reduce prolactin enough to achieve ovulation, and then, or at least 50% reduction. Few have been used the criteria. And then, what is the adequate dose? It is around 15 milligram or more for bromocriptine, 2 milligram or more for cabergoline, and not much used here, but 225 micrograms for phenolphthalein. Just going back to the second point, that I think the issue with achieving ovulation is very different for many people, and the threshold is different for different females. Mild improvement can restore menses in some, and fertility, but for some you have to really normalize the levels. So that looks like a weaker kind of target for basing the criteria on. Now, criteria based on the tumor. Now, it's either we see changes in the maximum diameter, height, surface, volume. Favorable responses are reported somewhere around like 25 to 80% shrinkage. And now we have to also see that this doesn't apply much if the tumor is already small. If it's an 8 millimeter, 9 millimeter, 1 centimeter tumor and there is no optic chiasm pressure, then it doesn't really matter much that how much shrinkage we achieve, if that's really the goal here. Though it is a goal in long term to get the patient off the therapy, but at least in the short term, that might not be a goal. And then what's the appropriate response? 30% reduction in the height or 50% decrease in the coronal surface. These are the two proposed. So I think looking at all the literature, there is no uniform criteria, but few things that can be used in our clinical practices is, one, we cannot achieve a normal prolactin or maximally tolerated dopamine agonist, and there is at least a lack of 50% reduction in the tumor size. So these two, if we're not able to achieve them, we can fall into resistance. The maximum dose reported in the literature is somewhere around 3.5 to 4 milligram per week. Now, some cases have been used higher dose, but then some literature is there that the benefits after 3.5 milligram per week are not very clear, unless it's like individual cases. And at least 3 to 6 months of time is needed to see or call it a resistance. It's a little difficult to call it resistant earlier than that. Now, looking at what's reported in terms of resistance, so bromocriptine, patients using bromocriptine have resistance around 30%, cabergoline less than 10% for microadenomas, for macroadenomas, a little bit higher number for cabergoline is around like 17%, and for volume reduction for bigger tumors, cabergoline doesn't achieve the 50% target in 30% of the cases. Now, between bromocriptine and quinidolide, pretty similar, not much different between the two drugs, but still, quinidolide can overcome resistance from bromocriptine in some cases. Now, this number is coming from this overview of literature here, where we can see that various studies using both micro and macro prolactinomas, looking at prolactin normalization is around 90% with cabergoline, and tumor reduction of 50% or more in 71% for smaller lesions. Though for smaller lesions, sometimes tumor reduction, other than the long-term goal of getting them off the medicine, doesn't really need it in the start. And then for bigger lesions, the number gets a little smaller at 83% for prolactin normalization and pretty similar for tumor reduction. What are the risks that lead to resistance? And we'll look at some of them a little bit more detailed, but some that stand out is young males and large invasive macroprolactinomas. Then some of the ones are very obvious, like elevated Ki67 index or like low ER alpha expression is also been reported, and then down regulation of TGF beta signaling cascade in downstream pathways. So the two that stand out in the previous were the gender and the invasion. So here, this looks at 92 cases. They did not normalize at a standard dose of 1.5 milligram per week, but now most of us know that this is not a very high dose. Majority of our patients are around 2 milligram per week. So I think from this study, still there is space to go up a little bit. But what they found is high prevalence of male who have resistant tumors. These are bigger tumors, 67% of macroprolactinoma, 16% of giant lesions, and then 52% had invasive. So invasion, large size, giant, male, they all are risk factors for resistance. Now, looking at giants alone, 60% only achieve normal prolactin and 40% do not achieve prolactin. But there is a silver lining here that even in the 40% who do not achieve prolactin, they still get a significant partial responses to going back to the original thing that it all depends on what's our target. If the fertility was a target and then in 40% significant partial response, the fertility might get restored. But then when it comes to tumor reduction, there was only like 74% who had more than 3% reduction in bigger lesions. So this is a case we saw here in the clinic. So it's a young male who presented with a very large tumor, and then he was not found to be a good surgical candidate because of the complexity of dealing with this lesion and the potential for side effects, especially the neurological one. His initial prolactin was greater than 4,700 in nanogram per DL, and then he was started on low-dose cabergoline, and then over the next 5 months, we escalated it to 2 milligrams per week. And on the right side, you can see that initially he presented with third and sixth nerve palsy, that improved, and then his visual symptoms are very, very significantly improved. He still has persistent hypogonadism, but we can see on the right side that the tumor keeps on shrinking. So even for giants, and we'll see where this leads to, but even for giant tumors, for each individual case, the outcomes can be very different. So starting with the dopamine agonist may be the way to go. Now, what about the complete resistance. So only 6% in this one study of 122 patients showed that there is complete resistance even at a dose of 3.5 milligram per week, and that is where the number coming from. That beyond 3.5 milligram per week generally might not be very beneficial, but individual cases can be there. Now, the secondary resistance is something that needs to be paid attention to. It's hard to sometimes kind of label them as secondarily resistant, but in literature there is only not a whole lot of cases, just handful. But this can suggest pituitary carcinoma, so we need to pay attention to secondary resistance. So, and then in these lesions, they can have adenomas with either worrisome features suggesting atypical adenomas with high proliferative index. So that might the path show, but we should have a very high index of suspicion for them to be pituitary carcinomas. Regarding the molecular basis of resistance, mainly is around the dopamine receptor. That's our main target where dopamine agonists work. And that's the basis for some off-label use of these medicines in non-functional tumors. So you can see either with the reduction in the receptor expression or downstream pathways are affected, or there is more of shorter isomers. Some additional ones are on the left side are, number one is more of related. So the left sides are related to the dopamine receptors. We can see that there is messenger RNA folding alteration leading to dopamine agonist resistance. In the second one, in the green one, we can see that there is more of a longer isomer, which can also lead to resistance. Then we have lack of beta-arrestin that can also lead to resistance. Number 4 are some skeletal, some cytoskeletal issues, especially the FLNA involved in the regulation of membrane expression and signaling. And then if that's not there, it leads to lysosomal degradation of the receptors. All these things on the left side, they lead to increase resistance through the receptor. And on the right side are only processes that increase the invasion, increase cell. These are mainly around the inability to repair the DNA. So you have increased cell migration, there is increased invasion, reduced apoptosis. All these lead to invasion and eventually resistance. But then again, if they have more of these pathways on the right side, you might see them in the carcinomas too. So what can we do in such scenarios? We can transition to cabergoline. People who are initially resistant to bromocriptine, when they're switched to cabergoline, around 80% do respond. This study shows that 58 cases, 70% responded when they were switched to cabergoline. But they need a little bit higher dose, which makes sense. Generally, like the usual dose of 0.5 milligram per week is not enough, and you need, like in this study, 1.5 milligram per week. And again, looking back, true, like complete resistance was only seen in 2% cases. Now, in this study, they used just proving the point that bigger lesions are more resistant. In this study, 80% of the tumors were macroprolactinomas, and 60% needed surgery, and 10% needed multiple surgery, and even 14% needed additional radiation treatment. Just to prove this point that resistance is real, and we do have to pay attention to that. Even if we factor in our various therapeutic targets at different stages of patient care. So we can increase the cabergoline dose if the initial dose is not working. In this study, they used greater than 2 milligram per week in 11 cases. 4 patients needed 3 milligram, 2 needed even 4 milligram, 9 milligram, up to 12 milligram in individual cases. And we all have patients in our practices using somewhere around like 8 milligram per week sometime to achieve the therapeutic goal. As long as patients are not having the side effects and we are doing the yearly echoes and everything looks good with the valvular cardiac valves and no issues with fibrosis like presentation of shortness of breath or any radiographic changes, and patients are well informed, I think this is a good strategy in carefully selected patients who can go up on the higher dose. But then again, generally, looking at the literature, 3.5 milligram per week is where we should see the benefit, and if we're not seeing much benefit, then maybe not a whole lot point going for everybody going up this weekly dose. So I think one thing is important that we get to 3.5 milligram per week and then we kind of give it a little time, 3 to 6 months, and see if we are able to achieve our target. So this is important, reach the dose and give it time. Now, for some cases, surgery can be considered. Debulking helps because then it increases the sensitivity to dopamine agonists, and not, even if we're not able to get the gross total resection, it's still worthwhile in some cases, especially if they have plans for fertility. Now, radiotherapy takes time, can be considered, takes time, and the response in best case scenario is 20 to 40%, and it's very similar around fractionated or stereotactic. And it takes time, like 3 to 10 years. But as we can see that this 20 to 40% benefit from radiation can be increased to 80 to 90% if we put them back in the medicine. So again, either a surgery or radiotherapy, maybe going back to the medicine is something we also need to counsel our patient, because sometimes patients are under this impression that if they'll go to these therapies, they'll not need the medicine. We have to tell them that they still might need medicine, but on a much lower dose. And then this is the anti-hormonal effect, but for the tumor reduction, it's different numbers have been reported in the literature, somewhere from 30 to 20% and 23 to 90% for stabilization or volume reduction. Quickly on the issue of somatostatin receptors. Now, prolactinomas do have them. Mapping helps because if they have more of the type 5 than the type 2 or the type 1, they can be candidates for the second generation vascular-type. And in these two cases, in first case, patient did not respond to bromocriptine and cabergoline with various maximum doses, even 7 milligram per week. Even did not respond much to lanreotide, but then when they were switched to pasireotide, they did have almost 100% normalization of the prolactin and 72% reduction in the tumor size. So this is another possible therapy that can be tried. And then in the second case, again, they went from dopamine agonist directly to pasireotide, and the patient has been doing very good after 7 years with normal prolactin. Now, the first generation response has not been as robust as the second generation. So the question is that, is it just the receptor, or it is the orientation of the receptors, or are there any other downstream pathways that decide that why patients are responding to the second generation and not so much to the first generation? So a little bit about the estrogen expression. Studies have reported that if men have more alpha ER expression, they have bigger tumors, resistant tumors, and poor prognosis. And some of the serums have been used. Like say in these couple of studies from 10 patients, they used tamoxifen, and in the last study they used raloxifene. And in the tamoxifen there was better response of 35% reduction in the prolactin. Now, sometimes they can be combined with dopamine agonists in some of the research studies and have shown benefits too. Metformin, some benefit, again very little volume. Combination might help with bromocriptine and prolactin, bromocriptine and metformin normalizing at 40%, or we have some mTOR inhibitor targets too. Again, the experience with temozolomide is small, but what's important to know is it's very important to do the MGMT identification, because this helps, because these the status is important to be known by immunohistochemistry. And the other additional point is that some patients will respond very good to the first cycle, but then if the tumor recurs, the response to the second cycle is not very good. So you need to be careful about thinking about the second cycle of temozolomide. Now the second point is that if there is no response in 3 months, then keep going might also not be very helpful. So quickly going to the last slide is one proposed pathway that we have a resistant macroprolactinoma. We can switch to cabergoline at conventional doses. That we're using bromocriptine or quinabolide. If we control, great. Still resistant, we can go up to 3.5 milligram per week. And still resistant, we can increase the dose further or wait on 3.5 milligram per week, depending on how urgent is the situation. And still no response, then we can consider debulking, plus minus using the dopamine agonist, but also doing the proliferative markers and molecular biology on the tumor. No controls, you can on the right side can consider radiotherapy for aggressive lesions or temozolomide. And then even after surgery or radiotherapy, we can go back to reinitiating dopamine agonists. Still have benefits. Thank you.
Thank you, Dr. Arkan, for the engaging and insightful presentation. Well, we can have at least 2 burning questions. Short question, short answer, please.
Or the tumor stabilize? Like mutator, or they stay definitely on this big high dose?
So one case that comes to my mind is a young 40-year-old who had a bigger tumor, and then he took the medicine for 3-4 years, high dose 8 milligrams per week, tumor completely disappeared, but prolactin never normalized. Prolactin stayed around this 80, 90, 100, and then he's still hypogonadal. So what we decided to do is, we said we'll live with this 80, 90, but 8 milligrams per week is not a very sustainable dose. He was dizzy also, he was having side effects. So we have cut it down to 4 milligrams per week after a year and a half. He's still at 80, 90, that hasn't changed. And there is no tumor reappearance, and then we put him on testosterone, keeping an eye on the estradiol. So we are not trying to achieve reverse the hypogonadal status with dopamine agonist anymore, because we think that's not achievable on this dose. So we cut it down after a year to 4, and keeping the prolactin at 80, tumor not reappearing, and giving him the testosterone. So a little complex answer to your question, but I think it all depends on each case. Then where is the therapeutic goal? So because the tumor is not there, so I think we can have this luxury of cutting down on the dose.
The time. No, thank you very much. We have actually touched on a very important area. You have alluded to the 2 cases when we switched to the first generation somatostatin receptor ligand. Secondly, the first one was started on first generation and then noticed. Yes. Are you aware of any ongoing studies that's in the time? Because it seems to be very promising actually to tackle this very important.
No, I'm not aware of any ongoing study right now. I think literature I could find only these couple of cases, but there might be ongoing study. I'm not aware of it.
I think Musa coffee. Just quickly, Musa, you have some cases. Yeah, still on the result. Yes. There is a lot of studies going on. I'll tell you about. Thank you.
We'll see you back at 1:20.
Thank you so much.
خالد نبدأ؟ السلام عليكم ورحمة الله وبركاته. We thank you for attending the afternoon session. Inshallah you will find it also interesting and exciting as the morning session, and we'd like to thank Dr. Khalid Al-Dahmani for preparing this course for us as endocrinologists and also other specialties. So I'll be chairing this session. My name is Dr. Abdul Al-Qutaisi. I'm from Sultan Qaboos University Hospital in Oman. I'll be co-chaired with Dr. Hassan Jamal. He's from As-Salmaniya Medical Complex in Bahrain as well. And our first esteemed speaker, and actually I'm honored to introduce Dr. Tariq Al-Had. Dr. Tariq is a senior consultant in Hamad Medical Corporation, and he's actually now the founding member or chairman for the pituitary chapter, part of the GAED association. Dr. Tariq is actually fully trained and got his training initially in Sudan, and then he traveled to United Kingdom in Edinburgh, Dundee, and London, and he got his specialization and CSST training there. After that, he moved to King Faisal Specialist Hospital. He worked for 2 years. And finally, he joined Hamad Medical Foundation as a senior consultant in endocrinology. And he has special interest in pituitary. And I said he's putting all the endocrines specialized in pituitary as one forum or one group. He will talk to us today about the consensus update on diagnosis and management of acromegaly. The floor is yours, Dr. Tariq.
For the patients who undergo either stereotactic surgery or fractionated surgery do show actually quite high prevalence of getting into remission, but unfortunately this is not without actually price, as 1/3 of them they do actually develop issues related to hypopituitarism, as well as, of course, there is well perceived risk for cerebrovascular events as well as other tumors, but this is rather extremely rare. So, when it comes to the issue of the medical therapy, the injectable somatostatin receptor ligand is still actually are very helpful, and we do have, fortunately enough, not only first generation somatostatin receptor ligands, we do have the second generation somatostatin receptor ligands, and the certain denominators has been actually shown to predict the response to the conventional first generation somatostatin receptor ligand, especially female sex, lower IGF-1 level, as well as the hypo-intense actually characters of the growth hormone secreting tumors, which generally usually correlate with the presence of the densely granulated tumors. There is some recent evidence, and you will hear more about this, that there might be a room actually to make more spacing for the interval of the dosing of lanreotide per se. So nowadays you can actually extend the dosing interval more than 6 weeks up to 8 weeks in selected patients, but you have to do this very carefully. And as I mentioned, second generation somatostatin receptor ligands, primarily basirotide, has come actually strongly to the fore, and it has actually transformed the control as well as remission rate of many patients. And we do have also some actually local data from Qatar to back this. However, this is not usually without significant price from either triggering diabetes or worsening pre-existing diabetes. Bigvizomant, which is not generally widely used in this part of the world, but according to what is known as the ACRO study, the 10-year follow-up showed that there is actually quite favorable 73% biochemical control when actually it has been compared with other things. Not only that, but bigvizomant, when it is used, actually does not worsen the pre-existing hyperglycemia, nor actually it can trigger it. And those actually with diabetes, as well as those who are with higher BM, may require higher doses of bigvizomant. And it might be interesting actually to hear your sort of local as well as the regional experience with bigvizomant later on. Part of the beauty of this actually consensus statement, it went actually further to suggest that you can actually combine treatment of bigvizomant with actually somatostatin receptor ligand, and that low-dose octreotide or lanreotide could be actually combined with bigvizomant, and this might be cost-effective and more efficacious patients actually, but patients of course has to be selected. Not only that, but the combination of basirotide plus bigvizomant can also yield far much better control rates that exceed around 70%. However, the addition of bigvizomant to the basirotide does not actually modulate the preponderance of basirotide to cause actually either de novo diabetes or worsening of pre-existing diabetes. And of course, patient selection has to be carefully made. Lastly, I think it will be interesting also to know whether oral octreotide has come recently to this part of the world, not to my knowledge, but this again has been actually endorsed and it has been actually recommended to be used, and it was actually recommended that it could be suitable for patients who have demonstrated complete or partial biochemical response to the injectable somatostatin receptor ligand, especially the first generation. However, there is lack actually of data to show that actually oral octreotide is currently recommended for patients who have got actually certain characteristics related to their tumors, and whether there is any actually correlates which can guide us which patient actually will actually benefit from this. And of course, the dosage has been suggested to be 40 milligram per day given in divided doses. However, there is some evidence to suggest that the dose has to be actually escalated up to 60 milligram, and that oral octreotide could be initiated at the time of the previously scheduled somatostatin receptor ligands. I think this is the main what has filtered out. Despite that, this data has been drafted nearly 3 years ago, the consensus actually statement as I meant, but I'm sure, with more and more available recent data, we might actually see more new consensus updates coming to the fore. I think with that, Mr. Chairman, I will stop here and welcome any questions.
Thank you, Dr. Tariq. Any questions to Dr. Tariq? Thank you for this informative lecture. Did they change the cutoffs, the cure rate now in the new consensus, or still the same, less than 1?
I think very little difference so far. Very little difference.
Should be less than 1 times upper limit of normal?
It should be within the normal reference range, the IGF. They have moved away from the growth hormone now. It doesn't actually make big difference. The most important denominator is matched age as well as sex sort of range, and you have to consult actually closely with your lab, because sometimes things might be a bit more different.
You have a question then?
day one. No, I think you have to wait for at least sort of 6 weeks in order to get a bit more actually helpful outcome. But in some patients, you might get an idea actually in the first few days following your operation. But ideally, as they have suggested, you have to wait for 6 weeks, and even there might be some selected patients who might actually do not show any evidence of remission except after a passage of 3 to 6 months. Even sometimes, complications like DI tend to be quite delayed. I remember I have seen a case who has actually been discharged and he has been actually fine, no evidence of DI, but he came nearly 2 months plus only complaining of nighttime nocturia, nothing else. And this has been distressing. So when I checked his, plasma and urine osmolality, he had a sort of a mild DI, and he got better actually just with a single evening dose of desmopressin. So I think, you have to be very careful sometimes to pass a sort of a conclusion immediately following the operation. Dr. Ryan?
Okay, Dr. Go ahead, please. Yes.
Oh, sorry, تفضل.
In most patients with chronic liver disease or liver cirrhosis, so what is the interpretation value?
I think it will be difficult, and in these circumstances, you have to resort to other conventional methodology like, gross hormone response to OGTT. And even you have to resort to this sometimes to sort out some dilemma where some fiasco might happen. Sometimes technicians might put the wrong actually age as well as, age group as well as sex sort of reference for IGF-1. I remember I had a patient not long time ago where I realized that he has gone into remission. His IGF-1 actually normalized from around 800 down to within normal, around 150 something. And then on follow-up, his IGF-1 has been reported as just being showing slightly, high. And I repeated that and it was still high. So if you just follow the dogma, you say, well, okay, this patient might have got recurrence. But I felt, well, okay, I would like just to back this up. And I went and I requested gross hormone actually series with an OGTT. And that showed actually flat response. And I just have to go back to the lab and say, well, okay, I think the guy might have.
Dr. Ryan, last question.
Yes, 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 yes. But I think again, away from dogma, there will be deviations, and we have to keep an open mind. So you might have just to combine certain variables in order to reach a conclusion. And when we went actually, and even we repeated the MRI scan, this guy has shown no evidence of any residual tumor whatsoever.
شكرا جزيلا دكتور طارق.
الله يبارك
Thank you very much.
Thank you.
Good afternoon, everybody. It's given me a really great pleasure to be here with you today, and I'd like to thank Dr. Khalid and Dr. Tarek to give me this opportunity to co-chair this session with my colleague Dr. Abdullah. Our second speaker will be Dr. Aisha Fizemi. Dr. Aisha, she is an endocrinologist consultant. She is specialized in neuroendocrinology in King Saud University Medical City in Riyadh, Saudi Arabia. Dr. Aisha, she is a fellow of American College of Endocrinology, and she is certified training in neuroendocrine from University of Western Ontario, Canada, and she obtained American as well as the Canadian Board of Endocrinology. Dr. Aisha, she has many studies as well as research in the field of endocrinology, and she will give us a talk about the medical management of acromegaly. Dr. Aisha, welcome.
Thank you, Dr. Hassan, for your kind introduction. Assalamu alaikum, everyone. No. Other one. The other presentation. Yeah. So I would like to thank the organizing committee for their kind invitation to be part of this useful and fruitful course. I was given the task to talk about medical management of acromegaly. These are the outline of my presentation. I will be touching a little bit about the epidemiology of acromegaly in general, predictor of biochemical persistent disease after the surgery, and then through my presentation, focusing on medical management of acromegaly, I will be using this latest consensus guideline that was published in 2022 by Pituitary Society Group. We know that acromegaly, in general, it's a rare disease. It's not that common. The average age at the time of diagnosis is usually late, between 40 and 50. And there's no difference in terms of the gender dominant, in terms of the incidence of the disease. And it's based on the previous data, there is always delay in recognizing the disease unless the patient presents late 10 years after the diagnosis. What about also duration of the disease? The longer duration of the disease, the more and the adverse consequence or side effect the patient develops. Besides the complication, the physical changes that patient noticed as a part of excessive growth hormone production, in terms of physical change, structural change related to the skeletal manifestation, resulted in arthritis, osteoarthritis, and arthralgia. There are cardiometabolic complications. That's the reason we need to recognize this disease in order to reduce cardiometabolic and cardiovascular mortality related to this disease, like diabetes, hypertension, also cardiomyopathy, and ischemic heart disease. Besides also incidence of malignancy. Not only that, we always focus on the cardiometabolic consequence of the disease and other manifestation like obstructive sleep apnea or malignancy incident. Also, the quality of life of the patient is affected in general. Despite having a good control of the disease, patients are still suffering in terms of the mental change, like they are having depression. It's very common in those population, and also a negative self-image about their image. And also in the clinic, when you see those acromegaly patients, you could tell from the first time, even if they are actually in remission 10 years after treating their disease, they are still having residual change in their physical appearance. As I said, there's always delay in diagnosis of this disease because it's overlapping with other clinical presentation of other disorders. For example, a patient might present with irregular menstrual cycle and infertility as a first manifestation, so they go to the obstetric gynecology for that in terms of the female, or male they go and seek fertility issues regarding that. Also, a patient may be the first presentation with uncontrolled diabetes and hypertension. They seek help of the family physician, and for that reason they are unrecognized and resulted in the delay in the diagnosis. But this is not happening anymore. Like you can see over years, there is actually improvement in the delay of the diagnosis, and it's becoming shorter, less than 5 years. As I said, it is like overlap between the clinical presentation and manifestation of acromegaly with other presentation like polycystic ovarian syndrome. And females tend to actually come later, they present later of the disease, and the reason behind that because of the estrogen effect on IGF-1. It tends to normalize or falsely lower IGF-1. For that reason, it's very female, they tend to present later on. Also, if they present with irregularity in the cycle around the perimenopausal age, they are missed. So when to screen for acromegaly, I think this is actually covered by Dr. Tara. So if you have obvious clinical manifestation on the patient, or if they present with a cluster of comorbidities like sleep apnea, type 2 diabetes, arthritis, carpal tunnel syndrome, or any patient with a pituitary incidentaloma, we screen them for acromegaly. What is the goal of managing acromegaly? The goal is to achieve biochemical control, decrease clinical and cardiometabolic manifestation, decrease the tumor size, decrease comorbidity and mortality. So these are the consensus of the Pituitary Society group that was published in 2020 in Review Endocrinology Metabolism Journal. I will be using it as a guidance during my presentation, focusing on the medical management of acromegaly. We know the surgery is the primary treatment in patients with acromegaly. It enhances the response to medical therapy. So we know the surgery, transphenol surgery is the primary treatment, and there are certain predictors before the surgery and after the surgery that help you or guide your management plan after the surgery in terms of medical options. What are these? The younger patient, they actually tend to have persistent disease, younger female, high baseline IGF-1 and growth hormone level, larger tumor, cavernous sinus invasiveness predict the persistent disease after the surgery. What about after the surgery? What are the predictors of persistent disease? Serum growth hormone after the surgery. So one of you was asking the question whether we can use growth hormone 24 hours after the surgery as a predictor of remission. Yes, we can use the growth hormone 24 hour to 48 hour after the surgery to predict remission. If it is less than 1, most likely the patient will go into long-term remission. But if it is higher, then less likely. The IGF-1 assessment will be done 6 weeks after, it will be done 3 months after the surgery. What about post-operative OGTT? It can help you to predict the response to medical therapy, whether there is also persistent disease, and histopathology type of the tumor itself predict the persistence of the disease. Also, radiological appearance can predict the persistence of the disease after the surgery, like the size of the tumor. Microadenoma, the remission rate 90 to 100%. Macroadenoma, between 50 and 70%. What about the cavernous sinus invasiveness? Using NOSP grade 3 and 4 predict the persistence disease after the surgery, where 1 and 2 most likely predict the remission. These are type of medical therapy based on the classes of a drug. We have drugs that target pituitary, like somatostatin receptor ligand and dopamine agonist. And also we have growth hormone receptors that act at the peripheral level of the receptors. So these are over the years, over the last 20 years, I would say, there was an evolution in terms of the medical therapy of acromegaly, starting with short-acting octreotide till what we have now available, oral octreotide that was already mentioned by Dr. Tariq earlier. So regarding medical therapy, after the surgery, the first line of therapy is to use somatostatin ligand, octreotide or lanreotide, based on this guideline. Or also you can use second generation somatostatin receptor ligand as a first line therapy after the surgery. So what is available commonly in most of the center is first generation somatostatin ligand like octreotide or lanreotide. Okay, so looking at the difference between first and second generation somatostatin receptors. So you can see, I don't think it's working. So the difference between somatostatin receptor, first generation somatostatin receptor 1 and 2, somatostatin receptor 1 act on somatostatin receptor 2, where second generation somatostatin receptors ligand effective because it acts in multiple receptors, 1, 3, and 4, and 5. So it's more effective in terms of its action on different receptors. The other agent I talked about, dopamine agonist, has minimal effect in terms of the hormone control, growth hormone control, and at the level of the peripheral tissue, growth hormone receptor antagonist. So we know that first generation somatostatin receptor agonist improve biochemical control, IGF-1 and growth hormone in more than 55% of the patient and reduce the tumor size in up to 80% of the patient, and it is in general safe medication to be used. Regarding the response to the therapy, so it was mentioned earlier that we have prolactinoma resistant, and there is certain definition for those people who are resistant to dopamine agonists. The same thing happening with first generation somatostatin receptor agonist. So we can define it lack of response after using somatostatin receptor ligand for 12 months of duration. Full response if we have normalization of growth hormone IGF-1 with more than 20% reduction in the size of the tumor. What about partial response? If you have 50% reduction in the level of growth hormone and IGF-1 and or more than 20% reduction in the size of the tumor. Full response if we don't see normalization of growth hormone and IGF-1 on no reduction in the size of the tumor. What about using somatostatin receptor ligand as a first line of therapy without the surgery? There are 4 randomized trials assess effectiveness of using somatostatin receptor octreotide as a primary treatment before the surgery. As you can see in this graph, in different studies, using somatostatin ligand octreotide was very effective and enhanced remission on those patients using it before the surgery. But in general, we have mixed data regarding using octreotide as a first line or first generation or second generation somatostatin receptor as a primary treatment for patients with acromegaly without the surgery. So it's generally not recommended. The only indication to use it as a primary line of therapy in those patients where the surgery is contraindicated, or we have larger tumor, invasive and inaccessible, or we have patients having comorbidities and they are not candidate to undergo surgery due to anesthesia risk. So what if there is no improvement in terms of the response to first generation somatostatin receptor or second generation? What do? It's the same thing as it was mentioned earlier with prolactinoma, as it was mentioned by Dr. Ajmal. Go and increase the dose. So don't hesitate to go up with the dose of octreotide or beziriotide. So you can go up and increase the dose. There are more than 4 or 5 studies assess the effectiveness of increasing the dose versus increasing the frequency. I.e., if I have lanreotide or octreotide and the frequency every 3 weeks compared to those medication given every 4 weeks, increasing the dose was very effective in that study at 12 weeks. The pointer is not working, sorry. At 12 weeks, increasing the dose was more effective with lanreotide compared to increase the frequency of the dose. Generally, first generation somatostatin receptor and second generation are safe, except for mild GI symptoms and greater reduction or normalization of IGF-1 and growth hormone. What about combining somatostatin ligand with cabergoline, which is dopamine receptor agonist? We have data showing its effectiveness and improve general control in 33% of those patients, with 50% of those patients achieve normal IGF-1. What about bigvusumab? It has different mechanism of action. It acts at the level of the receptors. According to ACRO study, IGF-1 was normalized in 53% of the patient at 1 year, and in 75% of the patient up to 10 years. So this tells you how it is safe to use it up to 10 years of duration. It was mentioned earlier by Dr. Tariq, the major side effect, regrowth of the tumor, it was reported to be about 7%. What about increased liver enzyme? It was about 9% on this population. Generally, it is safe, except of the local reaction at the site of the injection, increased liver enzyme, so you have to follow up those patients. In general, using somatostatin receptor ligand first generation, most of the patients, more than 70% of them, despite having good biochemical control, they are still having symptoms. i.e., like the headache will not be controlled, arthralgia will not be controlled, even if you achieve biochemical control. And they are still having, feeling unwell and poor quality of life, despite having good biochemical control on first generation somatostatin receptor agonists. So for that reason, second generation somatostatin receptor ligand, bezirotide, is very effective. It acts at the level, different level of the receptors. And that was actually different dose of bezirotide compared to active control group in that multicenter randomized trial, Paula trial, where they compare bezirotide 40 and 60 milligram with octreotide and lanreotide, and it showed actually significant reduction in terms of the biochemical control and tumor size reduction, as you can see from this slide. And also improve in general symptoms like the improvement in the headache, the fatigue, the arthralgia that you don't achieve with the first generation somatostatin, octreotide or lanreotide. And that was actually obvious from quality of life questionnaire or score, where there was significant improvement after using bezirotide. What about the side effect? The only problem with bezirotide, the hyperglycemia. In general, it wasn't a major issue, and it was correlated the incidence of hyperglycemia to the age of the patient. So the older the patient, the more risk of hyperglycemia as a side effect. Also, baseline, the presence of hypertension and dyslipidemia. So older age, diabetes and hypertension and dyslipidemia, and baseline hemoglobin A1C are predictors of incidence of hyperglycemia in those patients using bezirotide. Bezirotide effectiveness in medically naive patients, even if they haven't received surgery, it was more effective in terms of the biochemical control at 12 months, and even tumor reduction compared to octreotide. This is the head-to-head trial comparing bezirotide with octreotide that showed more effectiveness, 80% reduction in the size of the tumor in 80% of the patient compared to 77% of those patients in octreotide, and also biochemical control. The next step, so if you can use combination, so we can combine bigosumab with somatostatin receptor ligand like bezirotide or octreotide if we don't achieve good control. Combination with bigosumab showing normalization of growth hormone and IGF-1 in 80% of the patient. What about oral octreotide? This is recently approved in 2020 as another alternative agent to control or to maintain, this is very important, to maintain the control of the disease. All those patients actually were controlled by injectable medication, octreotide and lanreotide, and then you can switch them to maintain that control into oral octreotide, but you cannot use it in, as a first-line medical therapy on those patients. It is just to maintain your control after using the injectable one, and this was supported by two trials, SHASM trial and Chiasma optimal trial, where actually those patients on injectable regimen of octreotide were switched to oral octreotide over a certain period of time, and it was found that they maintain the control, biochemical control. So we can use oral octreotide to make the life of the patient easier and encourage the adherence to the medication by using oral octreotide to maintain the biochemical control. Towards precision medicine, so when you manage acromegaly patients, so that's the reason of the different agent and medical therapy is to tailor your medical therapy based on the certain predictors that we are having for certain disease. So patient characteristic is very important to decide which one to use, first generation somatostatin ligand or second generation somatostatin ligand in those patients, using molecular marker, genetic factors, and also T2 intensity on MRI and granularity of the tumor. So in those patients with MRI, so you look at the MRI after the surgery, and you look at the intensity of the tumor in MRI. So those with hypo-intensity tumor on T2, they showed good response to the first generation somatostatin receptor ligand, octreotide, liraglutide, and those with iso-intense or hyper-intense tumor on MRI, you can predict they will respond very well to second generation, which is bazirotide. What about the granularity of the tumor? So we need to use histopathology in order to guide our management plan, whether to choose first generation or second generation. So those those patients who have hyperdense or densely granulated tumor, they would respond to octreotide or liraglutide, first generation somatostatin. But if you have sparsely granulated tumor, then you will go and use bazirotide as a first line of therapy in order to enhance biochemical control. So the guideline actually, the recent guidelines have changed towards personalized medicine. So when you manage the patient, you don't use one size fits all. So you have to decide what to choose, first generation or second generation somatostatin receptors, based on the biochemical marker, genetic marker, and molecular marker, and histopathological features of the tumor. I will touch update on the recent study regarding medical management. So ACROBAT study, so you have to know this study, that evaluated the use and effectiveness of paltusotine, which is small non-peptide, small molecular, selective somatostatin receptor type 2 agonist that maintain the control of biochemical control in acromegaly patient. It's similar to the oral octreotide, so patients should be on injectable agent first before starting this treatment. And it's phase 2 trial, and it's actually opened the door for the patient to enhance the adherence to therapy. ACROBAT EDGE trial, where, as I said, they assess the oral paltusotine in terms of biochemical control. Patients showed good control, and they maintained their good control during the study period of 13 weeks. But they have washout period where they stop paltusotine and assess the biochemical response. And what they found that during the treatment, oral paltusotine, the IGF-1 was well controlled and maintained as the patient was using injectable agent. And when they stopped the oral, the IGF-1 went up again. So this is a new agent opening the door and promising in terms of the safety and effectiveness to maintain the control of those patients. EMPOWER study, another study, actually showed the long-term duration of using oral octreotide on those patients, and it's compared to the injectable one, head-to-head trial oral with the injectable, and it showed longer duration, durability, effectiveness, and safety of using oral octreotide in treating or controlling acromegaly in those patients. So hopefully, I'm not sure why the slide actually cut to have a, so the future of somatostatin receptor ligand, there are many actual studies going on and trials to evaluate or assess whether there is a future need for a new medication that enhance the adherence to the treatment. Also trying to find in the future new biomarkers in order to guide your option of medical management. And also hopefully in the future we found a new injectable agent that is easy to administer and used by the patients, because most of the time patients are not compliant with using oral octreotide because it's painful injection every month. So having a new oral agent or easy to administer agent will be useful in the future. This is in general, this is, I think I came towards the end. Overall, most of the patient, acromegaly patients remained uncontrolled, and we need actually to use our predictor to guide our medical management in order to decide the option of medical therapy in patients with acromegaly. And also, we are pleased with the current data in terms of the long-term safety and effectiveness of second generation somatostatin ligand, bezirutide, up to 14 years we have the data. So it's safe and effective agent. And still there are ongoing trials to find a new agent in the somatostatin ligand class in order to control the disease and enhance the adherence to the therapy. And thank you.
Thank you very much, Dr. Aisha, for a very nice presentation. Because we are actually behind the time, so we will take a very quick, short question and two short answers as well. Tara, please.
It's okay.
Aisha, thank you very much for some sharing the presentation. Can you just give us more insight about this new somatostatin receptors?
Agonistatin actually is phase 2 trial, still not approved yet. And it's like in terms of the effectiveness and durability in terms of maintaining biochemical control is similar to, so far to octreotide, but we don't have head-to-head trial to compare oral octreotide with baltusotine.
Thank you so much. About my question about the breadth, the volume of
So the maximum dose used in most of the studies actually up to 3.5 milligram per week. Duration, it's not clear really from that study, but most of the patients they will have with the cabergoline or dopamine agonist escape effect, so it will not be effective anymore. So even with my patient, I found it's like with initially I will find that response, I can see it, but with the time the patient will respond to dopamine agonist.
Thank you very much, Dr. Aisha. Please welcome with me Dr. Aisha for a very nice presentation.
Our third speaker for this afternoon session is Professor Rosario Bivonello. He's a full-time professor at Naples, Federico II University, and he's a member of the department there. He is also a member of the Italian Society of Endocrinology, and he has many scientific publications. He's an expert actually in endocrinology and also has a special interest in andriology, erectile dysfunction, premature ejaculation, infertility, pituitary disease, and Cushing disease. This session will be, he's going to tell us about Cushing, management of Cushing disease, top medical strategies for success. The floor is yours, Professor.
Thank you very much for the kind presentation. These are my disclosures, so it's really a pleasure to stay with you today and to share some of our knowledge and experience about the treatment of Cushing syndrome, in particular of Cushing disease. So this is something that you know very well. This is the new guidelines published recently in 2021 regarding the treatment of patients with Cushing's disease. And you see that there is some novelties compared to the oldest, guidelines coming 2015 before this one. Which are the novelties? First of all, the role of the medical therapy. You see that medical therapy now has acquired a major role in the treatment of Cushing's disease, and there is several indications of medical therapy. For instance, it is a second-line treatment after surgery when surgery is not successful. So in case of persistent disease, but also in case of recurrence of the disease, medical therapy is the first choice. And then we have the other alternatives like reoperation or radiotherapy or bilateral adrenalectomy. But also important to emphasize that medical therapy can also have a role in a primary approach when pituitary surgery is not feasible, or can be considered in a period before surgery. You see, for the first time in the guidelines, the preoperative approach with medical therapy is considered. And we know that we have several drugs available now I don't know why the slides are not, perfect because something happened to the slides. But you see that we have now available in, of course, in different countries, many different drugs with the three category. So the pituitary-directed agents, including pasireotide and cabergoline, several adrenal steroidogenesis inhibitors, including ketoconazole, metyrapon, osilodrostat, that we will talk about that later. And there are also, but it is indicated especially in US, in patients with diabetes together with Cushing disease, the glucocorticoid receptor blocker like mifepristone. So it's important when we make the treatment, especially the medical treatment of Cushing disease, to consider which are the goals that we have to reach. So for sure we have to normalize the cortisol levels and possibly to have a long-term disease control. Then, together with that, we have to, to treat the comorbidities which are associated with hypercortisolism, which is important because are the reason of the increased mortality of these patients and also the deterioration of the quality of life. And to reach this goal, you see that this box, show the major results of the efficacy of the different drugs already evaluated in a specific clinical trial. So for instance, you see that pasireotide LAR, according to the major clinical trial, can reach the normalization of cortisol in 40% or even 50% in the long term. You can see among, for instance, the steroidogenesis inhibitors, the variable effect of ketoconazole and the new levoketoconazole and metyrapon, but you also know from the recent study that we will discuss in the next slides that osilodrostat is now considered the more potent drug that we have, with the percentage of success which in the different studies reach even 80%. But it's also important when we have to consider the goal of treatment of Cushing disease to go further this data, to go to the real life practice and to consider the possibility, because this should be our real goal, to restore the normal cortisol rhythm in these patients, because the cortisol rhythm is the one, when it is deteriorated, highly associated with the cardiovascular comorbidity of these patients, which are also the cause of the mortality of these patients. I was mentioning before osilodrostat, and this is an overview slide which show how robust is the group of the studies performed nowadays on osilodrostat, starting with the link 1, which is the first proof of concept study performed years ago, and then the other link 2 is the phase 2, and then the link 3 and 4 are phase 3, and these are the most important one, which brought, the drug to the registration, to the approval in many countries. And you see that now we have also other studies ongoing, like link 5 dedicated to children, so to pediatric population, the link 6, which is an observational studies on all types of Cushing syndrome, and finally the link 7, which is performed in France, and it is dedicated to non-pituitary Cushing syndrome. So you see that in general, till now, more than 450 patients has been already treated with osilodrostat, so we have the data on a huge population of patients. That's why these are quite robust. And what about the tolerability of the drug? So osilodrostat was generally very well tolerated. This is, the side effect or the adverse events registered in the two main studies, the link 3 and the link 4. And you can easily see that in the majority of cases, the side effect or adverse events, including nausea, headache, fatigue, which are also expression of a cortisol withdrawal syndrome, which is also, if you consider the potency of the drug, the effect of this strong, and rapid action of the drug in decreasing cortisol. And then also the adrenal insufficiency, a real adrenal insufficiency, can occur as one of the main adverse events, which again means that the drug is very potent. So we were talking about the real life practice. So now we try to go beyond the clinical trial, the official clinical trial, and see what happens in the real life practice with different drugs. So I have just show some example. You see pasiriotide subcutaneous formulation that we use in Italy because we don't have the possibility in Cushing to use the long-acting release formulation. In the long term, shows in the real life shows higher percentage of success compared to the study, up to 60 or 70%. We also know from the real experience that metyrapone can reach control in 70% of patients in some studies, but only in 50% there was both the control of urinary free cortisol and also the late night salivary cortisol. But again, this is an Italian experience on osilodrostat in real life. The results was even more, impressive than the other two drugs. And I want to show in details these studies which involved many centers in Italy, including our centers, of course. And at the moment in these slides, you see 64 patients, but now we reached already 100 patients in this study. And you see that after 18 months, the group of patients already reaching this period of treatment has almost 90% of control in terms of urinary free cortisol, with the side effects which are similar to that of the study, where the hypocortisolism-related adverse events were the most common adverse events and was observed in around 30% of cases. And according also to what it was seen in the studies, the treatment was associated with an improvement in the body weight, in the visceral fat, in the blood pressure, and especially in the quality of life, which is very important. So I also mentioned before why and how is important to control the rhythm of cortisol, so the cortisol rhythm. And there are studies which are trying with medical therapy to restore, or at least to go close to a restoration of cortisol right. This is a study on metyrapone, which has the same mechanism of action of osilodrostat, in which the administration of the drug during the evening, actually twice at 6 p.m. and then at 10 p.m., is able to make a profile of cortisol which is more similar to the physiological one. And in this same study, metyrapone was able to induce the control of late night salivary cortisol in 37% of patients, which also is an expression of the control of the cortisol rhythm. But what happens with osilodrostat? This is, of course, we don't have many data yet because it's recent, but again, the possibility to give the drug with a higher dose in the evening compared to the morning can be a strategy to control better the cortisol rhythm. And indeed, in the link for one of the studies that I mentioned before, there was a recovery of cortisol rhythm in terms that the 49.7% at the late night salivary cortisol, which was in the normal range. So at least half of these patients seem to have a normalization also of the cortisol rhythm during the day. But the other goal I mentioned was the long-term disease. So how can we, continue to control the patients for a long period with the drug that we have available? So these are just some example of results in the extension, in the longest extension of the study. So you see that patients, a certain number of patients, a good number of patients can maintain the control with drug like pasiriotide and osilodrostat. As you see here, the percentage of patients maintaining in the long term the control of cortisol is around 70 or 80%, especially better with osilodrostat than with pasiriotide. And with osilodrostat, it was also a new evidence that even when we stop osilodrostat because of different reasons, normalization for a long time or because of adverse events, side effect, there was clinical cases showing that the normalization of cortisol or the block of adrenal or adrenal insufficiency can persist for a period of time even without the drug, which means that we have to know better the potency of this drug, which are able to give a prolonged effect even when it is withdrawn. And focusing again on osilodrostat, these are the data about the extension studies of link 2, link 3, and you see link 4 also, and you see that 75, 80%, 72% are the percentage of patients which maintain the control over time. And this graph is very clear to see that after the first rapid decrease of cortisol during the first weeks, then the mean cortisol, this is the mean urinary free cortisol, was maintained very stable during the period of the extension. And this is important because we know from the other drugs, the adrenal steroidogenesis, that we can have escape to this drug, which is quite common with ketoconazole, with metyrapone, also with cabergoline sometimes. But with this drug, as well as with pasireotide, the escape is absent or is very rare. So that's also important to remember. And the other goal that I mentioned is the improvement of the comorbidities and the symptoms and signs of the patients. This is just the example of what happens after 48 weeks during the link-3 studies in patients having osilodrostat. And you see the change in weight, systolic and diastolic blood pressure, the glucose profile, and also the lipid profile was going better in the patients very, very clearly during the 48 period of time. But more important are the effect on these two items, I mean, the depression and the quality of life, which is the most important thing to check in these patients. So you see the improvement again after 48 weeks of depression and both the quality of life, which were measured through specific questionnaires in patients during this study. The other goal, what about the tumor control? So the tumor control is the third goal that the last goal that I mentioned at the beginning, and sometimes it is important, especially when we have a large tumor, which is not common in patients with Cushing's disease, but it can happen. We know that the two agents directly controlling the tumor are pasireotide and cabergoline, which we use in Italy as an off-label, and of course the cabergoline. And from pasireotide, you see from a meta-analysis that it is able to control the tumor grow in 41% of patients. Similar results we also found with cabergoline, but of course with cabergoline we have studies with a low number of patients, so we cannot compare, of course, the study on cabergoline with the one on pasireotide, which included a large number of patients. But the other question can be, but what happens to the tumor when we are using the adrenal steroidogenesis inhibitor? So we don't have many data about ketoconazole and metyrapone. With ketoconazole, there are only some few cases in literature in which it was described the appearance of tumor which were not present before. But osilodrostat studies has the data also on tumor. And it was demonstrated that actually the change in the tumor size was mild in the majority of cases. And I mean, surprisingly, in some cases the tumor were mildly increased, but in some other patients, in the same, almost the same percentage, was mildly decreased. So there was a variable effect on osilodrostat on tumor, but tumor is not, I mean, a problematic issue when we used osilodrostat. But the guidelines that the recent guidelines that I mentioned at the beginning suggest to monitor a CTH concentration anyway, because the progressive elevation of a CTH, especially when it is very rapid and dramatic, could be a sign of a tumor growth. And in that case, we need to check the MRI to go and to see what happens to the tumor. At the end of this presentation, which was dedicated to Cushing disease, of course, to the pituitary-dependent Cushing syndrome, I would also mention that we now have data on osilodrostat even in case of non-pituitary Cushing syndrome. So, for instance, these three studies, when a phase 2 study dedicated to patients with non-pituitary Cushing syndrome, it was performed in Japan. The LINK-7 is an observational study performed in France in patients, again, with non-pituitary Cushing syndrome. And the last one is a real-world evidence in patients with ectopic Cushing syndrome and very severe cases, again, a retrospective multicenter French study. Just I showed the slides of these three evidence to show you the effect of osilodrostat. This is the Japanese one, which was performed, I mean, in only 9 cases of adrenal tumor or ectopic Cushing syndrome, and you see that they reached a percentage of success of 67%, and with a safety profile which was quite similar to the ones that we have already seen in patients with Cushing disease. So 6 out of the 9 patients normalized urinary free cortisol, 1 almost normalized, and only 2 cases did not. And this is actually the other studies that I mentioned. So the Link 7 study, and this was performed, you see, in many cases, including adrenal tumors or hyperplasia, and especially ectopic ACTH syndrome. And you see that 54% of patients in these cases normalize after 12 weeks only. And also the safety profile was again consistent with that we know about osilodrostat, but unfortunately 29 of these patients during the study died for side effect, but it was mostly related to the tumor, so to the progression of the tumor. And the last study, again the French study dedicated to ectopic Cushing syndrome, was, performed again in 33 cases, and osilodrostat in this study was given as a monotherapy with a percentage of success of 82%, or as a second line monotherapy or in combination therapy. In all cases, we had, an important decrease or normalization of urinary free cortisol, and the side effect of these patients was similar. So again, adrenal insufficiency in 24% of cases, and only 1 case died, unfortunately, for an acute adrenal crisis because despite the symptoms were evident, the physician did not recognize the problem. So it's important, of course, to monitor regularly the cortisol, the morning cortisol levels during treatment, and give a patient's education on how recognize the symptoms of adrenal insufficiency. So at the end of this story, we can say that we have now the possibility to use different medical therapies and the new osilodrostat treatment, and we can try to individualize the treatment for the single patients. It is, of course, indicated in case of persistent or recurrent Cushing disease, in patients candidates who are not eligible or refuse surgery, in emergency treatment in patients with severe hypercortisolism. But anyway, we have to consider the patient's characteristics and, of course, also the patient's preferences in order to decide within a multidisciplinary team the best choice for every patient. So in summary, we can say that medical therapy may benefit patients with persistent or recurrent Cushing syndrome, those who are not eligible or refuse surgery, and those who require emergency treatment for severe Cushing syndrome. The choice of medical therapy should be individualized based on the patient's clinical scenario, and the data coming from the Link studies or the real-world evidence studies demonstrate that osilodrostat is an effective and also well-tolerated treatment option for patients with Cushing disease, but can be also considered in some part of the patient's history in cases with non-pituitary Cushing syndrome. And for this, I will thank for the attention.
Thank you, Professor Ricardo. Please,
It's a pleasure.
first question.
Can you repeat, sorry, the question at the beginning?
Monitoring.
Okay. The monitoring, yes. Well, with pasireotide, you are... Well, actually, with pasireotide, we have to take a good control of glucose. That is the main issue, So first of all, before talking about monitoring, I would suggest to check the glucose profile before starting pasireotide and try to make the better control in case the patient has a diabetes or an impaired tolerance of glucose or something before starting. So better is the control before starting pasireotide, better would be the effect of pasireotide on glucose. But in any case, when we start pasireotide, we have to monitor glucose profile differently independence of the starting point. If the patient has, for instance, a normal glucose profile at the beginning or just a mild glucose impairment, then you can check glucose, not so frequently, once a week, and then to verify what happens to this glucose. And in case you don't see hyperglycemia, then you can check once a month, for instance. In case, indeed, the patients had already diabetes or a severe condition before starting pasireotide, the checking of glucose should be daily, during the day, during the first period, and to capture, the hyperglycemia very soon, because this hyperglycemia needs to be cured. So we have to start immediately some drugs because the hyperglycemia, is dependent on the direct effect of the drug, and you cannot expect that it's improving with time. So in the beginning, of course, once a week, and then you start metformin or the other oral or even other kinds of drug, and of course the monitor is dependent on how is controlled the cortisol levels.
Dr. Mohammed?
Yeah. Yeah, that's also a nice question because it's not a very frequent situation or condition, but it can happen to have this bilateral adrenal hyperplasia. Well, the guidelines actually suggest as a first approach to use a monolateral adrenalectomy first, so to take out one adrenal gland. And the choice of which adrenal gland to remove, it depends from the size of the adenoma, for instance, or the lesion, the uptake at the scintigraphy, or even, if it's possible, the gradient of cortisol at the venous sampling of the both adrenals. I have to say that this is an approach. Generally, it's can be a good approach, and remission can happen in a good percentage of cases, but there are 15 to 20% of cases in which you have to take out also the second adrenal gland because the disease is not in remission. Nowadays, my approach is a little bit changed because of the possibility to use this drug, especially with dosilotrostat because it's acting directly on the adrenal and it's also very rapid and effective. So I will try first to use medical therapy and to postpone the adrenalectomy. Also because I don't like, in general, to take out the adrenal glands to any patients, since I probably cure one disease, but I give another disease which is for life. So as soon as I can avoid that, and if it is possible to do only with one oral easy drug, I will choose like that.
Okay, Dr. Raya, we cannot say no to you. So your last question is yours.
Last question. Yes, theoretically, yes, because I think that combination treatment is an approach becoming more and more frequent in patients with Cushing because no one of the drug available is able to control 100% of cases. And the choice of a combination is to use both drugs acting with the same mechanism, or two drugs acting on two different mechanisms, especially in your case when you have a large tumor, then you can control cortisol in a rapid way with dosilotrostat, and then you can also block or prevent the growth of the tumor. So theoretically, the approach is quite good, and it is also some experience in the real life of this kind of approach. The only thing that we have to monitor very carefully when we add two drugs, especially dosilotrostat and pasireotide, especially if we use quite high dose, is the possibility of the QT prolongation, because both drugs can have an effect on QT prolongation, so which means that we have to check the cardiac rhythm and the cardiac condition of the patients in advance, and then monitor with an EKG these patients quite frequently, especially during the first period in which we give the combination.
Thank you, Dr. Ricardo. Yeah. Thank you.
Thank you very much.
Thank you very much, Dr. Zahid. Our fourth presentation will be a satellite symposium. Will be sponsored by Epson and will be presented by Mahfouz Jamahir, Dr. Tariq.
So,
Dr. Tariq,
next time we have to check the slides before.
Role
because
of
you said, but you didn't check that they
somatostatin
changed the
treatment of acromegaly.
Because when you change the computer, it is possible. Oh.
Thank you very much. Sorry, I think there is a bit of technicalities. Sorting it out. Thank you very much, ladies and gentlemen. I think this is the last presentation in this session. I'm going to give you a talk about the role of the first generation somatostatin receptor ligand lanreotide autogene management of acromegaly. And this talk is given in behalf of Epson, which has kindly actually supported our meeting together with Recordati. And of course, you know, this is a concluding sort of talk in this session about acromegaly, and some of the slides will be actually more or less overlapping with what my colleague Dr. Aisha has alluded to. We all know that, you know, first generation somatostatin receptor ligands are very important as part of either the sole or a combined therapeutic armamentarium, but the primary, you know, approach is by surgical treatment where it is appropriate and where it is feasible, and somatostatin receptor ligands actually do provide the safe haven actually for many patients. And of course, as Aisha earlier alluded to, there are certain sort of variables which we have actually very much to be aware of regarding, of course, achieving remission, preventing morbidities, as well as reducing the chances of mortality, likewise to preserve the pituitary function, and to try to arrest or reduce the recurrence of the tumor and eventually to try to cure from it. And of course, the somatostatin receptor ligands has been around for a quite decent period of time, and we are learning more and more actually options are coming. But however, they are quite good agents. They are synthetic for the sort of original somatostatin, which is considered as a sort of, I remember during my earlier sort of training days, as endocrine cyanide. And of course, the most important part is that it does actually prevent the secretion of the growth hormone, and the secretion of growth hormone, of course, through its messenger, the IGF-1, tend to create a lot of problems. And lanreotide autogel has been actually very helpful to treat many patients, and for those who does not know, it is available in various actually dosing options. There is 60 milligram, 90 milligram, and 120 milligram. And the goal of actually treatment is to try to start with the minimum effective dose, and then you can actually move to actually higher dose. And there is some recent evidence to suggest that actually the dosing interval could well be actually increased in selected patients. So we'll come to that. And of course, there is a quite actually, evidence to suggest that the lanreotide in general do actually get actually quite good response in many patients, whatever actually you use, whether 60, 90, 100 or 20, and this can result in reduction of both growth hormone as well as IGF-1, and unfortunately it does not work the pointer here, but you could see that actually the efficacy of the drug tend to kick off very early, and before actually 16 weeks of therapy you do get actually quite decent response in more than 50% of patients. And the improvement tend to involve both the growth hormone as well as normalization of the IGF-1 in nearly actually 2/3 of patients, and in around 43 of patients you do get actually normalization of both denominator, the growth hormone as well as the IGF-1. And as we know from the latest guidelines, the IGF-1 now is the most actually important, and in patients who do not actually need any dose escalation up to 20 milligram, around 85% of them, they do achieve actually biochemical control as shown by reduction in the IGF-1. I'm going to take you very quickly through a very important actually study, the LEAD study, where actually they assessed the feasibility of extending the dosing interval in those patients who have been actually maintained on a standard dose of 60 milligram for around 6 months prior to the enrollment in the study. And then they took those group of patients with around 124 patients, and they started actually 6 weekly injections, and they looked into the response in terms of their IGF-1 level, whether actually it started to increase anything between 100 to 100 and less than 130% of the upper limit of the normal range, or whether remain between 50 to 100% of the upper normal range, or whether actually drop below 50. And then according to this sort of denominator, they started actually to change the 4 weekly for those patients who actually showed increase in the IGF-1 above 100 but less than 130% of the upper level of the normal reference range, they actually switch them back to sort of 4-weekly interval. And those patients who have shown actually good response with reduction of IGF-1 less than 50%, they increase actually the interval to around 8 weeks. Those who have actually maintained IGF-1 level greater than 130% of the upper normal reference range, they were withdrawn from the study. And you could see that actually the response has been quite actually well translated. There are certain patients who can actually benefit from increasing the dosing interval to 6 weeks, as well as there are certain patients who can actually you can go ahead and increase the interval of the dose to sort of 8 weeks. The side effects in general is not very much dissimilar of what you normally see in these patients. Mainly it has been around 11% incidence of gallstones. And of course, there are certain number of patients who might experience common side effects, as you could see from these patients. The result of this lead trial has been actually taken by many actually regulatory bodies, as well as you have seen it actually being incorporated into that sort of consensus update 2021 by Maria Flisseru, Andrea Agostina, and Shlomo Melmid, and others. So, and nowadays actually it has become more or less adopted by many actually endocrinologists who see acromegaly patients. So, the somatostatin receptor ligands do have actually treatment challenges, and we know that the octreotide in general are associated with quite actually problems, including issues related to the injection. However, when we take the monthly injections, in general, they are of course quite actually burdensome for many patients, and there are issues related to adherence, as well as issues related to lifestyle, as well as issues related to problem with side effects like burning, as well as logistics of taking time off work. Here we are talking about the other octreotide long-acting, which require issues. And of course, many of these barriers is very much actually responsible for issues related to the failure rate of the conventional somatostatin receptors, primarily somatostatin, i.e. octreotide. And this has been very much actually, an issue to be actually tackled, as well as to be actually sorted out. And this has been actually more or less provided by the switching these patients actually to lanreotide. So there are some data which support switching patients actually from octreotide to lanreotide, and this actually the transition for such a switch is very much actually helped by so many issues, including profile of patients, tolerability issues, as well as the achievement of independence, as well as improvement in terms of other lifestyle, likewise the patient factor like being satisfied or dissatisfied. And there are actually fewer technical issues when you compare the somatostatin IM injections with the subcutaneous actually lanreotide autogel, and this has been shown actually by this study which has been published actually back in 2016, where significant number of patients actually they have shown quite satisfaction with the improvement in terms of their injection experience. And of course, the lanreotide autogel is indicated for injection by a healthcare professional. However, a trained person or even the patient can be injecting at home, and this can be actually achieved provided that the patient is well trained, the nurse or the other healthcare professional has been well instructed, and of course the right technique in terms of inserting the needle correctly and achieving the appropriate needle depth and administer the complete dose. And the value of giving the lanreotide autogel has been actually very well looked into, and it has been actually shown by so many studies that, you know, patients with acromegaly who are using lanreotide, they prefer it actually, you know, against the use of the other IM preparations of the conventional octreotide. And I think because of sake of time, you know, I won't go through this. However, you know, we should remember that there is a higher overall preference score reported for lanreotide autogel than that for octreotide LAR. Likewise, the device for the lanreotide autogel is very convenient. It is a pre-fill device. It can actually be administered very fastly, and it gives the patient full confidence of the full dose actually, you know, delivery, and there is low clogging risk which we normally experience with the other somatostatin receptor, as well as it is easy and convenient to prepare. And even nurses, they report fewer clogging experiences and faster administration for lanreotide autogel when it is compared with the octreotide LAR, and that 90% of nurses see fast administration actually as an advantage. 49% says that it would enable them to see more patients, as well as 45% said that they would have more time to talk to patients, and that around 70% of nurses experience too much actually clogging with the octreotide LAR, and 99% of these episodes actually do occur during such actually injection technique. And following transition actually from the octreotide LAR to lanreotide autogel, around 80% of patients preferred lanreotide autogel to the octreotide LAR, and patients who are on a longer dosing interval are more likely to have preference for lanreotide actually autogel, as this will have actually quite good improvement in terms of their quality of life, as well as the issues related to taking time off work, having to travel to go to hospitals, and what have you. And patients with biochemical control are candidates for an extended actually dose interval, as I have shown actually from the study of the lead, as I have shown it to you before. And biochemical control tend to be maintained actually when transitioning from the octreotide LAR to lanreotide autogel up to week 28, and the dosing interval can be increased accordingly, and the transition actually, you know, from the conventional octreotide LAR to lanreotide autogel tend very much to improve symptom control. I think I will probably stop here and take sort of questions because of lack of time, but there is enough data actually to suggest that, you know, changing patients over from the conventional octreotide to lanreotide autogel tend to be quite beneficial actually to these patients, especially on the face of the lead study, which have shown that actually the dosing interval can be increased up to 56 days. And we do have actually quite reasonable experience of achieving such actually recently in Qatar. I think just to, you know, get more sort of discussion, I will stop here and welcome questions.
I'm sure there is a lot of questions.
Of course, you are acquainted with the sort of new device, where the old device have a sort of a bit more actually larger sort of needle size, but this has been very much actually overcome, and the new device is very much convenient actually to use, and you will be able actually to see that, you know, you have actually introduced, you know, most of your drug. So just in summary, compliance and adherence could be quite actually a challenge when you are actually using such actually quite special medications to patients with conditions like acromegaly. And the lanreotide autogel does improve actually patient treatment experience and does carry potentially long-term adherence as well as benefit to these patients with this special condition. And there are no concerns actually regarding the loss of efficacy when you are using actually lanreotide autogel. I think, Mr. Chairman, I will stop here and then welcome any questions.
Thank you very much, Dr. Tariq. We will take 2 questions. If there is any quick question. Yes.
Yes, Musa. Yeah.
In our practice, I have noticed, to be honest, significant improvements in diet and patient satisfaction.
Yeah.
In the past, people they keep even traveling
Yeah.
distance just to come
Yeah.
injection.
Yeah. Yeah.
Nowadays, they will take it from there.
Yeah. Yeah.
Home travel and
Yeah.
the installation itself.
Yeah.
With this one, we show consistent installation as compared to the
Yeah, yeah. In Qatar, actually, we didn't have the sort of privilege of even having lanreotide except just a couple of years ago, before it was introduced to be formulary to be used actually to eligible patients. And the company has been quite generous actually providing sort of free around 6 samples. And the 6 patients actually we started them on lanreotide. They have actually done very well when compared with the previous experience with the conventional octreotide LAR. And there has been very little issues actually relating to the sort of new device. And now we are more privileged by having it actually been introduced into our formulary. So we'll be able actually to, you know, use it more and more for such patients.
Any more questions? So, yeah.
When is the break?
What do you mean? Yeah, now. We have a break
Okay.
now.
Sure.
We will have a very quick break for about 10 minutes. Then I would like to have you all here to complete our session today.
Thank you.
As we are reaching the end.
Thank you very much.
Thank you.
Thank you.
اكسلنت توب بس
الله يبارك فيك.
عندي سؤال ما ينفعش اساله في
لا 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 جدا لا لا اتفضل.
ده معناه ان خلاص يعني هل
Assalamu alaikum wa rahmatullahi wa barakatuh. You are welcome to the second part of the afternoon sessions. And actually, this last 2 parts or last 2 sessions are very interesting. The first session will be given by Professor Roberto Salvatori. He's a professor of medicine, Division of Endocrinology and Neurosurgery at Johns Hopkins, Baltimore. And he's also the director of the Pituitary Center there. He has been trained in Rome, Italy, but then after that he did his training in New York and also Johns Hopkins in Baltimore. He's going to talk to us about growth hormone deficiency, diagnosis and treatment. This is a pre-recorded sessions.
Hello, and thank you for your kind invitation. It's a pleasure to speak to you today about growth hormone deficiency, diagnosis and treatment. These are my disclosures. I want to start presenting a case. This is a 49-year-old gentleman who was referred for management of hypogonadism. He had no other medical history. He had presented with reduced libido, and the hormonal evaluation by his internist showed evidence of central hypogonadism with low testosterone and inappropriately normal gonadotropins. He had a normal prolactin and normal pituitary MRI, and when I saw him, he was already on testosterone replacement therapy. On review system, he reported some chronic tiredness and constipation, and in the past, he has mentioned that he had some abnormal liver blood test. Importantly, he had a head trauma 4 years ago after a bicycle accident with transient loss of consciousness, for which he was admitted to the hospital for 3 days. He rides his bicycle to work still every day. On exam, he had no feature of abnormality except his testes were small. And by the time I saw him, his testosterone was normal while on replacement. However, he had evidence of central hypothyroidism with a low free T4 and inappropriately normal TSH. And his IGF-1 was within normal limit at 156 nanogram per ml, with normal value in this assay for his age between 121 and 237. So the question I have for you, think about this and we'll answer at the end of the talk, is what is the chance that this patient has growth hormone deficiency? 0 because he has a normal IGF-1, 20%, 40%, 80 or 100%. So what are the consequences of adult growth hormone deficiency? You know, growth hormone is a misnomer. It's a hormone that doesn't only make us grow, but it also has important metabolic effect. So adult patients who are growth hormone deficient have altered body composition with increase in fat mass and decrease in lean mass. They have an increased cholesterol level. They often have increased carotid intima media thickness. They tend to have reduced bone density, reduced quality of life. And there is a question of whether or not there is a difference in life expectancy, and this question has not been answered yet. Now, IGF-1 is not a good test to diagnose growth hormone deficiency. This is an old study that showed a group of patients, on the left female, on the right males, who had bona fide growth hormone deficiency as shown by a positive and abnormal insulin tolerance test. And as you can see, in yellow are the normal plus minus 2 standard deviation value of IGF-1. As you can see, about 25% of women and about 50% of men had normal IGF-1 despite having been proven to be growth hormone deficient. And in fact, if you looked on the right side of the slide, you can see that actually some men had IGF-1 in the upper range of normal despite growth hormone deficiency. And this was proven recently in another paper. They looked at a subject who had a traumatic brain injury or sport-related concussions, and they did a stimulation test, and they measure IGF-1. And as you can see here, the ROC curve for diagnosing growth hormone deficiency of IGF-1 was very abysmal, essentially similar to flipping a coin. So IGF-1 is not a good test to diagnose growth hormone deficiency. Now, does everybody need a stimulation test to prove growth hormone deficiency? The answer is no. This is a result of a post-marketing study run by Eli Lilly when they introduced in the market their growth hormone preparation. And they looked at patients who had a different number of missing axes. And as you can see here in red is the percentage of patients who had growth hormone deficiency, albeit, of course, the stimulation tests were different. They may not be completely reliable. However, they noticed that in patients who had a pituitary pathology and had no other axis deficiency, 41% had an abnormal stimulation test. If there was one abnormal axis, let's say the patient was hypogonadal, the chance of being growth hormone deficient was 67%. If the patient had two axes missing, the chance was 83%. And for patients who had pan-hypopituitaries, the chance was close to 100%. And I use this data to convince insurance that patients need to be considered growth hormone deficiency when they have pan-hypopituitary, even without a stimulation test. Now, if you need a stimulation test, what stimulation test can you do, and what are the pitfalls and the problem in doing this stimulation test? The first thing I want to tell you is that a lot of stimulation tests, and in this particular study, this was the GHRH plus arginine stimulation test, are BMI dependent. This is one of the first papers that showed this, a study from Italy published several years ago, where they looked at normal individuals and they did a GHRH plus arginine stimulation test. As you can see here, the peak growth hormone in microgram per liter was inversely proportional to the BMI. And in patients who had a significant increase in BMI in the 40s or 50s, the growth hormone stimulation test was consistent with growth hormone deficiency, although these were patients without any significant pathology. We'll go over the cutoff suggested by this study and other studies in a later slide. Another important information that you need to think when you interpret the growth hormone stimulation test is which mechanism the test uses. And in this study, they looked at patients who had undergone radiation in the hypothalamic and pituitary area. And as you know, hypopituitarism due to radiation is actually a hypothalamic disease, not a pituitary disease primary. And as you can see here, when they compare the peak growth hormone to ITT on the left and GHRH plus arginine on the right, in patients who had been irradiated less than 5 years prior, the response to GHRH plus arginine was much more robust than to ITT. And the reason is that the GHRH plus arginine stimulates the somatotroph cells directly, while the ITT requires the entire axis to be functional. And it takes years for the somatotroph cells to atrophy. So these patients were actually really growth hormone deficient as shown by the ITT, but the GHRH plus arginine stimulation test did not prove that because the somatotroph cells were not atrophied yet. So you have to think about the mechanism by which the stimulation test works. Now, unfortunately, in the US, GHRH is not available, and so we have been relying on the glucagon test. The mechanism by which glucagon acts on growth hormone is not completely clear. You know, it sort of makes no sense. Glucagon acts opposite to insulin. So why would both hormones stimulate the growth hormone secretion? It's not totally clear. Now, one important thing, if you do the glucagon stimulation test, is that you need to extend it to 4 hours. So it's a long test. We published this in this paper where we looked in several institutions at the glucagon stimulation test. We found that about 6.6% of this test had a peak growth hormone that happened in the 4th hour. So you cannot cut the test short. You really have to extend it to 4 hours. The glucagon test comes with some side effects. Here in red is the fixed dose, which is what mostly used. In green is the weight-based dose, which is rarely used. But you can see almost half of the patient develop nausea, and also a significant percent of the patient develop vomiting. And this is probably an underreport because we looked at nursing note retrospectively, so they may, some episodes may have been missed. So you have to warn the patient that nausea is very common and they could even vomit. In terms of the cutoff, there's been some change, and again, I'll show you a slide later with all the cutoff, but an old study from Spain, published in 2002, proposed looking at the ROC curve, a cutoff of 3 nanogram per ml or microgram per liters, while a more recent study from the Mass General, published in 2014, showed that in a subject with BMI about 25, which sadly is most of us, the cutoff should be 1 nanogram per ml. Now, another test that can be done, and we were able to do it until about a year ago when this became commercially available, is a massimorelin test. I don't know if in your area of the world massimorelin is available, but if it is, it's a very good molecule. This is a study that led to the FDA approval of massimorelin. They looked at a significant number of patients and they divided in 4 groups. Group A were patients with pituitary pathology that were very likely to have growth hormone deficiency. Group B were patients who were intermediate likely, and Group C were patients who were at low likelihood of growth hormone deficiency. Group D was control normal subject. And when they looked at the ROC curve for growth hormone deficiency, they compared all these patients, massimorelin, to a gold standard, which is the ITT. They propose as a cutoff 5.1 nanogram per ml. For some reason, the US FDA decided to put a cutoff at 2.8 nanogram per ml, although the sensitivity is lower with a similar specificity, I think with the idea not to avoid false positivity. Now, if you look at this slide, you can see that this test matched very, very well with the ITT, which again is the gold standard. And as you can see here on the first part, these are patients with high likelihood of being growth hormone deficient. This is their growth hormone peak. This is a patient with intermediate likelihood, with a patient with low likelihood. These are not normal individuals. And very important, there was a very good correlation between the growth hormone peak by ITT and the growth hormone peak by massimorelin test when they were done in the same individual. And also, in a subset of this subject, the massimorelin test was repeated in a different day. And as you can see here, when they repeated, there was a very good correlation between the 2 studies. And this test is very convenient because it's a short test, it's only 90 minutes, and in general, is very well tolerated. The other important thing about the massimorelin test is that it's not BMI dependent, at least up to BMI of 37. And as you can see here, the sensitivity and specificity were not really influenced by the BMI. So this is a very good test. Unfortunately, in the US, it's no longer available due to a commercial issue, and I hope it will be available soon. What are the possible side effects? It's a solution. So some people get a little bit of bitter taste in their mouth. There is a question of QT interval that was found in one patient who was on Celexa. The QT interval increase above 30 to 60 milliseconds was seen actually more frequent in ITT than in massimorelin. Above 60 milliseconds was seen in 2 patients during massimorelin, and actually in 4 during ITT. And an interval increase of more than 500 milliseconds was observed actually only in a patient during the ITT and not during massimorelin. Nevertheless, I think it's probably prudent to hold for a couple of days any drug that may cause QT elongation right before this test. So if you look at the available test, the availability and price, you can see the ITT is accurate, is not always safe, it's contraindicated in patients with coronary artery disease, in patients with a seizure, in older patients. Is not simple, requires a lot of medical supervision, and the expertise, at least in the US, is fading. Is it's not that speedy. Is available, insulin is available everywhere, and of course is not expensive. The GHRH plus arginine is very accurate, is safe, is simple, is not speedy, is not available in the US, and the expense depends on the area of the world where you are. The glucagon test, the accuracy is debatable, is safe, is not simple because it's very long, is definitely not speedy. It is available, glucagon is available everywhere, and it's not expensive. And massimorelin finally is accurate, is safe, is simple, is speedy, and used to be available, now no longer in the US, and unfortunately it was very expensive, and that was one of the limitations that didn't cause its wide use, and that's why currently it's commercially not available, because it was too expensive for a lot of centers. Now, if you look at the recommended cutoff points recommended by different societies, I would concentrate on the right column here, the recommendation from the American Association of Clinical Endocrinologists, which is the most recent in 2019. And as you can see in the ITT, the cutoff is considered 5 nanogram per ml. The GHRH plus arginine is not recommended because it's not available in America, but if you look at the Endocrine Society, the cutoff depends on the BMI, so it's 4 for BMI above 30, 8 for BMI between 25 and 30, and 11 for BMI below 25. For the glucagon, clearly the cutoff is 3.0 for low BMI, is 1.0 for BMI above 30, and it's debatable for a BMI between 25 and 30. And massimorelin, the FDA recommendation is 2.8, although the paper that led to its approval recommended 5.1. And arginine is really not recommended in adult, arginine alone. So when you treat a patient with growth hormone, how do you do this? I usually start on a low dose to reduce the chance of arthralgia and fluid retention. I start with 0.2 milligram a day in males and 0.3 milligram a day in women. The dose is adjusted based on serum IGF-1. I usually check IGF-1 every month until I reach the goal, which is usually serum IGF-1 in the upper half of normal, which is, of course, need to be age adjusted. This is particularly important in patients who start with normal IGF-1. We want to see some movement of the IGF-1 upwards. Be aware of the challenge in serum IGF-1 assay, and try to keep the patient using the same laboratory. And an important issue is oral estrogen. Why? Because oral estrogen cause resistance to growth hormone. And this is one of the first papers that was published. There were many more that were published after this. And this looks at the serum IGF-1 in patients receiving different doses of growth hormone, whether they were on oral in white or transdermal in black. And as you can see, patients on oral estrogen had a much lower serum IGF-1 than patients on transdermal estrogen. So in general, when I treat a hypopituitary woman with growth hormone, I transition her from oral estrogen to transdermal estrogen to avoid this issue of resistance. What does the growth hormone treatment do? There are many studies. This is just one of them, looking at the lumbar and femoral neck bone mineral density. And as you can see, over the years, growth hormone increases in both sexes bone mineral density. I just want to warn you that bone density may actually reduce in the first few months of treatment before it increases. So the worst thing that one can do for a patient's bone is to start them with growth hormone and treat them with growth hormone just for a few months and then to stop it, because then you get the lowering of the bone density without the follow-up increase. There are changes in body composition. Again, here is comparing growth hormone to placebo. There is a reduction in visceral fat and subcutaneous abdominal fat. There is an increase in thigh muscle area compared to placebo. And there is also, in this particular study, an increase in exercise capacity, although not all studies confirm this. And this is comparing, of course, time 0 times month 12 times 0 times month 12. So it's a year treatment. Now, there are currently three either available or soon to be available forms of long-acting growth hormone. All three are for weekly use instead of daily use. Somatostatin is based on a technology that is the same technology that is used for Levomer insulin. Growth hormone is attached, has a linker that attaches to albumin. So after it's absorbed, gets linked to albumin that's released slowly over 1 week. The second one, somatogrone, is a modified molecular growth hormone, which both at the N and the C terminus has some addition that are taken from the beta chain of the ACG, which elongate its half-life. And finally, this lona-pegosomatropin is a pegylated molecule. Growth hormone is attached to polyethylene and glycol, gets injected, and then slowly gets released from the PEG and cleared by the kidney. So all these three molecules, some of them in the US are approved already for adults, some of them are approved for children, some of them are in waiting for to be approved. But this is a great opportunity to treat patients with a weekly injection instead of a daily injection. And this is a meta-analysis study that was published a couple of years ago looking at comparing different forms of growth hormone. And again, the data here are relatively small because these studies are still being done. But as you can see here, looking at the lean mass, fat mass, and visceral adipose tissue, there was really no difference here between daily growth hormone and weekly growth hormone in terms of lean fat and fat mass. And actually, in this study, the effect on visceral adipose tissue favored weekly growth hormone compared to daily growth hormone. And as you can see here, these treatment adherence is much higher in weekly. Well, as one would expect, weekly injection is more likely to be, patients are more likely to be compliant. There was really no difference in serum IGF-1. There was a mild increase in the dose, overall dose received in terms of long-acting growth hormone, and there was no difference in terms of side reactions. And again, this is a series of side effects showing that essentially comparing growth hormone, long-acting growth hormone to daily growth hormone in different studies, there was no really significant difference in any of the long-term side effects, most importantly, headache and arthralgia. So I don't know in your area if there is any long-acting growth hormone, which one is available. I think this jury is still out to determine the long-term safety of this molecule. Somebody has raised some concern about the fact that giving this weekly growth hormone, there is never during the week a phase where growth hormone level is very low, as it happens in all of us, let's say during the daytime. And so there is a question of whether this may cause some sort of acromegaly-like symptoms, and I think post-marketing studies will unveil this. Now, one other important point that we often ask is growth hormone safe in patients who have had, of course, a pituitary tumor or intracranial tumor? And I think that this is a settled issue. This is a statement from a very large consensus statement. And what it reads is that there is no evidence for an association between growth hormone replacement and increased mortality from cancer among GH-deficient childhood cancer survivors. So they have kids who were, let's say, germinomas, canopharyngoma, were radiated, and now they are growth hormone deficient. Patients with pituitary tumor, canopharyngoma remnants receiving growth hormone replacement do not need to be treated or monitored different than those not receiving growth hormone. Growth hormone replacement will be considered in growth hormone deficient adult cancer survivors in remission after carefully individual risk-benefit analysis. And usually in my practice, if I have a patient with growth hormone deficiency and has a history of malignancy, I want to wait at least 5 years of cancer-free interval between considering growth hormone replacement therapy. So the answer to our question, what is the likelihood the patient was growth hormone deficiency? Remember, he had central hypogonadism and central hypothyroidism, so he had 2 axes of missing, so the chance of him being growth hormone deficient, despite the normal IGF-1, was about 80%. And in fact, we tested him and he was growth hormone deficient. So in conclusion, in the absence of linear growth, which of course is what pediatric endocrinologists use, growth hormone probability tests remain the basis for diagnosing adult growth hormone deficiency in adults. However, not everybody needs a growth hormone stimulation test. If a patient has pan-hypopituitarism, particularly if the serum IGF-1 is low, there is no need for a growth hormone stimulation test. The insulin tolerance test is still the gold standard, but has possible side effects, and at least in the US, the expertise is fading. The GHRH plus arginine test is recommended where GHRH is available. Unfortunately, it's not available in the US. The glucose stimulation test offers a reasonable alternative, but the test is long, 4 hours, may be unpleasant, nausea and vomiting, and it may be difficult to interpret in patients who are overweight with a BMI between 25 and 30. Massimorelin appears promising as a simple, with rapid peak growth hormone, well tolerated and highly reproducible, but cost and availability are an issue. Growth hormone replacement therapy should be started at low dose to avoid side effect. Women who require estrogen replacement should receive it via transdermal patch. IGF-1 can be used to titrate the growth hormone dose. Long-acting growth hormone formulation are safe and effective and will likely be available soon throughout the world and may be already available in your area of the world. And growth hormone replacement therapy is safe in patients with pituitary adenoma or crown pharyngiomas, and is safe also, I think, in patients who have a history of malignancy as long as they've been cancer-free for about 5 years. And I thank you for your attention.
We'd like to thank the professor for his nice presentation. Here we reach for our last session today, which will be presented. Yeah.
No, we don't have experience from Taiwan. I don't think we have used it. Saudi Arabia. Okay. Thank you very much. So we are moving to the last session, which is the challenging cases and lessons learned from cases across the GCC. So we have 3 cases will be presented by our colleagues from Saudi Arabia, from United Arab Emirates. And the aim here is to present a challenging case, engage the learner, and come up with 1 or 2 take-home messages from these cases. The first case will be presented by Dr. Wael Al-Mustahi. He's a consultant endocrinologist, King Fahad Medical City in Riyadh, and he is also a pituitary expert, did a 1-year fellowship in Halifax, Canada, the same place where I was trained. So this is not a bias to start with him first. Anyway, he's presenting an interesting case. All presenters have 10 to 15 minutes to present the case, engage the learner, and come up with a take-home message, 1 or 2. Dr. Wael, you can start.
Assalamu alaikum jami'an. Thank you so much for giving me this opportunity to present. I'm really thank you, Dr. Khalid, for this chance. Also, I want to thank Dr. Fatma and Dr. Bakita to help me with the slide of this presentation.
Do you want this mic? You are familiar? Okay.
But I need a pointer. This is a case that have been seen maybe 3 years ago, and it's really was a challenge that I really want to share with all of you. Okay, I think the presentation is not here clear. It's fine. The screen is a little bigger than it should be. Okay, thank you. Yeah, yes, it's bigger. That's fine. Okay, Bismillah. So I have no disclosure. So the outline of our presentation will be brief about the case discussion, diagnosis, management, and take-home message. It will be integrated together. So the case from our side, the patient, 25 years old male, he presented with headache, blurred vision, and hypogonadal symptoms, including also double vision. They have no any other symptoms of pituitary hormone dysfunction and no trauma before. This is since January 2020. Also, another history, there is no significant past medical history or family history, no personal history of any calcium disorder or anything else, and he's married with have 2 kids. In examination, he have hemodynamically was stable with a normal PMI, with the presentation of left, third, and fourth nerve palsy with superior temporal visual field defects with no thyroid enlargement or palpable thyroid nodule, no Cushing or acromegaloid feature, and other systemic examination were unremarkable. So, after examination, they will do usual testing. So our test of prolactin came very high, as you most likely this is the first thing you are going to do.
So MRI pituitary showing a 4 centimeter cellular mass, and it was without any supercellular extension to the optic chiasm. I'm sorry, I'm running fast because the time. This is just a showing. So this was diagnosed before coming to our center as a macroprolactinoma, started medical treatment, and the follow-up have symptoms much improved. 6 months later, he came in June 2020, and he developed history of worsening progressive headache in the left retroorbital pain with no visual deterioration, no loss of consciousness, and he was reporting some compliance issue on the medical treatment. Examination was hemodynamic stable. There is still the third and fourth nerve palsy, but the people are equally reactive to light. So MRI done, also it's out, they mentioned there is a progressive growth of the tumor, almost 6 centimeter. Unfortunately, we don't have the actual image that extending to the superior and the direct contact with the optic chiasm, with significant extension through the base of the skull, inferiorly involving the left pterygoid muscle. This is all pituitary hormone have been done upon initial assessment in our clinic. It showed the prolactin 2844 with hypogonadal symptoms and centrally, and also central hypothyroidism. We did a short synapse to make sure, because AM cortisol wasn't in the supposed range, and it came normal. So the management was, at that time, we increased the dose and emphasized on the compliance. And at that time, I recall the patient was admitted for surgery, actually. We hold that and asked to start the medical treatment, because we believe this is most likely prolactinoma, and it's invasive, and we think it will be improved after treatment with intensification of the treatment. However, and you know what is the indication for surgery in macroprolactinoma. I think with all, the whole day today is for all this, so I will gonna through it. So 1 week later, we will just review the lab. We found something unusual, which the IGF was high, 57, which indicate to have, especially that this patient have no clear symptoms of acromegaly. So we do testing to make sure this is a true acromegaly or not. It became non-suppressible, which means they have co-secreting growth hormone and prolactinoma. Now the change of management, because the diagnosis is different. And repeated MRI at that time showing this. This is from in our hospital. As you can see, you have the session in the morning. I think you can read it now easily. So there is paracellular, supracellular, and extension with infracellular also, with destruction almost to the base of the skull. So this is just about the erosion of the cellular floor, extension to the sphenoid sinus with mass effect, with the bitemporal lobe also. So what's the diagnosis now? I'm sorry, at the time I think it's running, but we'll try our best. So prolactin, growth hormone, co-secreting macroadenoma, invasive tumor with compression to the optic chiasm. Anything in the next line of management? Okay. So who would start somatostatin therapy, and who considered testosterone replacement? Not now. Okay. We'll keep it later. So the transcranial debulking surgery was done on July 2022. The histopathology, so this is the histopathology. It came acidophil stem cell neuroendocrine tumor with positive for growth hormone, focal and diffuse prolactin, and negative for other hormone, and proliferating of Ki67 of 80%, with P53 of expression around 40%. Did it alarm you or anything? Any alarming things with this? Yes. So very high Ki67 and P53, acidophil stem cell also neuroendocrine tumor. So biochemical response post surgery, I mean, this is initial. He was in 2000, then reached up to 8,000. We'll reach that later. The time of surgery at that time, it was in July 2022. Also, the growth hormone initially was in higher side, then go down, but IGF-1 still was higher post-operative immediately. By the way, the operation was not successful. It was only towards a debulking, but they only reached 10%. It's almost like a biopsy because of severe fibrosis of the tumor. This is the image post-operative.
And as you see here, it's very clear that still there is large residual tumor in the same area of paracellular, infracellular region. So we believe there's no chemical response and there is still no structural improvement. So this is the timeline of our case. I can say from the beginning you have a macrolectinoma with progressive growth with defined that they have also co-secreting tumors. And a trial of surgical debulking unfortunately was not successful. So currently he is now an active disease. So what do you do next? You will do medical treatment, continue the same dose, or you start radiation, or increase the dose of cabergoline and observe, or start radiation, increase the dose, start octreotide. D. Always the highest, the right answer. Okay, or the longest. So multidisciplinary team was involved. So we increased the dose of cabergoline almost to 1 milligram per 3 times a week. We started octreotide. There is no further surgery because they failed. And start radiation therapy. So what type? I will pass that because it's already discussed in the morning. And the patient received 54 radiation, 30 fraction localized to the pituitary. And we did the screening for the acromegaly, despite have no clear feature, and it was more than normal. So this is the response after radiation. The prolactin went up to 8,000, then rapid improvement and almost to normalize by the March 2021. And here the IGF-1 also, it would reach the highest in August 20, but later on decline to normal level. And we 3 months to 6 months we are following the patient, and this is the time trend since he was with us. And he showed improvement immediately after radiation within 3 to 6 months, as I recall. I reached 3 milligram. I think I didn't increase at that time. Yes. Yes, we introduced octreotide, 20 milligram. I think we didn't increase it yet because he was planning for the surgery, for the radiation. And this is the imaging after surgery, which show very dramatic improvement after the radiation. And as you see here, this was pre in June, and this is January. Within 6 months, there is clear improvement in the cellular region. So this is again about the way that we did. Unfortunately, September 2021, the patient came back with recurrent progressive headache and no onset atypical facial pain consistent with trigeminal neuralgia and steady gait, but no visual field effect. So what could this be? Okay. This is CT upon assessment from the emergency, what you can see. Okay, so this is, I don't know if this is working. No. So I think you can see the cellular area. I know that this is not the best modality, but you see something up in the leptomeningeal area. In the head. Okay. So this is the MRI that you know more better. As you can see, there is recurrence of regrowth of the tumor. It's not recurrence, it's regrowth of the tumor. From the beginning is not totally cured. And if you can see here, this is some new lesion. So now, what do you think is the diagnosis? Yes, once you have change in the course of the pituitary tumor, this is called pituitary cancer. Especially this patient have leptomeningeal mets. So what additional therapy can be offered? Okay. Yes. Thank you so much. That time, I think we're trying the only thing that's available, maybe temozolomide. So we think about chemotherapy at this point. So again, we did a multidisciplinary meeting, and we asked to continue on cabergoline with compliance, and we start to send him to oncology for temozolomide. There is another thinking about another radiation. However, because of the neuralgia, we are hesitant. So the chemotherapy have been started.
Just a free word about it. It's, you know, as its first line for, it's an alkaline agent, and it's a first line treatment of chemotherapy for pituitary carcinoma. And you have to know about the MGMT expression, because this is like a marker for you about the medication efficacy, and because the aim of this to improve the 3 years survival. So when to stop the temozolomide? If you have no 3 to 6 months of the course, you have a response, you can continue. And if longer duration, there is better response, up to 12 months. If the side effect or progressive, you can stop. That means the patient doesn't improve. So in summary for our case, patient have leptomeningeal involvement, presented initially with aggressive growth hormone and prolactin secreting macroadenoma with combination of medical debulking, radiation, and palliative chemo. Just a definition, as we mentioned just now, previously they call aggressive pituitary tumor. Currently now all they put the term of PITNET, which is the preferred for the adenoma, the cancer whenever you have a metastatic for the leptomeningeal or distant. So when to suspect aggressive pituitary tumor? When, especially in the scene, the pathology is really helpful sometimes. And you know, if you have corticotroph invasive macroadenoma or macro giant prolactinoma, which shows resistant to medical treatment, and somatotroph also invasive, they're resistant to medical treatment, and non-functioning macroadenoma with silent corticotroph, rapid relapse of progression after surgery, tumor progression gene, also tumor with high proliferative marker like Ki67 and B53 expression, and also harboring TP53 or TRX. So what's the prognosis? Unfortunately, they have poor prognosis in general. Mortality is really increased even if the absence of the progression of the pituitary cancer and the aggressive pituitary tumor, and the survey reach up to 43% in mortality of the pituitary cancer. This is some predictor of the poor prognosis if the advanced age corticotroph pituitary cancer, systemic metastasis, and progression during the temozolomide therapy. This is our patient. Unfortunately, he didn't have any good effect after temozolomide, and the tumor was progressive. Unfortunately, also, we don't know what's happened to the patient. He lost follow-up more than 2 years now. We think maybe he didn't survive. So my take-home message, please, aggressive pituitary tumor and cancer carry high risk for morbidity and mortality, and which need multidisciplinary team effort to help the patient and treat him. Pituitary pathology should be alert the physician, and tumor behavior trigger the careful assessment and follow-up. For that, we have I want to share with you our experience now with the neuropituitary clinic combined with the neurosurgery. Here, Dr. Jama'an, Dr. Mohammed Al-Aswad from the neurosurgery team, and me with them in the same clinic. And hopefully, inshallah, this is the early step for Pituitary Center of Excellence. Thank you so much, and I appreciate it. Thank you very much, Dr. Wael. Interesting case, challenging case, but I liked very much the timely management. So, delay, no response with Kebergolan surgery, progression, radiotherapy, progression, temozolomide. So, floor is open for questions, comments. So, we have a comment here, and then Dr. Adnan.
I assume that you did genetic testing from the tissue for targeted therapy. Did you look into that, or it
No,
was
unfortunately not. We are not having the transcription factor or even the like
NGS,
somatostatin and such.
Because that would have opened doors for you to see once you have the failure of the first drug to go to a proper cyclical chemotherapy with what you call GFR, epidermal growth factor.
Thank you so much. Unfortunately, we are really hoping to see the patient at that time. Unfortunately, he didn't attend the clinic. You can shout, maybe, Adnan. Thank you so much. Yes, thank you so much. There's other
comment
here. Yes,
no, I have a question. Looking at the initial histopathology, which showed a very high K67 index, would staging at that point of time is important, staging, looking for secondaries in the brain or any other organ, and if it is important, what would be the best modality to look to stage this cancer?
Yes. Thank you so much for the question. Unfortunately, pituitary cancer is very rare, that we don't have really much experience. So even we won't see this, somebody will think this is an incidental meningioma. But because of the context of the case, we know that this is a pituitary cancer. We believe that if patient having developed any lesion that is really related and with aggressive feature, we consider to do like PET scan or the TET scan just to see if there is any other ectopic lesion. There is no standardized way of management. Even if we send the patient to oncology, no one is asking for any advanced images because this is already stage 4 cancer.
Thank you, Dr. Wal, for this interesting case. My question is there any need for biopsy from the leptomeningeal enhancement to confirm whether there is another secondary tumor that metastasized, or are you sure that this is the focus is related to the pituitary carcinoma?
Yes, thank you for this question. I think we base the diagnosis based on the clinical setting and the radiological. If there is really clinical dilemma and the patient is not aggressive features, yes, maybe you can go for an extensive diagnosis like a biopsy or looking for other related. But because from the beginning our patient showing really aggressive features, also some of the experts informed me that P53 is an suppressor gene, and whenever you give radiation, it might process the problem worse. So from the beginning, I reviewed some literature. They think temozolomide with radiation at the same time much be better for survival. But in our case, we couldn't do that initially.
Yes, regarding this co-secretion, because this is a huge tumor and actually is not showing any features of acromegaly.
Yes.
I have like some patients who is really smaller size and they have both prolactin and acromegaly, but this one, the behavior is a little bit different.
Yes.
Yeah.
Thank you. Maybe because of dominant of prolactinoma, this is one theory. Other theory, it's very rapid tumor that is not showing the acral changes. Because the patient, during his course, I didn't mention that, within 3 weeks, he have an imaging showing advanced and progressive tumor increase in size, within 3 weeks only. He presented to the emergency, and another 3 weeks, by CT, they proven that there is marginal increase in the size. That's why we think this is severely aggressive, that even the acral feature will not have the time to present.
Just two comments. First, after getting the histopathology report, did you do MRI spine? Usually with this aggressive feature, you will look for metastasis from the start.
Yes.
And the second question, though he had then elevated IGF-1 significantly, but also prolonged cabergoline can increase IGF-1, because his stain was showing only focal growth hormone stain.
Yes.
I don't know whether it is related to drug or truly elevated.
Yes, thank you so much for elaborating on this. The only thing that also OGGT was positive. That's why we think it's true, genuine secretion. But however, maybe it's not a dominant secretion, because even after surgery, after just small debulking, there is some regression before we start ectoriotype. So we think maybe they tickle it, or the burden of disease of the prolactin, it was higher than the mild secretion of acromegaly or growth hormone. I think they tried both, but if it's severe fibrosis, they couldn't remove anything except 20% or 10% even.
Think maybe I'll answer this in a different way. So you asked why a lot of questions. So now he's asking you as an MDT. So what would be your next step? So I think lost to follow-up end of 2021. But if he came to your clinic, what would you offer him? Repeat surgery by just raising hand. Would you repeat surgery for him? MDT? So you're MDT, you have to provide an answer for Dr. Wal this time. Would you suggest repeat surgery? No. Repeat radiotherapy? You did not.
No, the response, this is the image.
He had progression.
He had
Even
persistent disease and progress, unfortunately, despite the temozolomide.
I don't recall Sarah because he didn't come to me when after the chemo, but with the image we found in the system, maybe 3 to 6 months, but I'm not sure. And you want to test for MG, MT, or whatever? Not available. Okay. Treatment. Okay, so that's the next question that I want. Would you try immunotherapy here? Yes? Okay. Okay, so maybe immunotherapy could be tried here. Okay. What about pasireotide? There is a high IGF-1, high growth hormone. Would you consider it? Yes, no? No, not really. It's normalized after 3. I don't think we have answers to many of these questions. Unfortunately, it's very, very difficult and very challenging case. Thank you for presenting it, Dr. Thank you for the opportunity. Great case. Thank you very much. So now we move to the second case, and this time Dr. Adnan Ajmal is presenting to you another interesting case. We're moving now from pituitary cancer to something else. So let's see what's this case. شكرا دكتور وائل.
Thank you. So we'll quickly go through them. Tale of two cases, but we'll just present one if we don't have time. So this young guy, Somali gentleman, presents outside facility, 3 weeks of fatigue and polyuria. He gets diagnosed with new diabetes, he gets discharged. Then within a few weeks he comes back. Now he is bad hyperglycemia, hypertension, and severe hypokalemia. So this time he comes to Cleveland. So second assessment, we have very high suspicion for Cushing now. So these are some questions, more rhetorical, that we have an inpatient, very sick. What are our investigations of choice? We go with the first line, like the typical 3 testing regime, or we go with the second line investigation, high dose DST, DEX-CRH, CRH, AVP stimulation, or we go with the non-conventional approach, random ACTH cortisols, plus minus UFC, plus minus CRH, AVP stimulation. So these are the things we'll see what fits here. And then what to do with some other issues, DVT prophylaxis, antibiotic prophylaxis, osteoporosis treatment, antihypertensive of choice, and ICU needs. Because things are moving very fast here. He comes in very sick, and then we'll see that how a 1-week delay in decision making can cost him 6 months of care. So at this point, initial random ACTH was high at 54. PM cortisol was very high at 2,684. And then 1 milligram overnight DEX suppression showed that he failed it completely. UFC was, again, very elevated. Another random cortisol next day was high. He underwent 8 milligram high dose DEX suppression. He failed it. So at this point, the suspicion was that he had ectopic disease. He presents in a matter of 3-4 weeks. He failed this 8 milligram test. And then, so this was between, first 12 days, he goes through a lot of testing. He gets this bunch of levels. He gets the urine-free cortisol. He gets very high ACTH levels. And at this point, it's not a coordinated care. Let me say that. At this point, it's not a coordinated care. It means endocrinology is consulted, but they were like getting our opinion, taking time to implement that. But finally, they agreed to do a CD chest. And he had this upper lobe consolidation. And the concern was if he has a post-obstructive consolidation here and there is a mass behind it. And and then CD adrenal has bulky adrenals, definitely ACTH dependent disease. This much was clear by now. And then there was this question about paraganglioma, but then it was ruled out. But reference take 3 weeks to come back, so another problem here. So one thing was important, that the CT chest, we were at this point, were told that there is another CT chest at a different hospital. By the time, another few days for us to get that imaging, that was normal. So it looks like this was not the problem here. And this is reported in the literature, that cross-sectional can throw people off the track for diagnosis when you are trying to figure out what's the source. So, but then we did not agree with the findings on the cross-sectional that this is ectopic, and we went for the pituitary MRI, which was suggestive of a 9-millimeter lesion on the right side. But by this time, Ginny was already out of the bottle. He broke his 2 vertebrae while there in the hospital. He was very quickly diagnosed with multifocal cavitating ring-enhancing lesions, brain, and also to the eyes. And he had endogenous endophthalmitis. He has disseminated invasive aspergillosis. Now he gets very sick, and then he gets to the ICU. He was started off IV etomidate, and he underwent urgent transsphenoidal surgery. Though he had brain involvement, but we thought that that's the best we can offer him right away. And then all of a sudden, everything changed. His levels, he went into complete remission, but it took him 6 months of rehab before so this was just 1 week delay. So we thought, like, he took us 3 weeks he came to the hospital and got to the OR table. And again, there were many things here that threw us off. Cross-sectional imaging, his presentation, and all those. So, well, I'll skip this case and then go to, so I think at this point the question is, what would have been our diagnostic approach? Should we go with the first, where we go with the typical, or we go with the like second line testing, or we go with the atypical approach of very quick diagnosis and not wasting time on 8 milligram test, and maybe even UFC or CRH stimulation? Any thoughts? Which way we should have gone with this case?
Answer.
You chose 8 milligram, but though 8 milligram is another one which point towards ectopic, but there was no ectopic. He failed 8 milligram. So, so after this case, we did kind of lot of kind of thought about what should be the best approach. So this paper from France also came in the last year or two, shed some light on how we tackle with these cases who have this severe presentation. Then we don't have a lot of time. First we have to set up a team very quickly and move fast as soon as we have a very high index of suspicion. We kind of do symptomatic evaluation. We go through the checklist and etiology evaluation. So in this one, we look at what are potential complications we're dealing with. We started him on DVT, like DVT prophylaxis, hypertension with MR antagonist, insulin, PCP prophylaxis with Bactrim, manage his potassium, MR antagonist hopefully helps, and then issues with the steroid psychosis. We're taking care of all these things. So all these infectious disease and then hematology need to be on board very fast. We also need to be put in word with the surgeons about getting ready the surgery teams, because this will be a very high risk surgery when they have this degree of hypercortisolism. We also coordinate with the ICU teams because they need to be ready, with our pharmacists because of the etomidate protocol, because sometimes people are not familiar. Because the second case, which I didn't present, actually, we have learned the lesson with that. And the second case, we got him from the presentation to the OR in 12 days. And he did very good in overall outcomes. So, and then this kind of truncated approach. We don't do the first line testing. We don't do the second line testing. We do 2-3 random samples of cortisol and ACTH in the morning and evening, we do a UFC possibly. If we have time, we do the CRH stimulation. If CRH is not available, we do DDAVP stimulation. Now we have done one other case in Cleveland with DDAVP stimulation. And then we do a cross-sectional. And if we find that this is ACTH dependent, we start the therapy. In his case, it was etomidate. If the tumor is overt ectopic tumor, we go to resection. If it's an occult ectopic, we go to the MRI. So in our case, on the left side, we find the MRI. If it's 9 millimeter or a bigger tumor, we kind of move to surgery. This is the quick approach. We still can take 7 to 10 days, arrange all the multidisciplinary team and kind of do that. So this is just the IV etomidate protocol is available in the literature. It has to be done in the ICU. In this case, we did that to stabilize his condition. And these are kind of some of the therapies that can be considered in subacute cases, especially mitotane or cellular steroids to work pretty fast. So this is
Thank you very much. Thank you very much, Dr. Adnan. So floor is open for comments, questions. Dr. Lamki?
We should come up with a protocol, what the people in Birmingham did for the hyponatremia. Very common. I mean, people walk into the hospital and they die because of hyponatremia or hypokalemia. Now, I think we should learn from their lessons and try to mirror image if we can do something with regards to hypercorticolism.
I think there will be...
if we can. It's
yeah,
not
I
easy.
think across the GCC, we can kind of work on this protocol, which is already there, to kind of have a little file in place that what are the things, what are the boxes we have to check very quickly. Because the second case, when it came in, which the thing is, it's rare. The second case comes in 4 years later. But then we kind of were a little bit ready, and from his diagnosis, from his coming to our clinic, and we published at a few places, 13 days he was on the OR with everything ready, all the things taken care of with the testing. But outcome is very different. That young guy is back in England studying. This gentleman needed 6 months of rehab, only 1 week delay that caused him. So.
For this acute hypercortisolism, sorry, I missed it. Was there like manifestation of diabetes, exacerbation of hypertension, or more of everything? Yeah.
Hyperglycemia, hypertension, hypokalemia, DVT, fractures, disseminated infection. He has everything.
Would help him as like jumping to the treatment right away to save his life will be the best option for him in this case with this deleterious effect of the hypercortisolism in this case.
That's a very good question. So for the second case, just he has metastatic MTC with ectopic Cushing, the young guy, the one I didn't present. Now in his case, again, we quickly achieved the ectopic, we found the source in the thyroid, we took it out, he's doing very good. But for him, we have in the back of our mind that if he presents with recurrence of his metastatic MTC, we'll directly go to adrenalectomies. We'll not waste time on that. But in his case, we just found the tumor, he went into remission. So for him to get a recurrence is very low. For other case with the metastatic MTC is high. So I think, yes, bilateral adrenalectomies are an option when there is nothing else working.
Any more question? Last comment we'll take.
Adenoma. He had just a simple pituitary adenoma. So this was a thing that, another lesson that adenomas can sometimes present this aggressively. It's very rare, but they do. Because he just have a simple, and he's doing very good. He actually lost to follow-up. He's from Sharjah, he's living there. 2 years later, he called us. He's back in Somalia getting married. So he's doing great.
Thank you, Dr. Adnan. So we move to the last case. Thank you. Last case will be presented by Dr. Aisha. And this time also a different pathology. So you had exposure to pituitary cancer. And now second case was about severe Cushing disease. So let's see what's the third case.
Assalamu alaikum. Thank you for staying till the end. I'll try to be very quick. I'll present this case that I have seen in my clinic. Oh, this is a lady. Yeah. So this is Mrs. H, is 75 years old lady, had been followed up in our osteoporosis clinic since 2011 for management of her osteoporosis. She was receiving a cluster yearly, and she was following with one of my colleagues for that. During that time of follow-up, since 2011, she was always coming with her son fully covered, even she was covering her face, so she was not fully examined with every single visit. She was like an old lady on a wheelchair, kind of little bit withdrawn with her son. And one of our smart fellow decided when she heard her voice that she was having hoarseness in her voice to examine her. So they asked her to remove her cover, and they found that she had a classic feature of acromegaly. So regarding her history, she was diagnosed with diabetes, and it was not well controlled. She was on this medication, oral hypoglycemic agent, 3, hypertensive, and she was on a 3 agent and dyslipidemic. She had history of ischemic heart disease and history of multinodular goiter. Osteoporosis, she was receiving IV zoledronic acid. Regarding her social and quality of life, she lives with her helper alone, and she is wheelchair bound. She was sleepy according to her helper, she's like spend most of her day sleeping on the chair. Regarding physical examination, she was hypertensive. She had classic features of acromegaly in terms of the coarse facial features, spacing of the teeth, and she had, during visual field assessment in the clinic, she had bitemporal hemianopsia with decreased vision in the left eye. Also, she had large typical manifestation, large hands and feet, and she had significant goiter. The right lobe of the thyroid significantly enlarged, extending up to her jaw. So we decided to run and do quick screening test for acromegaly. Her IGF was significantly elevated, and her hemoglobin A1C was also elevated, 13.5. If you look at her hormonal profile to assess acromegaly associated hormonal disorders, we found she had central hypogonadism, central hypothyroidism, and her cortisol axis, adrenal axis was intact. So we did MRI, as you can see here. Anyway, you can see 1 by 1.5 centimeter pituitary adenoma. We did formal visual field assessment. It was negative, and she had ultrasound thyroid that showed bilateral thyroid nodules, really nodules suspicious, but her FNA both sides were benign. We did DEXA scan, and she had, as I said, osteoporosis, but no vertebral fracture. Her echo showed LVH with EF 35%. She had sleep study that showed significant severe obstructive sleep apnea. Colonoscopy, she refused it. So we decided to discuss the case with my team. This is a multidisciplinary team, pituitary team in my hospital. You can see here the second one on the left, Prof. Abdelrazak Al-Ajlan. He is a neurosurgeon in our hospital. The one at the end, Prof. Iyad Said, he is the radiation oncologist. And the two in the middle, ENT, helping with the endoscopic approach to transphenodal surgery. And actually, our team approved from United States by NABSA as the first multidisciplinary team in managing skull-base disorder and surgery. And we got this accreditation. I think the only center here. So we decided after discussing the case and comorbidities that she was not candidate for surgical procedure. So we decided to give her medical therapy and start octreotide 30 milligram monthly. And we deferred the radiation later on if needed. Regarding her comorbidity, osteoporosis, denosumab, we give her, plus the calcium, vitamin D, the usual. Her DM, so we started her MDI insulin regimen. Blood pressure medication, we adjusted it, and she was given CPAP at home for sleep apnea. During her regular visit to the clinic, so I noticed that her son was complaining of frequent hypoglycemia. So I tapered down her insulin over multiple visits till I stopped it because of recurrent hypoglycemia. And I kept her on glucophage 500 BID. And her blood pressure improved. She was only on one medication. And she was complaining of persistent headache at that time while she was on octreotide. So following her IGF-1, you can see here, IGF-1 was within normal limit, just with octreotide alone, and she was on thyroxine for central hypothyroidism. If you can see the timeline, she was diagnosed in 2017 with high IGF-1, and we started octreotide, and you can see significant drop in her IGF-1 in 2019 when she was started to have the hypoglycemia. So it was normal, and her level was stayed within the normal range. And then when it was persistently normal, so I decided to hold her octreotide at that time. And it continued to stay within normal range, despite having this up and down, but it was within normal range for her. So at that time, because of this presentation, I decided to do a MRI to correlate with the finding of normal IGF-1 and her symptoms of hypoglycemia and recurrent headache. So what do you think I was thinking of at that time? Yeah, apoplexy. She was having recurrent hypoglycemia, so probably she had apoplexy. So this is her MRI. So as you can see here, she had partial empty cilia with little bit residual tumor in her pituitary. Unfortunately, I don't have a pointer to point toward the findings, but you can see the CSF here filling the cilia turcica. So her hemoglobin A1C was 5.3, 5.2. Prolactin was mildly elevated. Do you expect that to happen in her case? Although she had no, almost very minimum tissue as a part of residual tissue of her previous tumor. Huh? Yeah, part of the empty cilia. So the commonest finding in patients with empty cilia, hyperprolactinemia. So why is that happening? The mechanism of hyperprolactinemia and empty cilia, and patients usually complaining of headache because of hyperprolactinemia related to empty cilia. Sometimes we do treat them with cabergoline to help with the headache. Huh? Yeah, intracellular pressure, and also the CSF pushing the stalk on one side causing high prolactin. So that was expected. So her AM cortisol, because I was thinking of adrenal insufficiency, as Dr. Raya mentioned, probably she had apoplexy, so her AM cortisol was normal. And her free T4 was okay on replacement. So we thought of pituitary apoplexy or infarction of the tumor itself causing normalization of her IGF-1 and her presentation of recurrent hypoglycemia. So that basically the tumor burned out at that time. So I went into the literature trying to find similar case of using octreotide as a primary treatment for patients with acromegaly, and that treatment causing empty cilia. And I found two cases. Unfortunately, the article was in Chinese language. So I found the abstract reporting the two patients treated primarily with octreotide and had partial empty cilia, but IGF-1 and growth hormone were persistently elevated and continued in treatment in those patients. I found this study using octreotide as a primary treatment in those patients, up to 9 years using octreotide in those patients. So they were about 67 patients with acromegaly due to macroadenoma. And in those patients, the thing that small group of patients, tumor disappeared in 3 patients, and 5 of patients developed empty cella using octreotide alone in those patients. So this is her latest MRI in 2021, showing partial empty cella and complete resolution of the pituitary adenoma. So the take-home message from that case, even though according to the guidelines, so primary treatment of any patient with acromegaly due to pituitary adenoma is to do transphenodal surgery. Although we are seeing good results in those few cases, so in selected patient, we can apply somatostatin analog as a primary therapy, and I mentioned it earlier, certain indication with comorbidities, like our patient, we can use somatostatin analog as a first-line therapy. As I said, you cannot generalize this conclusion in all patients with acromegaly. Certain patients, you can use somatostatin analog as primary therapy. And thank you.
Thank you very much. Thanks, Dr. Aisha. Very interesting case. Comments? Questions?
Do you think that the beginning by pituitary 30 milligram from the start, this is the induction, the cause of induction?
This is my, this is my explanation. Yeah. You can start with 20 milligram. 10 milligram is a very small dose. We start, it depends your individual your management. But usually a recommendation 20 milligram, not 10. 10 milligram is very small. 20 milligram and you can go up with the dose. I started with 20, but because of the sake of the time, I didn't give you the pattern of the dose escalation. We started with 20, and I titrated up her dose up to 30 milligram, and she was doing well with that, and IGF was well maintained. Even despite discontinuing her octreotide, her IGF-1 is still normal.
Thank you very much. Before we conclude this course, I'd like you to scan the QR code and mention 1 or 2 learning points that you have gained from this course. 1 or 2. This is the last activity that we will do, just to summarize and to learn from each other. So part of learning is not only from the presenter to the audience. We have a lot of people who are experts among the audience. So just share 1 or 2 learning points. So this is more of interprofessional education. So we learn from each other, peer learning. Okay. Not a word. Try to mention the whole sentence. Surgery for prolactinoma, I guess indications. Okay. How to recognize aggressive adenoma. What's the benefit of venipuncture and hyperprolactinemia? That's cannulated prolactin. It's one of the sessions that we had. Can we get more responses? Cannulated prolactin, so very helpful. Pituitary cancer and strange pituitary cases, challenging pituitary cases, yes. Again, cannulated prolactin dominating. Okay, congratulations, Yaraya, thus far. Okay. Always take opinion from colleagues with experience. So that's importance of MDT. Great. Okay, let's look at other entries. Benefits, we said about benefits. Osilidrostat, okay. Important of medical therapy and some of the adrenal specific agent to reduce cortisol, perhaps avoiding bilateral adrenalectomy, maybe in severe cases. Okay. MDR, I don't know what's MDR, maybe MDT. Okay. Anything else? Osilidrostat and Cushing. Is this a participation from the pharmacy industry or what? Okay, but the importance of medical therapy, as I again highlighted. Octreotide as primary therapy, usually for people not responding to surgery. Thank you very much. The purpose here is just engaging the learners, the audience, and learning from each other. And I'd like to thank the speakers, the moderators, the audience. Thank you for staying until almost 5 o'clock. And we thank our sponsors, Epson and Recordati. Without their support, we will not be able to do this course. Thank you very much for attending.